wait for some time and then plan for secondary.
So ideally, you should repair the corneal wound and clear the lens matter if you can remove it safely.
Yeah.
And do the IOL at a secondary sitting.
Okay. So
even
in
for
those
this case, it would have been ideal to put the lens later, but the patient didn't want one more surgery.
Okay.
And I took a call that it should be okay to do that,
Okay.
and it turned out okay.
Okay. Thank you.
Rishi, one question.
Yes, sir.
Supposing you want to delay the surgery,
Yes, sir.
and you see vitreous in the AC,
Yeah.
is there technically more chance that because it's in the AC and it's a traumatic cataract, is there more chance of it getting infected and leading to endophthalmitis?
Yes, once the capsule has been breached, there is definitely a risk of endophthalmitis, especially if it's a fresh wound. Since it's been a week and the eye has been quiet, that's the reason I decided to go ahead.
So just two corrections I'd like to make. One is that no, there is no increased chance of endophthalmitis if primarily there's no inoculation. It's the same chance. Second is that definitely I would wait for a couple of weeks, manage the glaucoma medically if I can, because the vitreous would shrink. I would have to do less vitrectomy. The fluffy cortex, most of it would have got absorbed. And I would use steroids if I think that there's a lot of inflammation.
Sure.
I would always put the lens secondary later because you have control, but I understand your particular case. So it's a case-to-case basis decision. And the last point on Suparna is that we shouldn't go home with the message that to remove the cataract along with the corneal tear, try your best not to do it. Only if you have flocculent lens matter in the anterior capsule or the lens is subluxated coming in the anterior capsule, those are the only indications for removal. You'll always have a better result if you do it staged. So those are my tips. Sorry to take up extra time on that. Thanks, Rishi, but you've brought together very good, and for a cornea session, this would be an all-day discussion. Yeah. But thanks for bringing this topic up. Excellent topic. Thank you. We move on to our next speaker. As you can see, we have a lot of tough surgeons today, like Rishi, and Vivek is following suit. Dr. Vivek is a cataract refractive faculty from LVP, and he is bailing us out of tricky situations. So your time starts now.
Yeah. Thank you, Dr. Somshila. What I'm going to talk about, the tricky situation is a PCR, something that we encounter.
Dr. Hema?
Yeah, something that we encounter very frequently. And the next 5-6 minutes, I'll be just discussing very basic principle about management of a PCR. So what do we do once we notice a central rent like this? The first thing that we have to do is freeze. We have to freeze, stay inside the eye, and do not pull out. Do not pull out your phaco probe. So as you can see in this video, the surgeon is doing phacoemulsification. The trenching is going on, and you can start seeing one very bright glow towards the end of the tunnel. Suddenly, the red glow increases. Surgeon realizes there's something wrong and pulls out the phaco probe. What exactly happens here? The moment you pull out, there's destabilization of the chamber, increase in the rupture, and there's a subsequent drop. So always freeze, inject a dispersive viscoelastic, and then come out. So this is the right way. Whenever you notice a PCR, whatever stage that may be, always go inside, inject a dispersive viscoelastic, and then come out. When you have a central PCR like this, or any PCR for that matter, always, if you're injecting a 3-piece lens, always increase the size of incision, and then insert your 3-piece lenses. This can be in the sulcus or in the bag. That will come, and we'll discuss later. In this video, as you can see, the incision was not big enough for the IOL insertion, and the PCR increased, leading to destabilizing, because there was a force while injecting the lens, the PCR increased, and there was a vitreous prolapse noted. The third important point is do not sweep your main tunnel. Whenever you notice a vitreous, do not use a swab or a Wexel sponge to check for the vitreous. So as you can see, the surgeon is trying to sweep the tunnel, and there's a movement which is happening inside the eye. Now this is happening because there's a lot of vitreous strands in the main wound, and that results in traction and further breaks. So this is something that needs to be avoided. The next video that I'm going to play is not very well centered, but it has 3 important messages. One, never use a main wound, again, for the reason that using a main wound can destabilize your chamber, increase the rupture. And second, ensure that your irrigation is away from the vitreous. If the irrigation is very close to the vitreous, it just hydrates the vitreous, and that further leads to more vitreous coming and blocking your side ports. The third one is a dialing movement of the vitreous should be from the port towards the central part of the eye. Let's see this video. There's definitely some vitreous at the main wound that the surgeon is trying to check, is not able to clear the vitreous, and that is why surgeon decides to go outside in movement to draw the vitreous inside the eye and further take care of the vitrectomy. However, what happens is there is collapse of the globe. This is something that needs to be avoided, otherwise it increases the size of the rent. Subsequently, the surgeon tries to do a vitrectomy from the main tunnel. So this is again should be avoided because vitrectomy, if your tip is not visible, do not proceed. And in the tunnel, if you have a vitreous, you're not able to see anything. Now this third step again is important. You can see how inside is your irrigation. So I'll just go back to that part where irrigation is happening. Irrigation should not be towards the center because, as I mentioned earlier, it will again hydrate the vitreous, and that will lead to more and more of vitreous prolapse from the main tunnel. So this is the outside-in movement that we were discussing about. You can see the irrigation is too inside. Secondly, the cutter is facing downwards. Always ensure that the cutter is either facing sideways or facing upwards to ensure adequate vitrectomy. Always suture your wound. This wound suturing is important because of two reasons. One is it ensures a very tight sealing. Second is these complicated eyes, usually we tend to keep a lot of viscoelastic inside, and the pressures next day might be quite high. That might result into further vitreous prolapse. Dr. Rishi already mentioned about keeping your settings low. Reduce your flow, reduce your vacuum, reduce your bottle height, and when you're cutting anything, just increase the cut rate. When you're cutting your cortex or taking care of small nuclear fragments, the cut rate can be low. So this is your another video where cortical wash is being taken care with the cutter itself. This is done under the setting of eye cut. While doing this, ensure that the flow is low and ensure that the vitreous is taken care of. At the earliest sign, whenever you see the vitreous coming towards your vitrector, you can always go back to cut eye mode and take care of the vitreous first and then proceed with the cortical wash. Most important, to identify the vitreous, use triamcinolone. Triamcinolone, the usual vial is about 40 milligram per ml and 4 milligram per ml, I'm sorry for that. And just ensure that you use diluted triamcinolone to stain the vitreous. The diluted triamcinolone goes and stains the collagen fibrils there. It just gets spread between the collagen fibrils. The another tip is to stay in the center and do not chase all the vitreous strands. If you do not stay in the center, that is what is going to happen with you. You might just eat up the iris somewhere, especially when the iris is very, very floppy. About the choice of IOL, if you have a very well-centered rent like this, you can always go back and insert IOL in the bag. So as you can see, the rent is quite circular. And if the rent, especially in PPC, when you have sometimes a spindle-shaped rent, there can be a circular rent as well. So when you have a spindle-shaped rent, the haptics can be aligned along the perpendicular to the long axis of the tear. When you have a rent, which is when you have a drop or epinuclear fragment drop, you can always go back and insert a lens in the sulcus. So here you can see there's a drop, and you can see the lens fragment in the antivitreous. When do you place a lens and send these patients to your retina colleagues? When the grade of cataract is NS2 or lesser, usually you can go ahead, safely place the lens in the sulcus and take a suture on the main wound, and you can just refer the patients to the retina colleagues. But when the lens is very hard, do not proceed and place the lens. Let the retina colleagues take over. So just to reiterate, stop, but do not pull the phaco probe. Use dispersive viscoelastic to coat the PCR. Always follow the outside-in movement to drag the vitreous out from the main wound. Use triamcinolone to aid vitrectomy. Reduce your phaco settings. Avoid main wound, and suture your wound. Thank you.
Thank you, Vivek, for an excellent presentation. The discussants are Dr. Suparna and Dr. Hima. Request a question for comment.
So,
May I
Dr.
request
Vivek,
Akhil
it was
to
a
sit.
very good presentation. I actually what you said is we should just freeze. So we should just keep the probe inside and not try to come out. Like it's a common tendency that we try to pull the probe out, but don't have a mental freeze. So usually when we see a PC reno, that's the first thing which happens. So important is to maintain your calm, but freeze the probe inside, don't come out. So that is one important tip he gave. Then the other things is all the parameters should come down. As Dr. Vivek has rightly pointed out, except for a high cut rate of vitrectomy, all parameters should come down. And Dr. Vivek, in the case in which you had a fragment or a piece drop inside, so would you like to place an IOL? I feel if you have a retina support in OT, patient can be directly taken up in case you have. Or I don't know, means retina people would be correct to tell like, is it better to put IOL in such cases? Or just do a good vitrectomy, close the case and refer to a retinal surgeon. So I don't know, retina people may be better to answer. Dr. Somshila,
Both options are good. And as Vivek pointed out, he said that if it's a hard cataract where they have to deliver the cataract anteriorly, then don't put the lens. But if otherwise it's cortex or nuclear fragments.
which can be eaten up with the...
Right. And it's often we can't get them to do it on the same day because of the high volume practice. So you have to refer it for another day.
Okay.
So this is a good way to go. But you have to have the judgment. If you're in doubt, don't place the lens.
Okay. Thank you.
It was a very good presentation. I think this is a dreadful complication every anterior segment surgeon would find. I think you have covered most of it, but recognizing early PC rent, that is very important, like pupillary snap sign, or sudden deepening of the AC, or pupil distortion, and PC rent can occur at any stage of the surgery. For example, I had a rent even after putting the IOL in the sulcus. So it's very important to realize early and manage, and staining of the vitreous with triamcinolone, I think it should be done, and suturing of the wound is very important before going for any surgery. And as Dr. Suparna rightly said, I think the cortex which has gone into the vitreous is quite big. I think it should have been left to, I don't know, but I think you have very good retinal surgeons who can take over and manage that.
Thank you, Dr. Hima. Thank you, Dr. Suparna. Thanks, Vivek. We move on to the second last presentation, Dr. Akhil Bevara. He's going to talk about how we only live once, so we might as well as make it a good life.
So good morning, everyone. So this is an image that sends a shiver down the spine for any surgeon taking this case up for cataract surgery, a posterior polar cataract. So what is a posterior polar cataract? It's usually congenital cataract that is inherited in autosomal dominant pattern. Incidence is around 3 to 5 per 1,000 patients, associated with PC defects in 20% of the cases, and a high chance of intraoperative PC rent, almost up to 40% in some studies. So let's jump straight in for some tips and tricks for performing cataract surgery in these cases. So after making good self-sealing incisions, a dispersive viscoelastic is injected first, and then a cohesive viscoelastic is injected to form the anterior chamber. Now, the caveat here is never inject too much viscoelastic, because this can increase the intraocular pressure and can lead to a PC rent there itself. So a capsulorhexis usually should be a little larger in size and preferably an oval shape. So this is a video of capsulorhexis being performed in such a case. So it's initiated first with a cystitome and then continued with a retractor forceps. An oval-shaped capsulorhexis being made. The advantage here is that if suppose during hydro procedures there is an increase in the intraocular pressure, the nucleus still has place to prolapse out into the AC instead of falling through a defect in the PC. So moving on to the hydro procedures, it's very important to avoid hydro dissection in these cases initially. Hydro delineation needs to be done, and an inside-out delineation can be done in which a small trench is made in the center, and then the hydro delineation can be done through the trench. And for phaco-dynamics, a slow motion phaco-emulsification is preferred with low aspiration flow rate, low energy, and low vacuum. So let's look at a surgery being done in such a case after a good capsular excess and hydrodelineation. Initially, the soft nucleus is attempted to be removed with irrigation aspiration, but it was not possible. So viscoelastic is injected, and with the phaco probe with slow motion phacoemulsification, the central nucleus is removed. The epinucleus is trying to be aspirated, but obviously it has good attachments as we did not perform hydro dissection. So a visco dissection of the epinucleus is being done here. Instead of visco dissection, even hydro dissection can be done, but at this stage, not when the nucleus is still inside. Now the epinucleus is being aspirated with the epinucleus mode in the phaco machine. So it's very careful to gently remove the epinucleus. Now the cortical aspiration is being done. It's very important not to cause too much traction while removing the cortex. The cortex should be removed first all around in the periphery, leaving the central PC plaque that is present, as you can see, intact. Once all the cortex is removed, then gently the PC plaque is being elevated to release its adhesions from the posterior capsule. However, it is not always possible to prevent a PC rent. As you can see here, there's a small PCR that can be observed while removing this. So the PC plaque is then aspirated. And as the rent was small and in the center, and there was no vitreous prolapse, so the viscoelastic is being injected, making sure not to collapse the AC. The section was extended, and a 3-piece IOL was attempted to be placed. But as we were trying to implant the IOL, we noticed that the rent has extended and a vitreous prolapse was noted. So then we did a thorough anterior vitrectomy with a vitrectomy cutter with a high cut rate and cleared all the vitreous from the anterior chamber. And now 3-piece IOL is being implanted into the sulcus. Because if we attempt to put it in the bag here, it is possible that the rent may extend even more. So then we noticed another vitreous strand had prolapsed into the AC, so vitrectomy is being done again to clear all the vitreous from the AC, and the wounds are hydrated. So the important tips for nucleus management: avoid rotating the nucleus in these cases, avoid aggressive nuclear cracking techniques, and avoid putting any pressure on the capsular bag. For epinucleus, strip off the epinucleus sheet first in the periphery and then move to the central part. A hydrodissection or viscodissection can be done to release the adhesions of the epinucleus. And during cortex removal, as least traction as possible should be given. Tangential movements are preferred while removing the cortex, and strictly avoid PC polishing. So I'll show you why in another video. So the tips: if a posterior capsular rupture occurs in these cases, inject a dispersive viscoelastic to plug the PCR. If the vitreous face is intact, we can first aspirate the cortical matter. Then if there is a linear PCR, then it's better to convert it into a circular posterior, we can perform a posterior capsular excess to convert it into a circular fashion, but this should be smaller than your anterior capsular excess. And if the vitreous face is disturbed, a thorough anterior vitrectomy should be done. So this is another video of a cataract surgery being done in such a case. The nucleus has been removed. So gently the epinucleus and the cortex are being aspirated. So in this case, even though there is no PCR, as you can see, there is a fibrosis of the PC centrally and a small PC plaque. So here, in such a case, it's better to avoid doing any kind of PC polishing because the PC will be fairly fragile in these cases, and you can easily cause a rent if you go ahead and try to polish the PC. So it's better to leave it alone, inject a viscoelastic, and a hydrophobic IOL, foldable IOL is being placed in the bag in this case. So post-surgery, we should explain the patient that you will need a yak capsulotomy later on, and that can be done maybe 2 to 3 months after the surgery once the fibrosis has occurred. So that's all I have for today.
Thank you, Akil. I'll request Dr. Hima and Dr. Rajshekar to give their comments.
It was good presentation. One thing is, while dealing with the posterior polar cataracts, I think it's always important to maintain the anterior chamber depth. So whenever you are coming out, make sure that you inject visco with the other hand and then maintain the AC at each and every step of your surgery. And I think the rest covered. Yeah, that's it.
Dr. Rajshekhar,
Yeah.
your comments, please.
So not only this post-polar cataract, but any case with central post-capsular opacification, so try to maintain the posterior capsule intact throughout the surgery, put a lens, complete the case, and if the patient complains of any visual disturbances, you can always do a yak capsulotomy afterwards. So it's always good to opt for a yak capsulotomy than a vitrectomy. Because vitrectomy, it's a direct opening into the posterior segment, and it has more complication compared to yak capsulotomy. Thank you.
Dr. Akil, what's your opinion about not removing the cortex totally, just drawing it towards the center and trying to flip it towards the end, so that instead of peeling it totally, where you have more chance of a PC rent, and then having to tackle that also, so that you, even if in case you get a PC rent, it will be towards the absolute end of the surgery.
Yes, I think that's very important, sir, that we should never try to remove the cortex completely. So in the case that I showed, the cortex was still not attached to the PC plaque. But if we notice that while removing the cortex, the PC plaque is also getting elevated, it's better to stop there, release the cortex all around, and take it off in a bulk at the end. If a PC rent occurs at that point, then we can manage it better. But otherwise, if a PC rent occurs initially, then we are in a soup. So
Akhil, that was a nice presentation. I think it's very difficult to predict which case will create problems, which case will, sometimes we'll prepare too much and then will come out easily. Sometimes we don't predict and then end up in problems. I think what I noticed is the modern IOL Master 700 with SSOCT based the optical biometers, we can look into those scans and then fairly predict whether it is in the capsule or if the capsule there is a breakage.
yes,
We have done one study where we noticed we can predict these cases and then prepare accordingly.
yes, sir. Very true, sir. Yes.
Dr. Rajlingam and
More
also...
addition is your excellent presentations.
Thank you.
And in the first video that after the cataract removal and you found a small posterior capsular opening.
Yes.
So if you have an actually very good vitrectomy with you, so you can go and do anti-vitrectomy through the hole where you find it. So that whenever you are inserting your IOL, no, it will not extend. So there won't be any pressure from the posterior segment. So it will not be enlarged. That is one technique we have to follow.
Yes, sir. That's an excellent point.
Yeah, whenever there's a PCR, you're talking about injecting a dispersive. Dispersive is to be avoided. I would recommend to go with a cohesive. And okay, after you have a simple circular PCR, you are going to implant the IOL. Please don't inflate it too much. So the moment you start pushing the IOL, that will again cause pressure and extend the PCR. So insufflate only so much, it just forms the little bit of AC and opens up the anterior and posterior capsule, and then deliver the lens delicately, and be careful that you do extend the incision and deliver it. Don't do too much of pressures.
Yes.
So that's very important.
Yes.
So in his
Thank you.
defense, all the videos are not his, compilation of videos, but your point is excellent. Thank you. I think before the organizers throw us out, we'll go to the last presentation. Shalini is a tough girl. Shalini, tough timing also for you. Last girl in the show.
So, good morning everyone. So, I'll be dealing with runway rexes. So, this is Vogt who introduced an opening in the anterior capsule and saved our life. But he gave the concept of creating the opening in the anterior capsule with the toothed forceps. Hence, it was associated with more number of complications with that opening extending up to the equator and sometimes till the posterior capsule. Then Gimbel and Newhan saved our lives with the concept of continuous capsular rexis, which was which contained more strength. But still, in some of the cases, we come across a lot of complications, especially an intumescent white cataract, which scares us. The problems associated with continuous rhexis in an intumescent cataract is the poor visibility of the reflex, fragile capsule, and the raised intralenticular pressure. In the modern era of phacoemulsification, when cataract surgery is rapidly evolving, mature white cataract remains still a challenging entity for experienced surgeons. Hence, attaining a continuous curvilinear capsular rhexis is considered to be the limiting step, particularly for the intumescent type. So I will be going through a series of videos. Initially, I'll be discussing what are all the problems which can happen if you're not careful about making your rhexis in an intumescent white cataract, and how can you deal with those problems if you come across them. So when we see a white cataract, we are always tempted to make a larger rhexis, and this is what happens if you go too much to the periphery. It has a tendency to extend, and then it might become very difficult to salvage, because as you can see that the surgeon is still continuing with the rhexis, and the rhexis is continuously extending on the other side, and now it has totally gone out of his hands. Another problem, if you make too small a rhexis, then that itself can be difficult during the surgery itself to continue with the phacoemulsification, and later on just the capsular contraction can cause hyperopic shift. So what do we do? So there are various ways of dealing in such situation. Initially, when mostly SICS was practiced, in those days, if there was an extension, as you can see in this video, a continuous rhexis, when it extends, can be converted into a can opener. This can be practiced in case of small incision cataract surgery. But on the other hand, if you aim to do a phacoemulsification and place a foldable IOL in the bag, as you can see, this was an intumescent cataract where the surgeon gave an initial nick and then continued to extend the nick in a linear fashion towards the periphery. And this is something we are always scared of, the Argentinian flag sign. So when you come across such a situation, it can be still salvaged at this stage. You can see that the surgeon is making a small nick, and then with the help of forceps is trying to complete the rhexis on the either side. So this can be done when you have an Argentinian flag sign, but this has to be done very carefully, and the nick has to be given making sure that that itself does not extend to the periphery. Coming to our next video. In this video, you can see that the surgeon has very carefully given a small nick and now extended the rhexis to the periphery and will now use a forceps to complete the rhexis. When you are using capsular forceps to complete your rhexis, the most important point to keep in mind is to pinch the capsule close to the flap and grasp and re-grasp at each clock hour, because that itself will maintain the direction of your force on the capsule. Otherwise, that itself could lead to extension of your rhexis again. And as you can see that the surgeon at every clock hour is grasping and re-grasping the capsule, hence is very comfortably able to complete the capsular rhexis. So basically, in an intumescent cataract or in a traumatic cataract where you feel that the intralenticular pressure is high and the lens matter is bulging out, you have to be careful that do not give your nick very large. You have to create a central cruciate opening. Try to aspirate some amount of lens matter which is loose outside, reduce the intralenticular pressure. Then with the help of your cystitome or with the capsular forceps, you can create an adequate sized rhexis and then complete your phacoemulsification. Thank you.
Thank you, Shalini. I think you showed us a lot of good tips in tackling the anterior capsule and the rectification for these. Because we are way over time, I think we'll end the session here. And I would like to thank all the speakers and panelists who were here throughout the session and contributed with their comments as well as with the wonderful presentations by all the speakers for this session. So thank you very much. And of course, I'm very thankful to TOS and to the scientific committee for giving me and giving us this opportunity to host this session.
So we'll move forward for the next program. The P. Shivareddy oration. I request our President, Dr. Ashish Bansal, Dr. Badrinarayana, and Dr. Rishi, please come over the dais. Sir, बैठिए. Text. So I request who is this? Dr. Ashish Bansal, please introduction to the Prema Padmanabhan. Where is Dr. Badrinarayana, sir?
The oration which is coming up is the P. Shivareddy oration, and we have none other than Dr. Prema Padmanabhan from Chennai, Shankanitrale. Dr. Shivareddy was one of the doyens of ophthalmology in Telangana and was the superintendent of Sarojini Devi Eye Institute. And I request our President, Dr. Ashish K. Bansal, to introduce the person who's going to be delivering the oration today, Dr. Prema Padmanabhan.
Well, good morning, friends. So it is my august duty and an absolute honor and pleasure all the same to introduce the awardee of the prestigious P. Shivareddy oration, that is Dr. Prema Padmanabhan. Well, I have had the privilege of knowing Dr. Padmanabhan for the past 30 to 35 years. And the first time I met her was way back, probably somewhere early 90s, when I was a fellow or a young consultant at L.V. Prasad Eye Institute, when Dr. Padmanabhan came there for a guest lecture. On meeting her and listening to her, the first thing that struck me, like everybody else, was her simplicity, her elegance, her poise, and her oratory. She is an exceptionally gifted speaker, and as you'll notice shortly, that poetry flows out of her mouth when she speaks. She is a very well-respected teacher, and her students adore her and idolize her. But mind you, don't be misled by her rather frail outer appearance. Behind that soft demeanor, she hides a very resolute and a very strict disposition. And I learn from her students and her colleagues that she's a very hard taskmaster and is very a perfectionist. Dr. Padmanabhan did her undergraduation and post-graduation from Maulana Azad Medical College way back in 1978, and then did her fellowship in vitreous retina, I'm surprised to know, from Medical Research Foundation, where she's at presently working as a medical director and a distinguished senior consultant in Chennai. The list of distinctions, achievements, and honors of Dr. Padmanabhan run very deep. And just to name a few, she was recipient of the Rustam Ranji oration by APOS in 1998. In the same year, she won Dr. Jones oration by International Women Association. Then she won the Tibrewala oration in 2005 on corneal transplantation and eye banking by L.V. Prasad Eye Institute. In 2018, she was awarded the first Pellicaris oration, among many others. She has been recipient of the Best Paper Award at different international fora, to name a few: the World Cornea Congress in 2005 in Washington, Asia RO 2013, and U Cornea Symposium in Spain in 2015. As recently as 2022, she was awarded an Award of Excellence by ISCRS, recognizing her distinguished achievements in the field of cornea. The list goes on, so I must stop here, and I present to you Dr. Prema Padmanabhan, who will be delivering her P. Shiva Reddy Oration 2023. Madam Prema Padmanabhan, please.
I request Dr. Prema Padmanabhan, please come over the dais. Dr. Rita, please associate. Yeah, please come. Okay. Amma, slides.
Thank you, Ashish, for those very kind words. I thank all the organizers, all the office bearers of Toscon for this great honor. To give a talk that commemorates one of the renowned ophthalmologists of yesteryears, Dr. Shiva Reddy, is a great privilege. Dr. Shiva Reddy was the face of Sarojini Devi Eye Hospital for decades. I'm sure there are thousands and thousands who have been trained by him. Being the very first to start an eye bank at a time when corneal transplantation itself was in its infancy is no small achievement. And he would be a proud man to know how his initiative has been given shape and a nationwide movement by another renowned ophthalmologist, also from Telangana, Dr. G.N. Rao. So I think corneal surgeons from all across the country and corneal patients from even beyond have a lot to be grateful for to the state of Telangana. I have chosen a topic which has always intrigued me. Keratoconus, like beauty, lies in the eye of the beholder. What you see in it and what you make of it depends on how you look at it. Without doubt, it is the most overtly biomechanical disease in all of ophthalmology. And so it makes abundant sense to discuss it in its own dialect. So I take this opportunity to hold the prism of biomechanics against it and breeze through the kaleidoscopic array of applications and implications that it throws up. The cornea is a tissue where this structure-function relationship is strong, intimate, and very evident. The stroma, which occupies about 90% of the thickness of the cornea, consists of collagen bundles, lamellae, which are embedded in a ground substance. It is the architecture of this stroma which determines its biomechanical behavior. And this differs from anterior to posterior, from center to periphery. In the anterior part, the lamellae are densely interwoven and randomly placed. Posteriorly, they are more sparse, but they are more organized in an orthogonal shape in the center and a circumferential shape in the periphery. Apart from this, there are meridional fibers which extend and connect the cardinal points, forming cords that go across the periphery of the cornea. Apart from the collagen, there is elastin in the posterior peripheral part of the cornea. Now, each of these confers specific properties to the cornea. The Collagen is what gives it tensile strength. The ground substance gives it viscoelasticity. The anterior fibers need to have a shear strength to withstand the shear forces. The elasticity is higher in the meridional direction in the center and in a circumferential direction in the periphery. The elastin retains the corneal shape in spite of microfluctuations in intraocular pressure. So what do all of these properties add up to? Corneal biomechanics is a simple term for complex properties and confusing terminologies. But in the context of ocular tissue, most often we only speak of elasticity, although with specific reference to the cornea, it comes spiced with a little bit of viscous elements. The elasticity itself depends on the manner in which the shear is applied and the strength is measured. And taken together, they are non-linear in nature, depth-dependent, anisotropic, and they have a bidirectional relationship with intraocular pressure. So you can imagine that there is no one word that describes it, there is no one unit of measure, and there is no one device that can compositely encapture all these properties. So when the corneal ultrastructure is so complex, and the biomechanics even more so, it is this complexity which actually lends itself most ideally to finite element analysis. And this has become a hot topic for research in recent years, where a number of mathematical models have been created to try and answer clinical questions. And this includes the biomechanical behavior of the cornea and the optical performance of a keratoconic eye. What is its response to intraocular pressure? How does collagen cross-linking affect it? And so on. One such study with the finite element work has introduced a new biomechanical index known as the stress-strain index. The two important characteristics of this index is one, that it is not influenced by the corneal geometry or by intraocular pressure, and second, it is directly translatable into a known biomechanical property called the tangent modulus, which is close to the Young's modulus of elasticity. The same authors have gone one step further to create a differential map of the stress-strain index, and this is known as the SSI map, much like the tomography map, which gives you spatial differences in curvature and thickness. The SSI map gives us a spatial differences in tissue stiffness of the cornea across its diameter. And this promises to be a very useful tool to give us newer insights into this disease. The pathogenesis of keratoconus is known to be multifactorial, but whether individually or together, these triggers act. The final common pathway is believed to be biomechanical a breakdown. And this is a schematic that attempts to show the likely sequence of events as the disease evolves. If
Pointer, ma'am.
Yeah.
Pointer.
Okay, there. Thank you. So, it's okay. No, it doesn't. It's okay. In B, you would see that initially the breakdown of the stromal crosslinks cause a disruption of the posterior lamellae. And that allows the intraocular pressure to give the posterior curvature a little nudge, which is what you see as the posterior elevation as one of the first points of keratoconus. As it evolves further and goes, thanks Rishi. As it evolves further and goes to the mid-stromal level, the anterior lamellae start to take the brunt of the stress, and then that's when you start to see the anterior curvature elevation and the compensatory thinning of the epithelium. When the disease advances still further, there is a complete breakdown. There are breaks in the Bowman's layer. You'll see a compensatory thickening now of the epithelium and a further increase in the posterior elevation. This is purely from a mechanical point of view. One of the biggest risk factors for keratoconus has been always noted to be the eye rubbing. Now, eye rubbing affects the cornea in multiple ways, but I will only be concentrating on the biomechanical aspect, although the biological reaction to the biochemical changes that occur in the allergies that accompany and often provoke the eye rubbing are no less important. When there is an indentation of the cornea on the anterior surface, there is a relaxation of that stress on the anterior lamellae, but this stress is transferred to the posterior lamellae, which are now stretched as the cornea indents towards the anterior chamber. And this force is much higher when a knuckle is used to rub the eye as compared to the finger. The compressive forces of the anterior surface are transferred on its surroundings to the anterior part of the hump that forms surrounding it in what's called a hoop stress, which acts circumferentially. Apart from this, there are shear forces that act when the eye is rubbed, when one layer exerts a shearing action against the other. And when all of this is done repeatedly, there is an element of fatigue. And together, all of these cause the biomechanical breakdown. So all this suggests that biomechanical changes precede the topographic or the shape changes that occur in keratoconus, and that is important when we're looking to trying to diagnose this condition at an earlier stage. Any condition, especially one which affects young adolescents and is known to be progressive and is visually debilitating, early diagnosis, being the early bird, is the key. It's hard to imagine now that at one time keratoconus was a slit lamp diagnosis. The power of computational video keratography and the ability to image the posterior cornea and the corneal thickness, giving us a three-dimensional view of the cornea, allowed us a much earlier entry in the diagnosis. Even more subtle changes are seen when we study the aberrations, the wavefront aberrations that these eyes produce. But all of these, if you notice, look at only the secondary effects of keratoconus and not at its biomechanical cause. It was only in the last 2 decades when we have devices that can image the dynamic corneal response to a stress that we are able to make some interpretations of biomechanical behavior. Based on these, some of the more commonly used or popularly applied indices for diagnosis are the CBI and the TBI, and the CBI LVC for early detection of post-refractive surgery ectasias. Our own study also showed that the TBI performed better than any other parameter to differentiate subclinical keratoconus, that is, even before topographic or even tomographic changes are seen. So it's interesting that as research allows us to script the likely sequence into a neat storyline of genesis of the disease, technology side by side allows us to get earlier and an earlier peek into the genesis, so we are able to diagnose it at an earlier and yet earlier stage. Hopefully, in the not too far from now, we would be looking at identifying biomarkers even before they so much as create a footprint on the cornea. Grading the severity of a disease becomes relevant when we have more options for treatment. At a time when only contact lenses and corneal transplantations were the only options that we had for these patients, it was enough to use the Amsler, Crew mesh, or the classifications. Today, we need more granular details, especially about the cone. And that is what the ABCD has given us. But even that ignores the biomechanical aspect of it. And that is why the E stage, the E factor, was introduced in the hope of making it a more composite classification system. Very recently, the Dresden Keratoconus Index was introduced. What's interesting about this is that it is a standalone biomechanical device, or rather method, of grading keratoconus without even requiring any tomographic input. So those of you who are more actively involved with keratoconus would recognize Dresden as one of the holy cities of keratoconus. Based on machine learning, two mathematical models were created, of which the random forest model showed a fairly high accuracy in being able to classify a keratoconus as mild, moderate, or severe, based entirely on biomechanics. There is no consensus on how progression of keratoconus is defined, how it is described, measured, or even tracked. There are many candidate parameters for this, but each has its fallacies and limitations. We tried, knowing that progression of keratoconus is basically a biomechanical phenomenon, we tried to look to see if any of the biomechanical indices would allow us to track progression. And while some of them did show a statistically significant change in progression, notice the high standard deviation in all of them, which makes it quite an unimpressive parameter or set of parameters to foresee or to predict a progression in keratoconus. So since the SSI maps now give us a more spatial information about stiffness, we thought we would look at whether the SSI map would be able to pick up the earliest stage of progression even before shape changes. So here was a child who came to us 10 months after his first visit, where the change in the Kmax was negligible. The change in the pachymetry was borderline, but remember, we need to also take into account the epithelial changes. And the change in the global SSI was almost nothing to speak of. But when we ran this through the SSI maps, we distinctly found a change in the area of the cone. So the area of the cone had indeed lost its stiffness, making this the earliest recognition of a progression even before there were changes in tomography. And this is actually in line with what was found by the second harmonic generation and beyond microscopy, which tells us that most of the changes, the pathology lies in the cone and progression starts in the cone. How does all this affect treatment? Stated very simply, our goals of treatment are to improve the quality of vision and to retain that quality of vision for a length of time. To improve quality of vision, we need to change the shape of the cornea. That is, restore the curvature and asphericity to more physiological levels, and to reduce the asymmetry and the irregularity that characterize this condition. There are, to ensure stability, we need to address the biomechanical aspect of it. Currently, there are many options in treatment, and without doubt, the collagen cross-linking has been a big game changer. Although this only changes the biomechanics of the cornea, it does not address the refractive element, for which many clinicians have tried to combine cross-linking with other procedures as adjuncts to improve vision, collectively called CXL+. Just a word of warning about, and a note of caution, however, about CXL+. In trying to kill two birds with the same stone, we may be jeopardizing the corneal structure. Here are two eyes, almost mirror images of each other. One undergoes a cross-linking alone, the other undergoes a topo-guided treatment along with cross-linking. Now, a topo-guided treatment, a topo-guided ablation involves a very controlled ablation of the steeper part to try and flatten the steeper part of the cornea, and a peripheral crescent of ablation to steepen the flatter part of the cornea. And this is meant to reduce the asymmetry of this, or the topographic asymmetry. 1 year later, the corneas are absolutely stable, and notice that the eye that has undergone the TCAT plus cross-linking has got a more regular shape than the other. And this is confirmed on the difference map, which shows that the TCAT plus the topo-guided treatment did exactly what it was meant to do, which was to steepen the flatter part and flatten the steeper part. And as a bonus, this eye actually had a greater amount of corneal flattening compared to the other. So if your question is, which cornea looks more symmetric, and therefore which cornea is likely to have a more correctable refraction and a better quality of vision, your answer would probably be the eye that has undergone the TCAT plus CXL. But let's take a completely different perspective on the same situation and look at corneal thickness rather than curvature. You'd realize that we have sacrificed a lot more tissue in the eye that has undergone the TCAT. Not only that, it has removed tissue from a larger zone and from the healthier part of the cornea. So now if your question is, which cornea has lost less tissue and therefore likely to be stronger, the answer would be the eye that has undergone the simple CXL. So this is what I meant, that there is a price to pay for achieving both a refractive as well as a biomechanical effect, and we need to scrutinize the collateral effects of whatever treatment we choose. And without doubt, we have to be heading towards a more customized treatment, because clearly one size does not fit all for keratoconus. And whether this customization is to be based on tomography, on aberrometry, or on biomechanics, or even biomarkers, that's a debate for another day. And even as keratoconus, like the moon, tries to keep a facet of its side hidden from us, the spirit of human inquiry makes it a game of hide and seek. And as long as we can keep that spirit of inquiry alive, we have hope. Thank you very much for your kind attention.
Thank you, Dr. Prema. That was, I think, the most comprehensive talk I've heard on keratoconus, and it's so beautiful. Thank you. Always a pleasure to learn from you. I request all the office bearers on stage to honor Dr. Prema with a plaque. Please come, ma'am.
I request Dr. Rishi introduce Dr. Ramesh Kokania.
The next oration is Rustam Ranji oration, and it's my pride privilege to introduce the speaker, the recipient of the oration this year, none other than my good friend, Dr. Ramesh Kekunaya. Ramesh is the Network Director, Capacity Building of LV Prasad Eye Institute. In addition to that, he holds other major portfolios, which is Director of the Child Sight Institute, which is basically for pediatric ophthalmology, Director of Center of Technology Innovation, and Head of the Jasti Ramanama Children's Eye Care Center at LV Prasad Eye Institute. He is also an Executive Bureau Director of the World Society of Pediatric Ophthalmology and Strabismus, which is the WSPOS, which is a very important international body for pediatric ophthalmology. He is the founder, executive bureau member of Pediatric Ophthalmology and Strabismus Network of India, which is POSN, and an administrative council member of the International Strabismological Association, which is the ISA. Dr. Kekunaya received, which was APOS accredited at the Jules Stein Eye Institute, University of California, USA. His core clinical interests include simple and complex strabismus in adults and children, childhood cataract, vision development, myopia, amblyopia, and neuro-ophthalmological disorders in children. He has been honored with achievement awards from American Academy of Ophthalmology and Asia Pacific Academy of Ophthalmology. Dr. Kekunaya is also the recipient of the International Scholar Award and International Education Award from AAO and the Honor Award from the American Academy for Pediatric Ophthalmology and Strabismus. He has authored 150 publications in peer-reviewed journals, in addition to having written 25 textbook chapters. He is Pediatric Ophthalmology and Strabismus section editor of the BJO, which is the British Journal of Ophthalmology, Current Eye Research, and BMJ Open Ophthalmology. He has presented widely and is invited as keynote speaker in both national and global levels, and is passionate about teaching. He is a calm and composed person, and he's loved by his fellow colleagues. He spends his free time listening to music and watching movies. And if you have ever met him, he's always smiling and brings a smile to your faces also. It's my pleasure to welcome Dr. Ramesh Kekunaya to the stage, and Dr. Raman, our organizing secretary, will escort him to the stage. And I'll request him to deliver the Rustam Ranji Oration 2023.
Can I have my slides, please? Yeah. Thank you so much, Rishi. That's a wonderful introduction. Thank you so much. I'm really lucky here to be giving an oration lecture at the Bhagyanagar Toscon. I really appreciate all the organizing committee members for giving me this opportunity. And with the deep gratitude, I'm delivering this Dr. Rustam Ranji oration lecture. Dr. Rustam Ranji was a practitioner in Secunderabad area, and he had more than 4 decades of practice. I was going through his CV. He was having a very keen interest on youth welfare, so I thought that pediatric cataract fits very well there in terms of his vision, what he wanted to do for children and youth. So my topic today is a little general in terms of seeing beyond the haze, from diagnosis to restoration of vision in children with cataracts. I believe in this journey, all of you are sitting here, we are a part of restoration of vision. For these children, once there is a cataract, they have a lifelong follow-up. The prevalence of childhood blindness due to cataract varies from 6% to 22%. 1 out of 5 blindness in especially the developing countries can be because of pediatric cataract. That's the magnitude of this disease. And for this child with bilateral cataract to read that or see that movie of Harry Potter, it takes a very, very long journey. It's not easy. Sometimes it can be challenging. So it really takes many of these things in terms of creating awareness, in terms of evaluation. It needs ocular as well as systemic. Most of the times there is a tendency to look at ocular features only, but it's much beyond than just ocular. Surgical techniques, yes, of course it's important, but that's not the only thing. And what follows is the follow-up as well as visual rehabilitation. It's a teamwork between the parents and the healthcare professionals. Look at this child here, came very late with bilateral cataract. It still happens in 2023. I'm sure most of you are dealing with these kind of cases. It's not that everything we have lost at this stage. Still, you can see the child really touches. It sees the vision by touching. She can tell what it is. It takes a long time if there is a delay. So we looked at still the delay in presentation of childhood cataract across many parts of India. Still, it's a very significant problem due to the late presentation, failure to detect, and even referral pattern. We are still struggling. I think that needs to, it's improved significantly, but there is a long way to go. When you see these children with pediatric cataract, one size never fits all. You can see some of them have total cataract, some of them have strabismus, some of them have dysmorphism, some of them have a genetic syndrome. By looking at them, you can say that there is something wrong in terms of, because as human being, we like symmetry. Whatever you see asymmetrical anywhere, it catches your attention. So by looking at this face, you can get a lot of information about the etiology. Etiology, the workup is really, really short, but whenever you see a patient with this, pay attention to these things. First, dysmorphology and morphology of the cataract, and also family members. You know, examining a family member does not take much time. It's not very expensive. It does not need, it just need a mindset to check the family members so that he can come to an etiology and also help the family so that if there is anything, you can. And then comes the lab test and genetic test. This is one of the series we published looking at a profile of modern series. In 2020, we looked at still the virus and the familial cataracts are the most common cause of pediatric cataract in our country. There was a publication in 1983 from Arvind Group. It said 50% of the patients are idiopathic. Now that 50% has come down because we have genetic tests, we can identify the syndromes better, we can classify them. This is the list of, if you look at unilateral and bilateral, how they are different in these groups. Having seen many patients, a simple rubella syndrome, you all would have seen. But now we can recognize this pattern. Can you see the forehead, how it is? There is a swole. If you see this swole of hair on the forehead, it's rubella syndrome unless proved otherwise. These are all some of the patterns. Be it an infant, be it a newborn, you can see this round thing. There are other features, but looking at this rubella dysmorphism, it's important because even without some of the laboratory tests, we can still diagnose this, and we can also refer them to cardiologists and other things. Morphology, be it anterior, be it central, be it posterior. Each of them speaks a particular diagnosis. Each of them can be associated with particular systemic association. We should be able to recognize these hidden things there and then come to a diagnosis. As you can see, some of these cataracts are reversible with some dietary changes. Some of them can have brain changes like CTX-related cataracts. If you detect them early, you can really treat the cataract as well as severe intelligence abnormality they can develop at an early stage. So these are the red flag signs you need to really know. And also, some of these syndromes, if you see once, you will never forget it. But there are many, many resources available, specifically the OMIM on the website. You can put these features and you can see what are the diagnoses with that particular cataract. One thing which is really different from adult cataract is this curve of the axial length and curve of the keratometry. It changes in the first 6 months and first 1 year. Our battle is against this growth. Growth tend to happen in kids. It will happen. But when you select an intraocular lens, you will have a problem. That's why whenever you counsel, it takes a lot of time to counsel with the parents of pediatric cataract, because you need to know what type of lenses, what's the follow-up requirement for these kind of situations. You need to have a lengthy discussion with the parents. And also, we need to tell them what to expect, because it's not a one-time phenomenon. Many parents think that surgery is done and my child will be all right at this point of time and I don't have to worry. Sometimes the problem starts after the cataract, so you need to have a thorough counseling with the good preoperative assessment. Sometimes tools like UBM and all that can come into really handy in these kind of situations. One of the burning question is, many people around the world ask is, when to put implant in a child, be it an infant, neonate, or a toddler. This is a Venn diagram. You can see there are 3 components to it. One is the vital parameters of the eye. This review is available free. Anybody can download it. There are intraoperative factors. And the third thing is patient socioeconomic status, as well as the insurance, all that come into picture. Then only you can take a decision whether you can implant a lens or not. This is a simple tool for intraocular lens implantation. Age plus the undercorrection should be equal to 7. This is the most simplistic way you can choose intraocular lens if you decide to implant a lens in a child. And we have validated this NAD formula through this study, validation of these guidelines. When we looked at 8 years down the line after follow-up or 10 years down the line, kind of it correlates. They have definitely a prediction error, as we showed in this paper. Many of the IOL calculation, power calculation formulae can be used, but in our experience, we experienced either SRK2 or T works very well, and all of them will have for sure some kind of prediction error. The next part I just wanted to touch upon is the cataract surgery. It's the rhexis, it's the type of IOL, and it's the technique of post-op capsulotomy, what you do. Surgical technique involves multiple things like incision site, and then how do you implant, and how do you take care of sutures, the wound. This is important. It's not that you can just leave them just like that. And post-operative care also is important. And depending upon the resources, because most of this cataract happens in lower socioeconomic status patients, so you need to have that economics taken care of for this patient. One of the most difficult across the world people have is with pediatric management, cataract surgery is anterior capsular rhexis. This is the most difficult thing most people think, but with the experience with the adult cataract surgery, once you have done few number and you are comfortable with the adult cataract surgery, this is not as difficult, because you take this grasp, re-grasp, inward pull, grip. If you have this grip all the time, you can get this anterior capsular rhexis done. And go slow, but don't go too slow, because if you go too slow, you will be overcautious and you can have problems. So some of these patients will require some kind of staining, as you can see in the first video. Sometimes, as you can see in the second video, we can just rotate the eyeball and look at the sheen of the anterior capsule. We call it as sheen rhexis. And obviously, in some of the cases of trauma, you need scissors. And some patients with PHP with the fused capsule, we might need a vitrector. with which we can do it. As I'm doing vitrectomy there, you can see the bleeding there. You can cauterize using an endocautery for these vessels. One of the important things which is usually not done is anterior lens capsule polishing. Under surface of the anterior capsule, up till equator, if you clear this capsule, honestly, the anterior capsule rhexis and lens aspiration does take very little time. What takes time really in pediatric cataract is this step, where we have to go till the equator as much as possible, remove this lens epithelial cells, because in the future, they can cause two things. One is visual axis opacification. Second thing is sometimes they can migrate into the trabecular meshwork. This is one of the reasons some of these patients can develop glaucoma. So that's why spend some time in capsule polishing. Posterior capsule management, you can leave them aphakia or lens. If you keep them aphakic, keep the anterior capsule and the posterior capsule of equal size. In the future, it becomes easier. There are two ways to do the PPC. One is the manual, and the second thing is using a vitrector. After implanting the lens, you can go behind the lens and do it. Both are pretty safe, but sometimes in an unknown territory, like in cases of posterior lenticonus, already there will be a God-made capsulotomy will be there. But in these kind of situations, you'll be much more confident. So as the fellows get better, it's better to convert into a manual. That's more regular and it's good. And there are different types of IOLs you can use in children, but most often you use hydrophobic lenses. Hydrophilic lenses have a lot of problem, and also any kind of blue blocking and all these lenses are not good, because the UV radiation and the good light is important for the macular development in kids. That's why we don't use any of this yellow lenses and all that. We just use simple, foldable is better, and single piece hydrophobic lenses are used most often. And we generally do PPC till 10 years of age. Over a period of time, we have realized that the visual axis opacification can happen even later. Some of the situations where posterior lenticonus, you can see there are two situations. One is there is a fishtail sign, and one surgery where there is a large crater there. So in this patient, the first patient, we are implanting the lens and then opening up that crater. But in the second case, we have aspirated everything and then we have implanted the lens there. And sometimes, always one of the things we need to do is in kids, always do the retinal examination just intraoperatively, because next day it's difficult to do it. Finish everything. One of the things is you can inject somewhere. You can use this peekaboo sign where you can see the posterior pole very easily with the air, and you can adjust the microscope. You don't even have to take an indirect, and you can really visualize both in aphakic patients as well as in pseudophakic patients. And these are some of the patients where it's a difficult cases with aniridia. Two types of aniridia you can see. Most often we try to avoid lens in these patients. So sometimes we need some innovation. There are some instruments available, especially for Zepto cataract. You can see this precision pulse capsulotomy. In my opinion, if you are experienced, it will not make much difference. But in a country where your training is not really good, probably if the cost of this can be reduced, because this is a limiting situation for most of the surgeon getting the anterior capsular axis right, it can be really used in some of these cases. And this is some of the long-term outcomes of these patients. And in some patients, especially the intumescent lens, you can use this Zepto. Only thing is, there'll be a lot of surge. As you can see here, as I'm giving this pulse, you can see suddenly there is decompression. So there is some concerns about what happens to the endothelial cells in these small babies. And one more innovation is, if possible, visual axis opacification is one of the long-term complication. To prevent that, we can also, Dr. Mary Tazignan from Belgium, she has developed this bag in the lens. There are some lens produced in India. So if this is available, this makes the visual axis opacification very, very minimal. And technique is not so difficult. You just have to insert this lens between the two leaflets of the anterior and posterior capsule there, and it has to be centered well, and your capsular axis size should be equal. These are the two prerequisites for implanting this lens here. And you can see in the long term, they do very well. This is after 3 years of follow-up. Some of these innovations, if it is available, it's good. In Ali Prasad also, we try to take this surgical and other expertise to the secondary center. Some of the clusters, we do this simple pediatric cataract in the secondary center as well. And obviously, complications are always there. You need to really take care of them. And also, you need to take care of our trainees. In a formal Oscar format, we have this scoring system, and we really look at their quality of training compared to consultants. We frequently look at their scores, how they are improving. But it's pretty good with this kind of numbers, what they get. We can train many fellows, because this is an important aspect of taking the pediatric cataract to the next level. And with regards to rehabilitation, I just wanted to say that along with this optical correction, either intraocular lens or contact lens or FAK glasses, you need to learn something from these patients. That's why we set up this retrospective developmental approach. Whoever is coming late to us, we look at their brain, we look at their EEG, we look at their behavioral changes with many kind of experiments, obviously with the collaboration with the University of Hamburg. And we try to look at whether the child is able to perceive this biological motion. To our surprise, what we have seen is patients with these kind of blindness for a long time, maybe 5 years if you do, things like color vision, things like biological motion is very intact. That's why in our rehabilitation things, more of a colorful and the video-based with lot of biological motions like running, cats, dogs, all that they can. This is very much intact even if you have a congenital blindness due to this cataract, and it's reversible later. And the last part I wanted to touch upon is, this is the most important aspect. We did a study. You can see the drop in follow-up rate after 1 year of surgery. This is not acceptable because they have a lifelong risk of glaucoma. And what we did is we brought in a system where we sent an SMS or a call from our counselors, with which we could improve this drop in the follow-up rate to close to 80% of them came for the follow-up. So some kind of calls are required because sometimes parents don't really understand. So this child to get a vision, this is my final slide, final few slides. They are born in their maternal place. They will get the surgery at the maternal place. They will grow. They'll go to their own house. They grow towards, schooling to adulthood and everything. But still, we have to take care of their follow-up. That's why every visit when they come, do a real follow-up. Real, the full form is refraction, eye pressure check, alignment check, and lens and related parameters, be it retinal evaluation, be it corneal evaluation, everything we need to do it. And people who are sitting in this room, all of us are capable of doing this to give a care for these children over a period of time. And this journey is a real long journey for these people. And with the real contribution, we can restore their vision through a multidisciplinary, multi-speciality. We can make a socio-economic as well as developmental impact on these children. Because vision loss in a child is not just a health issue, it's a developmental issue of the whole child. Thank you so much for listening, and I'm really thankful to the whole group. Thank you so much.
Thank you very much, Dr. Ramesh. You have detailed very clearly, and this is a very important topic. And most of the surgeons, even anterior segment surgeons, but dealing with the children is very difficult. Thank you very much for your detailed topic. I accept our matter, sir. So next, the inauguration program will start. Please wait for 10 minutes.
లాస్ట్ వాడు పెడతాడు ఇది లాస్ట్ మీద నువ్వు ఫస్ట్ కిందకి తీసుకురా. నువ్వు ఇక్కడ స్పీక్ చేసి మీదకి రాని మన దగ్గర ప్రింట్అవుట్ ఉంది వదిలే ఫస్ట్ చైన్స్ అన్ని మీదకి రాని సార్ ఇది కనెక్ట్ చేస్తారా అటు సైడ్
Excuse me. నేను ల్యాప్టాప్ పెన్నుగా ఉంది ఉందా మరి ఒకసారి అండి సరే కానీ ఉందా పవర్ ఉందా కాదు పవర్ కార్డ్ కాదు ఎందుకంటే 1 అవర్ పడుతుంది ఛార్జర్ ఉందా ఉంది జస్ట్ ఇది
अरे इकड़ रा अच्छा अక్కడ పెట్టమంటావా मतलब these two
पीछे की चेयर्स बोल रही हूँ मैं, सामने की मत डिस्टर्ब करो। हाँ, ये थोड़ा इधर करो, ये वाली चेयर, कैप इक्वल रहना। हाँ, साई इधर सुनो, ये चेयर लास्ट उधर ले जाओ, डॉक्टर राजलिंगम का चेयर वहाँ ले जाओ, डॉक्टर वाई रामन का इधर लेके आओ। वो पीछे मोमेंट,
हाँ उसको थोड़ा हटा दिए तो 4 लोग
शिवा वो टेबल थोड़ा पीछे करा दो।
బాబు కిరణ్ పైన చూడు
WhatsApp. Next is slide. కింద arrow. ఈ కింద arrowనా కింద Shall I start? Hope yesterday all the delegates have enjoyed the academic feast, and I welcome all of you, all the delegates for the today's inaugural function. So we are going to start with, it is my privilege and honor to invite Dr. Ashish Bansal sir, Honorable President of the TAS, and then it's my privilege to invite President-elect Dr. Badrinarayan sir and Vice President Dr. Bharat Kumar, and all other office bearers together, Dr. Rajalingam, General Secretary, TAS, Dr. Rishi Swarup, Chairman, Scientific Committee, past President, Dr. A. Ravindra sir, and Dr. Nandakishwar sir, HYA President, and Dr. Madhukar Reddy sir, LOC Chairman, and Dr. Ravi, Treasurer, TAS, Dr. Praveen, Joint Secretary, TAS, and Dr. Modini Madam, my colleague, Chairman, ARC, Dr. K. Srinivas Prasad, Chairman, Airtel Journal of Publications, and Dr. Alpa Atul, Treasurer, LOC, and Dr. M. Supana, Joint Organizing Secretary, LOC, to occupy your chairs. Now, I invite our guest of honor, guest of honor, Dr. Santosh Hanavar, to be escorted to the dais by Dr. Arjun. So kindly occupy the chair, sir. Yeah, sure. Now, I invite our chief guest, Dr. Srinath Reddy, sir, to be escorted to the dais by Dr. Suparna. Now, I'm honored to invite Dr. Rajalingam, sir, the Master of Ceremonies, to take over for the further proceedings. Thank you very much, Organizing Secretary, Dr. Raman. Now, we will, the session of prayers will start. I request Mrs. Aruna Kishore and the team, please come for prayer, sir.
Hello. Is this on? Don't do this. Excuse me, is this on? Om Gam Ganapataye Namaha. Om Gam Ganapataye Namaha. Om Gam Ganapataye Namaha. Om Gam Ganapataye Namaha. Bhajamanasa Vigneshwaram Anisam. Bhajamanasa Vigneshwaram Manisham. Bhajapurvarpana Sadana Ganesam. Bhajamanasa Vigneshwaram Manisham. भज पूर्वार्पण सदन गणेशं भज मानस विघ्नेश्वरं मनीषम् गजवदनं दुरितं कविनाशं गजवदनं दुरितं कविनाशं गजशमनं शतसूर्यविकासं भज मानस विघ्नेश्वरं मनीषं भज पूर्वार्पण सदन गणेशं भज मानस विघ्नेश्वरं मनीषम् वरदं जनशरणं भयहरणं वरदं जनशरणं भयहरणं वरमुनिमानस पापविहरणं वरदं जनशरणं भयहरणं वरमुनिमानस पापविहरणं वरबलरसन रतं भवतरणं वरबलरसन रतं भवतरणं वनतुलसी दलपूजितचरणं भज मानस विघ्नेश्वरं मनीषं भज पूर्वार्पण सदन गणेशं भज मानस विघ्नेश्वरं मनीषं भज पूर्वार्पण सदन गणेशं भज मानस विघ्नेश्वरं मनीषम् What is this?
Thank you very much. Then I request all the dignitaries on the front dais, please come for the lighting of the lamp. Our chief guest, Dr. Srinath Reddy Garu, please come out. Our president-elect, our AIOS President General Secretary, and others, please come for the lighting of the lamp. Thank you, sir. Next, I invite our local organizing committee chairman, Dr. Madhukar Reddy. Please deliver your message, sir.
Good
morning, delegates. My dear outgoing President, Dr. Ashish Bansal, incoming President, Dr. Badri Narayana, Chief Guest this morning, Dr. Srinath Reddy, and guests of honor, Dr. Prema Padmanabhan and Dr. Santosh Honawar, and all my friends and delegates. It's my pleasant duty to welcome you all for this 8th Telangana State Ophthalmology meeting, which we have a record number of registrations this year, about 1,000, and that's a great achievement for our newest state association. And Telangana Ophthalmology Society, Hyderabad Ophthalmology Association, and the local organizing committee have really put together this conference by the hard work of Dr. Raman, Suparna, and Rajalingam. There are many people, Charuta, Alpa, and Sridhar, Arjun, Somshila, Dr. Nandikishore, Dr. Manoj. And it's difficult to take each one by name, but all of them have put together their hard work, and this is the result. And please enjoy this academic and social experience, and if there's any shortcomings, please forgive us. And please go ahead, enjoy the rest of the meeting. And thank you very much for being with us.
Thank you, sir. The secretary report now. Respected our chief guest, a famous cardiologist and retired professor from the All India Institute of Medical Sciences, New Delhi. Respected Dr. Srinath Reddy Garu, and a international renowned ocular plastic surgeon and ocular oncologist, Honorary General Secretary of the AIOS, Dr. Santosh Honawar Garu, our task president, Dr. Ashish Bansal, Dr. President-elect, Dr. Badri Narayana, and Vice President, Dr. Bharat, and Chairperson of the Scientific Committee, Dr. Rishi Swarup, Treasurer, Dr. Ravi Kumar, ARC Chairman, Dr. Modini, and our editor publication, Dr. Srinivas Prasad, all LOC members like Chairman, Dr. Madhukar Reddy Garu, Organizing Secretary Raman, and Co-Organizing Secretary, our Suparna, and other local organizing members. AOS Treasurer, Dr. Manoj Mathur, and Chairperson, I think she is not there, Namrata Sharma, Dr. Chitra, and dear delegate, senior and my junior colleagues, PG students, and my friends. Good afternoon. Telangana Ophthalmic Society has formed in 2016, and this is the 8th annual TOS conference. Before year, we have conducted the 7th annual conference in Warangal, and it was really great success. And the local organizing committee has put a lot of effort in the Warangal and made it really a great conference in the last year. So we appreciate Warangal LOC for their dedication in organizing such a nice conference. As all you know, TOS not only organizing conferences, but involving in conducting the workshops, seminars, and symposiums as an academic activity. In 2022-23, we have organized conferences under the ARC in Sarojan Devi. It was a very large gathering, about 110 delegates were present. And later on, we conducted a seminar in association with All India AIOS in Radisson Blue Hotel. And that was also very successful conference. And at the same time, we have conducted the seminars in Warangal, Karimnagar, and Khammam. Apart from academic activities, the society worked for the welfare of the primary members of Telangana Ophthalmic Society. So I will give you some example. Previously, the Telangana Ophthalmic Society succeeded in bringing down the number of beds for the empanelment for the Arogyasri and EHS. It was actually 50 bedded that used to recognize for the empowerment for the Arogyasri. That 50 bedded had brought down to 20. It is a great success for the Telangana Ophthalmic Society. And TOS represented DCA for the permission to open dispensary in clinics, in ophthalmology clinics. I think now NMC has given a permission to open your pharmacy and dispense the drugs only for your patient, not for the other patients. And we have represented Telangana government to remove the B-scan from the PC-PNDT Act. Still it is pending now. And we requested the Telangana state government about the removal of the eye hospitals and clinics who have buildings less than 15 meters. These both issues are still pending with the government. And there was a meeting to discuss about the aggregators in one of the meetings. And the aggregators who are earning more money than the doctors who are working for them. And this issue still there is no consensus. And we have to come to a consensus and we have to resolve this issue. The other issue we took, Telangana Ophthalmic Society has concern toward primary members who are facing quacks actually day in and day out. They have reported to the chairman of the Telangana State Medical Council, and Telangana Medical Council is very serious about the quacks involving various fields, not only in ophthalmology. And the TSMC is very serious about this issue after the TSMC elections. So every year, membership drive is one of the important activity in the Telangana Ophthalmic Society, and this will strengthen actually any society. So at the time of bifurcation, the membership was 708. Now it has increased from 1,407 to last year to 1,693 this year. If we go on adding members at this pace, I think we will reach 2,000 in a short period. So regarding finances, we are satisfactorily growing, contributions from the members, participation of the traders in the conferences. They are our financial strength. Treasurer has some problem with bank account and GST. I hope he will spend some extra time to push forward and solve the problems. TOS has sufficient financial position now and to continue the day-to-day activities. Telangana Ophthalmic Society website, it is started in 2016 and it is now full-fledged website. So you can enroll your membership through online. So you can apply e-posters from the online and other facilities like you are submitting like scientific abstracts, and even you can submit a e-poster online. It has a facility to update the individual member profile also. So this website is safe and secure. Development of cell app for the Telangana Ophthalmic Society is on the card now. So now total membership for the Telangana Ophthalmic Society is 1,693. So this conference is a great actually success by enrolling all members. Now it is more than 1,000 registrations have already registered. And the number of abstracts, it is more than 550. This is also a very large abstract that we have received this year. So still many ophthalmologists, they don't know the permanent address of the Telangana Ophthalmic Society. I am telling that it is a Sarojini Devi Eye Hospital because many phone calls I have received that where is the actually office of the Telangana Ophthalmic Society. Please note down, this is Telangana Ophthalmic Society official address is the Sarojini Devi Eye Hospital. I congratulate Dr. Vijay Kumar being elected unanimously for the post of Vice President of Telangana Ophthalmic Society. We had Telangana Ophthalmic Society Executive Body elected in 2022 in the last conference in Warangal. And Dr. Somashila was actually resigned, and EC has appointed Dr. Rishi as an chairperson of the scientific committee and Dr. Modini as an chairman for the ARC. Both are doing excellent work. Thank you. Then on behalf of TOS, I congratulate AIOS General Secretary Dr. Santosh Honavar and AIOS Treasurer Dr. Manoj Mathur. both from Telangana, for their grand victory in the last AIOS. They need a great applause. On the behalf of Telangana Ophthalmic Society, I congratulate Dr. Sai Baba Gaud, he was ex-superintendent of Sarojini Eye Hospital, for his Lifetime Achievement Award from AIOS. I also congratulate the cine lyricist, Sri Chandra Bose, who was our chief guest in the last conference in Warangal. And he earned an Oscar award for his lyrics in the RRR cinema. I congratulate all orators, Dr. Prema Padmanabhan, Dr. Ramesh Kakania, Dr. Deepak Megur, and Dr. Srinivas Reddy, select for orations. And thank you for being with us for this conference, sir. I thank Dr. Santosh Honavar, AIOS General Secretary, for being with us as a guest of honor. And thank you very much, sir. I thank Dr. Ashish Bansal, President, and our President-elect, Dr. Badrinath, and Dr. Bharat Kumar, Vice President, and Dr. Nandakishore, our advisor, for their constant guidance to improve this society. I thank and congratulate Dr. Srinivas Prasad for sparing his valuable time for nice and informative Toss Today magazine to be released shortly. I hope he will release 2 issues in a year. I thank Dr. Rishi Swarup for accepting the post of Chairman AS Scientific Committee, and everybody appreciated his effort and efficiency in arranging this scientific feast in this short period of time. This time, releasing this scientific schedule is slightly late, but he is always the latest. I thank ARC Chairman, Dr. P. Modini, for your contribution for this society by conducting workshops. I think you will introduce some innovations in the coming workshops. I thank all executive committee members and LOC members for giving this opportunity. I thank everybody for this opportunity. Thank you very much. Next we will go further. Now I request our President of TAS, Dr. Ashish Bansal, to give the mementos to all LOC members. Our Chief Patron, Dr. Giridhar, the last LOC members. I request Dr. Giridhar and Dr. Rajkumar, Dr. P. Praveen, and Dr. Venu Madhav. Venu Madhav, Dr. Praveen, Dr. Rajkumar, thank you, sir. Next, the much-awaited program for the installation of the new TAS President by our past President, Dr. Ashish Bansal. Your medal.
Okay, so the annual conference is also the time for change of guard. So as I complete my term as president of the society, it's my pleasure to introduce to you our next president, Dr. Badrinarayan Garimalla. Dr. Badri is a very senior member of the society, and he was born in 1952 in Warangal, and he completed his MBBS in 1975 from Kakatiya Medical College, and did his post-graduation from Osmania Sarojini Devi Hospital in 1979. Subsequently, he worked with Christopher Blended Mission for a couple of years, and then later on, he was involved in organizing multiple eye camps in Mehboob district and worked with Singareni Collieries for about 20 years. Dr. Badri has been the professor and head of Pratima Institute of Medical Sciences, Karimnagar, for 11 years and has recently retired from that post. He is happily married to Mrs. Shraddha and is proud father of 3 daughters who are well settled. Dr. Badri is very passionate about teaching and also about community eye care. And I wish him all the best for his tenure as president of the society, and I'm sure he'll take the society to bigger heights and will be an asset to the society during his tenure as a president. So now I'll be transferring a very heavy medal on to his
So I now request our President, Dr. Badri Narayana, felicitate the past President, Dr. Ashish Bansal. I request our Chief Guest, Dr. Srinath Reddy Garu, felicitate our new President, Dr. Badri Narayana. I request now the President of Telangana Ophthalmic Society, Dr. Badri Narayana, please facilitate our Chief Guest and Guest of Honor. Guest of Honor. Dr. Badri Narayana, please facilitate our Guest of Honor. Now I request the President, Dr. Badri Narayana, please give your message.
Thank you, Dr. Bansal, to introduce me. Distinguished guests, dear colleagues and postgraduates, I welcome you all to this 8th State Conference of Telangana Ophthalmological Society, very well organized by the Hyderabad Ophthalmological Association and local organizing committee, led by Madhukar Reddy, Rajalingam, and Raman and their colleagues. So, it is not an occasion or event. It is a wonderful celebration. This conference is a really wonderful celebration of joy and learning and fellowship. And here we came together to sharing our clinical experiences and skill transfer from the reputed people. And at the outset, I would thank all the members of the society for electing me as the president for 23 and 24. I will strive to serve the society to your expectations. And the journey, the long journey of 8 years, or whether a short journey or long journey, that is excellently presented by Secretary. Newborn, it was a newborn society, and we have, within a short time, as he told, our membership has doubled. And this membership drive will continue with the cooperation of all the members. And I would take a moment to honor the efforts of previous presidents and the office bearers, and their contributions actually have paved the way and shaped our progress today. And it is easier for me to just travel this 1 year because of the guidance, their guidance, valuable guidance. And as Dr. Bansal told, my passion in teaching, I learn as well as teach. Or I learn while teaching. My guru, Dr. Sharma, used to tell, see, I am also student, you are also student. I am little elder student, you are younger student. He never used to use the word or seniors, juniors like that. He used to say, I am an elder student, you are a younger student. That's all. That is the difference. So, in our profession, the learning is never-ending process. I have seen the great Honorable Lalit P. Agarwal coming in wheelchair and participating in the discussions and debates. See, that is an inspiration by our seniors. That is our heritage, I can say. Sir, we have to carry that heritage to the younger generations and nurture the younger generation with our knowledge and passion for the work, commitment to the profession in serving the needy. So regarding CMEs, many a times I had discussions with teachers and seniors and who are working in the institutes. So how learning can be improved and made it as a palatable. Sometimes learning is there, sometimes it is not a palatable learning. So make learning, learning is a palatable thing. So for that, now for this ophthalmological society, there is a wing, ARC, that is academic and research committee is there, now headed by Dr. Modini, and members, Dr. Raman, Sridhar, Suparna. I think this year they have got a Herculean job. There is a task put before them for the year long, and I think I request the incoming president also to just kindly focus on the continued teaching programs. So there she is on that work with our colleagues for the entire year. And the CMEs, we have to take the help of the medical colleges, and already the teaching is going on, and we have to renew the thing and put some of the new perspectives of changing patterns in clinical methods as well as surgical skills and all. And in this committee has also another responsibility. See, nowadays even the National Medical Commission has made it a mandate, strict, for the postgraduates to present papers in the conferences as well as to write in the journals also. And that also made mandatory for the assistant professors, associate professors and professors also. So in indexed journals and reputed journals. For that, lot of research has to be done, lots of efforts have to be put to have a good articles. And for that also, the TOS will be working. And then next the problem comes, once the postgraduate out of the college, already some 8 to 9 years they have been studying and learning and these things. After that, 1 year senior resident and another thing, put it in some hospital without any work, and whatever they have learned in the post-graduation, they will forget soon. And another is next what to do question, whether join a fellowship or have practice. If it is a practice, is the individual practice or a group practice, and how to procure the equipment, how to organize a clinic, how to organize a theater, and all those things are there. So for that also, the TOS will definitely work to guide the career guidance like thing. The seminars or workshops will be conducted to just guide them depending on their respective choices they can choose. And another thing is, I want to bring to your notice that, see, you have to have some sort of agreement with the trade also. See, they supply at a different rates. And we have to, as a society, we can bargain with them and bring the price to the lowest levels also. And another is after sales service also should be regularized and controlled. And I think TOI should do some job on this. And see, we have to, another main problem is we have to, suddenly comes out of the postgraduate course, they are in the institute, wonderful. And it is very difficult to integrate themselves into the practicing community. Senior people are there, established practitioners, large nursing homes, corporate houses also now come up. So they have to integrate themselves into our community and start their practice. So all those things are there. There are some certain things I just brought to your notice. And as Rajalingam told, the excellent work they have done. They have been doing for months together this excellent work and paperwork, as everything now you shape, you see. And I will also put a stress on the membership drive, as Dr. Rajalingam told. And another happy news is the 2 members of the TOS have gone to AIOS. Their continued commitment to the profession, I've seen them, I've seen very closely Dr. Manoj and Dr. Santosh and Nandakishwar also. And how committed they are, this thing. And they are truly, that is representation. People have recognized their commitment and they have elected to the highest post. And I wish that they will serve the community at the nation level and represent in international fora the TOS flag. Thank you so much.
Thank you, sir. Thank you very much for your encouraging message, and I hope the task will go further forward with under your guidance, sir, under your presidency. Meanwhile, I request Rajakumar, sir, please take your memento. Next, actually, mention our IAP, AIOS elected treasurer, Dr. Gopal Raju. We congratulate you, sir. Joint Secretary, and Joint Secretary. Sorry, Joint Secretary. Thank you, sir. Then I request our Chairman, Scientific Committee, Dr. Rishi Swarup, please distribute our scientific awards.
Thank you, Dr. Rajalingam. As Chairman Scientific Committee, it's my distinct privilege to announce the scientific awards from the previous conference. And I request our chief guest, Dr. Srinath Reddy, to hand over these medals. First would be the oration medals of this conference, followed by the winners of the last conference. So I request the first oration medal winner, Dr. Prema Padmanabhan, to come and receive the medal for the P. Shiva Reddy oration. Dr. Prema is one of the senior most cornea specialists of the country from Shankar-Nethralaya, Chennai, and has been a teacher par excellence, and it's really our privilege. The next oration recipient is Dr. Ramesh Kekunaya from LV Prasad Eye Institute, and he is the recipient of the Rustam Ranji Oration 2023. Request Dr. Ramesh to come on stage. I think he's just stepped out. We'll see if he comes in later. The next recipient is for the Hari Kishan oration, Dr. Srinivas Reddy. He's a practitioner from Jammikunta. And he's very passionate about teaching postgraduates, and it's our privilege to have him with us. The fourth oration recipient is Dr. Deepak Megur for the Ravi Kumar Reddy oration. He hasn't yet arrived for the conference, and he'll be coming in tomorrow, and we'll give his oration medal at the time of the oration. We'll wait for Dr. Ramesh to come and hand over his oration medal at a later point. Moving on to the student awards from the 2022 conference, the winner of the N. Subramania Reddy free paper session for postgraduates who are TOS members goes to Dr. Akhila Kutumbaka from the Amrita Institute of Medical Sciences and Research, Kochi. Is she here, Dr. Akhila? Can somebody receive it on her behalf? It seems Dr. Ramesh has arrived, so we request Dr. Ramesh to come up and receive his oration medal for the Rustam Ranji oration. Dr. Ramesh Kekunaya is the head of pediatric ophthalmology at the LV Prasad Eye Institute, Hyderabad. Moving on to the Student Awards of 2022 conference, one of the main free paper sessions of the conference is the Ramchandra P free paper session, and the winner last year was Dr. Akash Belenji from the LV Prasad Eye Institute. Is Dr. Akash here? He will also receive a check of 10,000 rupees along with the memento. The next award was for Manoj C. Mathur poster session, and the recipient is Dr. Shubhav Prasad from the Center for Sight Hospital, Hyderabad. Next award was the Swaroop video session, and the recipient is Dr. Arvind Kumar Maurya from AIMS, BB Nagar, Telangana. I think he's not there in the conference at this point, so we'll give it to him separately. The next award is for the Dr. V.V. Ramana Rao Case Presentation Award, and that goes to Dr. Rolika Bansal from Center for Sight, Hyderabad. I think she's not here, but Dr. Akash will receive it on her behalf. Dr. Subhav, sorry. The next award is the Drishti Student of the Year Award, and that goes to Dr. Parth Palan from LV Prasad Eye Institute, Hyderabad. Finally, going to the Gangadhar Reddy quiz. There won't be any award given. I'll just announce the winners. The winners from the last year were Dr. Parth Palan. The first team was Dr. Parth Palan, Dr. Prapti Cheda, and Dr. Anirudh Herur, all three from LV Prasad Eye Institute. Congratulations to them. And the runners-up was Dr. Manish, Dr. Anvita, and Dr. Aisha from Sarojini Devi Eye Institute. Finally, the presentation of the LDP award to Dr. Sai Kiranmai. Yeah, she will receive a check for 10,000 rupees from our chief guest. I asked actually. Yeah. There's been a small error. There are certificates for the quiz winners. So I request the winners of the last year's quiz, Dr. Parth Palan, Dr. Prapti Cheda, and Dr. Anirudh Herur to come up on stage and receive their certificates for the first prize of the Gangadhar Reddy Quiz 2022. Thank you, Dr. Srinath Reddy, and congratulations to all the winners.
Thank you, Dr. Rishi. And now we have a great moment of our AIOS. Felicitation of Dr. Santosh Honavar, Dr. Manoj Mathur for bringing laurels to the Telangana Ophthalmology Society. Mementos by Chief Guest. I request our Chief Guest, please disperse the mementos. Dr. Santosh Honavar, Dr. Manoj Mathur, please come out the dais, sir. I request the guest of honor, Dr. Santosh Honavar, to release the souvenir. Souvenir books. Souvenir books ఎక్కడ ఉందమ్మా? Yeah. Releasing of the souvenir by our guest of honor, Dr. Santosh Honavar. I request our chief guest, Dr. Srinath Reddy Garu, please release the program book. Next. I request the guest of honor, Dr. Santosh Hanavar, please deliver your message, sir.
Good afternoon. It's a great privilege and a pleasure to be part of the 8th annual meeting of the Telangana Ophthalmological Society. Being part of TOS from its ophthalmologists in India, it's the baby actually, and it's grown very rapidly under leadership of past presidents, secretaries, and chairpersons of scientific committee to achieve a mature status, I should say, to be able to hold conferences of this magnitude and have such a vast, well-encompassing scientific program as it has today. I bring to you greetings from the All India Ophthalmological Society, of which TOS is an affiliate, and all state societies are affiliates of AIOS, and AIOS is proud to have TIOS grow so rapidly and accomplish such feats. All conferences have scientific program as the backbone, and Rishi Swaroop and his team of scientific committee have done a wonderful job in having a well-encompassing scientific program which has something for everybody, I should say. It's a very vast and a nice scientific program covering all the subspecialties, including ocular oncology, which has a session. That's all I really have to say. I'm really pleased to see TOS grow, but I would like youngsters to come into TOS and take responsible positions so that leadership vacuum is filled in the near future. TOS is headed by very mature and senior elders, but youngsters really have to come into TOS and take up positions of strength, I should say. I'm very pleased to be here, and thanks everybody for this honor. And thank you for the support at the AIOS elections, which really brought us, me and Manoj, into the fold of AIOS, and we promise to do all our best to keep TOS flag flying higher in Delhi, and come back to you with annual reports of our progress. Thank you so much.
Thank you, sir. Next, I request Dr. Nandakishore introduce our chief guest, Dr. Srinath Reddy Garu.
Good afternoon. It's my proud privilege to talk about somebody, there's so much to talk about him that to tell it in one sentence, Professor Srinath Reddy is somebody who has conquered all the frontiers that are to be there in the field of medicine, cardiology, and public health, not only nationally but also internationally. However, to give you a brief glimpse into his biodata would probably get you all exposed to the kind of towering personality we have amongst us today, and how fortunate the award winners today are to receive their awards at his hands. It's indeed a great privilege. His achievements, his positions are so many that it takes probably the entire 1 hour to describe it. But I tried to make it as brief as possible because he didn't want me to be too lengthy. So
just to tell you what all his present positions are. He is the distinguished professor of public health at the Public Health Foundation of India from 2022 onwards. He is adjunct professor of epidemiology at Harvard 2014 onwards, adjunct professor at Emory, Sydney Universities, and Perelman School of Medicine, Pennsylvania, member WHO Executive Group, International Steering Committee for COVID-19 2020 onwards, and National Task Force of Public Health Experts for COVID-19. The positions he has held so far he has been the founder and past president at the Public Health Foundation of India, formerly head of Department of Cardiology at AIIMS, New Delhi. First, Bernard Lone, visiting professor of cardiovascular health at Harvard School of Public Health from 2019 to 13, president World Heart Federation, served on various technical committees of WHO and ICMR, editor, National Medical Journal of India for 10 years, President, National Board of Examinations 2009 to 14, personal physician to 2 prime ministers, ranked first in top 10 sustainability leaders in healthcare, delivered various lectures and orations. Distinctions and awards have been too many. Among them, the most important would be awarded Padma Bhushan by the Government of India in 2005, chaired various national and international bodies, authored over 570 scientific publications, WHO Director General Award for Outstanding Global Leadership in Tobacco Control, Queen Elizabeth Medal from the United Kingdom in 2005, first Indian to be awarded as Fellow London School of Tropical Medicine and Hygiene, Fellow Faculty of Public Health UK. Doctor of Science at Aberdeen University, Scotland, 2011, NTR Medical University in the same year, University of Lausanne, 2012, University of Glasgow in 2013. Honorary Doctor of Literature from Jodhpur University and Doctor of Science from, in Medicine from London, ILBS, India and Maulana Azad Universities. He is the first Indian to be elected as international member of National Academy of Medicine, USA. Apart from that, I think a few of us, like myself, Dr. Madhukar, Rishi, and anybody else who is there from St. Paul's School, we proudly, we feel very proud that we belong to the same school from which he has also passed out, St. Paul's School in Hyderabad. Sir, with these few words, I present to you our distinguished chief guest, Professor Srinath Reddy. It will be a pleasure to hear you, sir.
Thank you, sir. Thank you very much. We fortunate to share the dais with so great person. I request our chief guest, please deliver your message, sir.
Dignitaries on the dais, luminaries in the audience, distinguished delegates. It's indeed a great honor to be here, and an unexpected honor at that, as the chief guest at the Toscon of this year. I asked myself what I really did to deserve this honor. So I asked myself initially 3 questions. Is it because I'm a Pravasi Hyderabadi? Is it because I am a cardiologist? Is it because I'm also a public health advocate? And then I thought perhaps the answer to all these 3 questions is yes. Yes, indeed. I'm a non-resident Hyderabadi, but as I told the Chief Minister of Telangana a few years ago, when he came to do the Bhumi Puja of our Indian Institute of Public Health in Hyderabad, मैं दिल्ली जाके दिल का डॉक्टर तो बन गया साहब, but फिर भी दिल है हैदराबादी. So the answer to that question is yes. Then is it because I'm a cardiologist? Perhaps. Of course, even when I was a young resident in cardiology at the All India Institute of Medical Sciences, or even before that while doing internship at the Osmania Medical College, those days when valvular heart disease was widely prevalent,
and we had to look at cases of infective endocarditis. And we would quite often get culture negativity because antibiotics might have already been used. One of the diagnostic criteria that had to be employed was an ophthalmic examination for flame-shaped hemorrhages, cotton wool spots, and the so-called Roth spots. So that is where the relationship between ophthalmology and cardiology perhaps started in the area where rheumatic heart disease was very prevalent. Then, of course, came hypertensive retinopathy, then came diabetic retinopathy with coexistent diabetes and hypertension and cardiovascular disease. But now we find that retinal imaging is now what is being called oculomics, to supplement genomics and epigenomics and proteomics and all of that. Now, oculomics has become an important element of diagnosing a variety of diseases, including cardiovascular and metabolic diseases. And we recently had the video of Sundar Pichai announcing at the Google that Google AI had actually succeeded in identifying through retinal imaging cardiovascular disease, particularly coronary heart disease, in a large number of people through deep AI. And therefore, we recognize that this particular technology is now beginning to find out non-invasive methods of diagnosing cardiovascular disease, especially coronary heart disease. The interesting part of it is he announced that not only cardiovascular risk could be detected and estimated well, but individual cardiovascular risk factors also showed an excellent correlation, whether it was age or BMI or HbA1c or blood pressure. All of them showed an excellent correlation with the digital imaging that was found. Therefore, digital retinal imaging retinal imaging with AI has been now announced. Of course, it's not new. We know that retinal pictures in cardiovascular disease were actually being cited in literature for more than 20 years. And even last year, a study from the British Biobank of more than 48,000 people showed how cardiovascular disease, especially the cardiovascular risk for coronary heart disease and stroke, could be very well predicted by deep AI. And therefore, we now are looking at non-invasive methods of diagnosing cardiovascular disease through retinal imaging, particularly coupled with digital health technologies like telehealth. We can actually take it far and into primary care and ensure that even where other diagnostic modalities are not available, this could be an excellent predictor of cardiovascular risk. And this becomes, and this is now being called RETI-CVD for cardiovascular disease. And of course, while this has been going on for 20 years, the fact that Sundar Pichai announces it in Google makes it real big news. Now, in terms of why this becomes important is because we are seeing a huge number of health transitions in this country. We are seeing a rapid rise in non-communicable diseases, especially diabetes and cardiovascular disease. We have seen, even recently, the India diabetes study that has been published, showing that currently, above the age of 20 years in India, 101 million persons have diabetes and 136 million people have pre-diabetes. That means more than a quarter of the people in India have diabetes. About 11.4% with diabetes and 15.3% with pre-diabetes. That is more than a quarter with dysglycemia. And we also know that of these people, 35.3% had hypertension. And these trends are growing now, and already we have 32% of our deaths from cardiovascular disease. And it is projected that the burden of cardiovascular disease and diabetes is going to grow further with not only demographic transition of aging, but a nutrition transition towards unhealthy diets and increasing urbanization. All of this propelling us into a vortex of more cardiometabolic diseases, especially cardiovascular disease and diabetes and prediabetes. And that is going to have an impact on the way ophthalmology is going to be practiced also, because you're going to be seeing the consequences in terms of the eye involvement, and you're also going to be seeing how ophthalmology can be put to good use, particularly with retinal imaging in early diagnosis, risk prediction, and possibly aiding early interventions. So there is going to be a whole dramatic area that's going to be developing that we will be seeing. At the same time, we are also seeing, apart from aging and other factors, climate change is now becoming an important element. And I've been reading about climate change and the relationship to congenital cataract with global warming. But recently, another study from Canada suggests that severe vision impairment is noted with rising temperatures. And out of curiosity, I looked at what they said was the rising temperatures, the effect of persons over 50 years of age. And they say that even above what would be called, for us, very tolerable temperatures, they would be seeing, in terms of temperatures, about what would be about 10 degrees Fahrenheit, they would be seeing about 14% severe vision impairment, and over what would be over 50 degrees Fahrenheit, and over 60 degrees Fahrenheit, 44% severe vision impairment. And that's nothing when you convert it into centigrade. So essentially what we are going to be really seeing is, with climate change, we are going to be seeing much greater amount of challenge. And they have not clearly indicated what the reasons are, but they say increased exposure to ultraviolet light, degradation of folic acid with increasing temperature, air pollution, and infections could be contributory causes. At the same time, we are seeing a much greater use of digital devices, and that again is going to be an important cause of vision impairment. So we are going to be seeing a lot of transitions that are going to be happen in the area of ophthalmology in terms of practice, and they automatically relate to public health. So when we are really talking about how cardiovascular disease is going to be diagnosed in the future, how diabetes is going to be managed in the future, and what the impact on ophthalmic practice is going to be, what the impact of aging is going to be, what the impact of in climate change is going to be, clearly ophthalmology is not merely going to be confined to hospitals and clinics, but has to enter the public health arena. And there, actually now, we are seeing a much greater emphasis on primary health care. And institutions like LV Prasad have set stellar examples of how care can be taken right to the periphery with their vision centers, and how primary care can be really integrated into full-fledged, competent ophthalmic practice. And therefore, we will see increasingly in the future a greater emphasis in the health and wellness centers and in the other primary healthcare centers, that ophthalmic practice also has to be integrated into primary healthcare. And the current Ayushman Bharat's comprehensive primary healthcare component is indeed trying to focus on increasing those levels of competencies across the board. And therefore, ophthalmology will have to enter widely into health system strengthening, and not only confine itself to tertiary care or secondary care, but become a very strong contributor to universal health coverage at primary care. And that's going to be the future, and I think conferences such as these should look at how that engagement can be fostered. At the same time, I believe it's absolutely important that we not accept the results of what are produced in the West as automatically correct. particularly in issues like artificial intelligence, we know it depends on the context. Now, if the context in which the study has been done and the data sets are very different from the profiles here of the population burden of disease or the nature of presentations, those algorithms automatically cannot be employed here. So the context matters a lot. And therefore, what we call Bayesian analytics of understanding the context of the pretest probability, the test result, and then estimating the post-test probability becomes a very, very important element. And there is no reason why, with the huge caseload that India has, we cannot generate our own large data sets and generate our own algorithms as appropriate, even as we study the utility of the algorithms that are developed elsewhere. Therefore, this requires a considerable involvement of research and the incorporation of research methodology into conferences like this, where research methodology is taught to younger students and young practitioners so that they can actually put that to good use. There is no reason why the huge amount of data that we are gathering from across this country from multiple centers cannot become the source of that kind of analytics, and we should be able to generate our own algorithms as we move along. And for that, institutions such as the Public Health Foundation of India and our Indian Institutes of Public Health will be very happy to provide support as needed. The reason I'm emphasizing this is that it is important as we advance science to remember, as Kathleen Jamieson said, that science is organized skepticism. Scientific temper has to really question whether anything is valid and replicable, and also whether it's transportable to another setting. But again, as Louis Pasteur told his young research fellows, keep your enthusiasm, but let strict verification be its constant companion. And I think that should be the spirit of advancing science through conferences such as these and all analogous teaching events. As Henry VIII said to his second wife, I shall not keep you longer. So I'll express my gratitude to you in 2 sentences. One is mercifully short. The second, unfortunately, is rather long. The first is thank you. The second is thank you very much. Thank you, sir, for an excellent message. Then we'll go for the awards. I request our LOC chairman, Dr. Madhukar Reddy, and our organizing secretary, Dr. Y. Raman, please present the mementos to Dr. G. Badrinarayana, our past president, Dr. Ashish Bansal, then General Secretary, Dr. Rajalingam and Rishi Swaroop, Dr. Ravindra, our past president, advisor, Dr. Nanda Kishore, Treasurer Dr. Ravi Kumar, Joint Secretary of TAS Dr. P. Praveen, Chairman ERC Dr. P. Modini, Editor Publication Dr. Srinivas Prasad, I request our Chairman LOC present mementos to Dr. C.V. Gopal Raju, Dr. Manoj Mathur, and Dr. Santosh Hanavar. Dr. Santosh Hanavar. Next, I request our President, Dr. Badrinarayana, present the mementos to Dr. Madhukar Reddy, Chairman LOC. Huh? Acha, Bharat, sorry. Dr. Bharat Kumar. Request our President Dr. Badrinarayana present mementos to the LOC Dr. Madhukar Reddy, Chairman, and Organizing Secretary Dr. Y. Raman. Dr. Y. Raman. Then Joint Organizing Secretary Dr. Suparna. LOC Treasurer Dr. Alpa. Now we are at the end of the inauguration ceremony. I request our Organizing Secretary, Dr. Raman, please give vote of thanks.
Respected dignitaries on the dais and dear colleagues, at the outset, I would like to thank all the members of the Executive Committee of the TAS for giving us this opportunity to host this 8th annual Telangana State Ophthalmological Conference at Hyderabad under the aegis of HOA. The support rendered by members of the EC, in particular our President Dr. Ashish Bansal and General Secretary Dr. Rajlingam sir, has been very inspiring. I thank all LOC members and members of the HOA for their invaluable efforts and great commitment to the exhibited during the course of organizing this month conference. On behalf of LOC and TAS, I thank today's chief guest, Dr. Srinath Reddy sir, for taking out his valuable time, gracing the occasion for his excellent message to the audience. I thank my fellow TAS members and today's guest of honors, Dr. Sanjay, Dr. Santosh, for their presence and their valuable messages. We all know Dr. Sanjay and Santosh have been our strength since inception of TAS. We all know without participation of the delegates and support from trade and liberal contributions from sponsors, it is not possible to organize any conference. This time, their participation has been the highest ever so far. I thank all of them from the bottom of my heart for their participation. I thank the orators, faculty, guest speakers, and our postgraduates for their invaluable contributions. I congratulate our Chairman, Scientific Committee, Dr. Rishi, and his team for making all this possible. I am immensely thankful to Dr. Suparna, my Joint Organizing Secretary. So she has been all the strength for me, in fact, and I think everybody should learn from her. The accounting and then the documentation, extraordinary capabilities. Okay. And I am immensely thankful to all other my LOS members. Okay, everybody, because lack of time, I am cutting short. And I am very much thankful to Dr. Rajalingam sir, our hospital superintendent and my colleague professor, and the General Secretary of the TOS for inspiring me to take this job and encouraging me from time to time. And I am also very thankful to Dr. Praveen, who was helping me all the time, and also Dr. Ravindra sir. So he was guiding me. And I express my special gratitude to Dr. Madhukar sir. Madhukar sir has been always a disciplinarian and a kind advices he was giving all the time. And I am also very thankful to Dr. Nandakishwar sir and Manoj Mathur sir for guiding me in this endeavor. And I thank every one of you, all the delegates, for attending this Mammoth conference. I hope you will enjoy tomorrow, today also and tomorrow also. Hope we'll have better, bigger conferences in future. Thank you, one and all.
Thank you. Now, national anthem. Please stand up. Babu, easy. Ki Jai. I request all the awardees, please come over the dais. We'll take a group photo. All awardees, please come over the dais. Sir, all awardees, please come over the dais. Dr. Gopal Raju, please come out the dais. Sir, we'll take. Dr. Manoj Mathur, other awardees. Lunch. ఇక్కడ అయిపోయింది. Please join for the lunch. Please.
Check, hey. Hey. Check. Check, 1, 2. Check, hey. Okay.
Especially Dr. Mallika. Come. Mallika, please come onto the stage. Is Rashmin around? Okay. Rishi, Gopal Raju. Yeah, I think most of us are still in lunch. So anyway, we'll start the program. Yeah. Yeah.
So, yeah, good afternoon, everybody. At the outset, I'd like to thank Madhukar sir and Nitish for inviting me for this session. I'd start off with my case. A 65-year-old gentleman with a recent history of cataract surgery in the right eye presented to us with pain and reduced vision of hand movements. This was also associated with episodes of vomiting. On examination, we found ciliary congestion, corneal edema, a uniformly shallow AC. It's almost like the iris was adherent to the cornea, raised intraocular pressure, and the fundus was very, very hazily seen. The patient was diagnosed elsewhere to have a pupillary block glaucoma and referred to us for a YAG PI. So at this point in time, the differential diagnosis for shallow AC with raised IOP in a postoperative case can be either pupillary block glaucoma, suprachoroidal hemorrhage, or an aqueous misdirection syndrome. So on B scan, the patient showed some clump echoes on vitreous. However, the retina was well attached with no evidence of choroidal detachment. So suprachoroidal hemorrhage was ruled out. And also, this could not be a pupillary block glaucoma because the patient in our case had a uniformly shallow AC. But as you can see in this representative picture, in pupillary block glaucoma, what we see is iris bombay, wherein the peripherals are very shallow, but at least there is a certain amount of depth in the central part of the, at least around the pupil. So a diagnosis of aqueous misdirection syndrome was made, and the patient was initially managed medically with IV mannitol, oral acetazolamide, eye drops of combination brimonidine and timolol, hometropin eye drops, and prednisolone acetate eye drops to counter the inflammation. However, there was no clinical improvement for the next couple of days, and we could not do YAG PI because the AC was very shallow and there was corneal edema. YAG hyalotomy could also not be done because there was fibrin in the pupillary plane. So we went ahead and decided to operate the case. So as we start here, we see that there is corneal edema with a shallow AC. And after placing 3 ports, we did a anterior vitrectomy, as we say, behind the intraocular lens. But however, despite doing this anterior vitrectomy, the AC did not deepen. And at this point in time, what we did was we tried to, I made an AC entry and tried to form the AC with a viscoelastic substance. And then using the cutter, I performed what is known as IZHV or iridozonulohyalurovitrectomy. The logic here being that we are creating a unicameral space, direct communication between the anterior and posterior chamber to promote the free flow of fluid so that there are no pockets of fluid which are preventing the AC from deepening. So after that, we see that the AC is well formed, and in this retroillumination just before vitrectomy, you can see that the iridotomy was also adequately good enough. And then I proceeded with the pars plana vitrectomy to remove some of the exudative membranes which were caused because of the prolonged inflammation. So at the end, we see that the corneal edema is reduced substantially. The AC is reasonably well formed. And in the subsequent follow-ups, the patient at the end of 3 months ended up with a visual acuity of 6/12. So what I learned from this particular case is that we need to identify these kind of cases early. The differentiation between various diagnoses must be done very quickly. And in early stages, we can do a medical management with or without a YAG iridotomy or a hyalodotomy when the media is very clear. And if this is not possible, we need to intervene surgically at an early stage in order to prevent permanent damage either because of inflammation or raised intraocular pressure. And also that whenever we encounter such cases, we need to do a prophylactic preoperative iridotomy in the fellow eye because they are also at a higher risk for developing something similar. Thank you.
Good. That's a common case what we all see. And what was the initial diagnosis you made?
Sir, it was sent to us as a pupillary block glaucoma, but after whatever the ultrasound and the way the AC was behaving, we felt that it was aqueous misdirection syndrome or a malignant glaucoma.
Okay. They were synechia all around the pupil? When the pupil was not dilating?
The pupil was not dilating because of the inflammation and the inflammatory fibrin which was there, which was preventing it from dilating.
Okay. Initially, did you try to do a hyalodectomy initially?
But by the time it came to us, the fibrin was very well entrenched and it did not allow us to have a good view of the the anterior hyaloid. Yes, madam. That also could be a diagnosis possible. Angle closure in the sense pupillary block glaucoma. Because here the AC was uniformly shallow, ma'am. In pupillary block glaucoma, what we see is a iris Bombay kind of picture, wherein the peripherals are very, very shallow, but at least in the central you have some space or gap between the cornea and the iris. There was no gap uniformly. Yes.
I think classically it did look like an aqueous misdirection when you started presenting the case, but the fact that there was so much of inflammation, clumpy cause, did you send the vitreous sample for any?
Yes, ma'am, we did, but there was nothing in it.
Because
I mean,
usually-
probably except for a few inflammatory cells.
Yeah, because usually aqueous misdirection, you don't see so much of inflammation.
Actually, what had happened was this patient was managed by the doctor who had operated for almost 4 or 5 days medically, and then they sent to us. So there was quite some delay between the presentation and this thing. In fact, the patient in the first 2 or 3 days had reasonably good vision, and then the deterioration had started. So then the doctor was probably thinking that we can salvage it here itself medically. So there was a delay in sending it to us. Yes, ma'am.
Was the vitreous sent for culture?
Yes, sir, it was sent, and fortunately or whatever, there was no growth, at least the bacterial or culture growth. Yeah, there were a few inflammatory cells seen.
Good afternoon, everyone. I would like to thank Dr. Madhukar Reddy and Dr. Nitesh Narayan for this opportunity. Okay. It's not going in the play mode. Still not. No, it's not nothing to do there. It has internal only. So basically, I think as an introduction, I'd like to say that this case highlights the fact that we should take a patient's complaints little seriously. Sometimes when patient says something but we don't find the cause on examination, we just assume that the patient is probably not correct and we just reassure them. And we paid for that heavily. And if we don't understand if you're not able to understand why the symptoms, we should look again into the history, again into all the medication that they're taking. So many times we find that there are medication which are newer and nobody knows those adverse effects. Even the prescribing physician who would have written those medicines do not know those side effects. Ophthalmologists do not know because they are newer medication. So there's no harm in researching them. At the same time, just go onto the internet and search while the patient is there. Search each medicine that you don't know. And I've repeatedly found medicines which are causing the exact problem for which I did not have an explanation. Now here this is a patient who actually lost most of his vision because of a drug. Okay, no problem, we'll just manage it. So this is a 58-year-old gentleman who was a hypertensive, and he came with both eyes vision drop. Both eyes had retinal vein occlusions. He was a hypertensive for 10 years. And because of the hypertension, he had renal failure, which was scheduled for renal and liver transplant. I think the liver transplant was because he had HBV infection. So on examination, this was the vision, right eye 636, left eye 5/60. The right eye had vitreous hemorrhage, which was old and new, but there was no retinal detachment. And the left eye had a central retinal vein occlusion, for which he had been injected ranibizumab already a day prior to coming to us. So the right eye was taken up for vitrectomy because it was an old vitreous hemorrhage, and we saw multiple branch retinal vein occlusions because he was a hypertensive. And vitrectomy was done, endolaser was done, there was neovascularization on the disc. The same day as we finished this surgery, the left eye went into ischemic conversion, though he had received a ranibizumab the same day. So we injected aflibercept the next day. And we also followed it up with laser and cryo so that this becomes a painless eye. It does not go into neovascular glaucoma. So now he was one-eyed, and he was happy with this eye. 1 month post-operatively when he came to us, he was asymptomatic. And he had now undergone, by this time he had undergone a renal and liver transplant. And he was quite happy with his vision in the right eye, and the NVD had regressed. 8 months post-operatively, he came saying that the vision was dim at certain times, but we did not find anything. The disc was healthy, macula was good. So we reassured him, though he was very sure there was a deterioration in the vision. So then he came again 4 months later, which is 1 month post his liver transplant. And again, by this time, he was really handicapped. Though vision was 6/9, he was hardly able to look around. He could not recognize people. He was practically blind. IOP was high, but it was not glaucoma. The glaucoma specialist saw him and started some drops, but it was not a glaucoma case as such. So this was his picture on that day. You see the disc is relatively healthy, macula is good on OCT, but the field is very bad. So we thought it might be an intracranial cause, but the MRI brain was normal. We thought it might be macular ischemia, which was ruled out. Disc ischemia was also ruled out on angiogram. So now we thought of looking at his drugs, and these were the 2 drugs which can cause ocular toxicity. These he was on for his multiple infections, renal and liver infections. The linezolid had already stopped a week back, and it can cause optic neuropathy. So the only one which was offending drug was entecavir, which is known to cause diffuse retinal degeneration. It was not an optic neuropathy from linezolid because the disc was healthy, vision was good, color vision was good. ERG was advised, which the patient could not do. He again came a month later, and by this time he had lost some of his thickness, macular thickness on OCT, if you compare the one on top with the one on bottom, and field was very bad. So basically entecavir is very important for preventing reactivation of hepatitis B. However, there are reports, only 2 reports of retinal degeneration. So the mechanism is not known. So we should be aware of this toxicity of entecavir, and when patients start complaining of vision drop, we should take it seriously and try to change the drug. because it is reversible in the early stages. Thank you.
Yeah, that's a wake-up call for all of us, because many a time the patient does not show also. Recently, last week, I got a patient who reluctantly was telling that he was on ethambutol, but his vision was deteriorating because they don't want to say that they have TB or whatever it is. It's both sides. But actively, we should ask for drugs.
Yeah, we should take care of all the documents and search each of those drugs which we don't know.
How do you, what kind of investigation would you advise on this patient? Like when I saw when he came, recent visit, his vision was 6/9, the other vision was normal, but he was still complaining of blurred vision. So what kind of test would you advise on this?
Well, OCT for any unknown macular pathology which may be missing, but with macular pathology, vision would not be 6/9. However, OCT is the first thing, non-invasive. OCT angiogram, which is a non-invasive vascular profile, it gives you any ischemia of optic nerve or macula. And then you can go to perimetry, which will give you the fields. And if the fields are suspicious of possibly intracranial problem, then a MRI brain, if the field is bad. That's all I would say.
Thank you, Doctor.
Thank you.
I now invite Dr. Abhilasha for her case presentation.
Thank you, Dr. Nitesh, and thank you, Dr. Madhukar Reddy and the scientific committee of Toscon for giving me this kind opportunity to present my case. So, my case is of an 11-year-old boy who presented to me on 6th October 21 with decreased vision for 4 months. He had history of fever for just 1 day, 15 days prior to getting the decreased vision. Systemic history, he had history of alopecia and he was on homeopathic treatment. Best corrected was 6/6 in the right eye, counting fingers ½ meter in the left eye. Intraocular pressures were normal. He was on prednisolone, homide and dorzox T eye drops. The anterior segment was unremarkable in the right eye. Left eye had pigments on the back of cornea, 2+ cells, flare, dilated pupil and lens was clear. And this was the picture in the right eye, and this is the left eye fundus picture, where we could hardly make out anything except there was a whitish deposition there. So the treatment history, this patient was being treated somewhere else. He presented with history of pain, redness, decreased vision for 2 days. At that point, in June 21, that is 4 months before he presented to us, his best corrected was count fingers, and his diagnosis was acute anterior uveitis with hypopyon, and he was started on pred drops and homide drops. His investigations were all normal except for a raised ESR. On 5th July, he was given intravitreal Avastin. Then his best corrected improved to 636. Then in August, again it dropped to 660. And in September, his vision dropped to hand movements and intraocular pressure was 32. At this point, the diagnosis was panuveitis with pupillary block glaucoma and left eye YAG PI was done. So this is all from the other doctor's notes that I copied. And then on September 30th, he was given intravitreal triamcinolone injection. After 5 days, he had presented to us. So in our hospital, we had advised toxoplasma, IgG, IgM. All the tests were normal except for BZB. BZB IgG was raised and IgM was equivocal. This patient did not have any history of chickenpox. So now my differential diagnosis is that this is definitely a case of infectious uveitis because patient has already received intravitreal steroid and he has dense vitritis. So here I was thinking in terms of acute retinal necrosis. It's a young boy, no response to steroids, high IOP, and BZB IgM titers were also raised in the absence of history of chickenpox. So I started him on IV acyclovir, 15 milligram per kg for 7 days. After 5 days when I reviewed, there was no improvement. This is the B scan, and patient had trace hypopyon still. Now we decided to do a diagnostic and therapeutic vitrectomy for microbiology, cytology, and AC-TAB for PCR. So this vitrectomy was done by Dr. Rajaram sir, and Here you see inferiorly there are some healing retinitis lesions which were lasered. So the microbiology came positive for gram-negative bacilli, and the culture showed Pseudomonas sutseri. It was post-injection end-off. Cytology was non-contributory. PCR was positive for VZV from the anterior chamber. So post-operatively, we continued the acyclovir. So this is 3 weeks post-op. Patient has a little bit of cataract, and you can see the laser marks here, and the fovea looks good. There is extensive atrophy of the iris. So the final diagnosis was VZV panuveitis with ARN, and also coexisting post-intravitreal injection Pseudomonas sutseri endophthalmitis. So the differential diagnosis of pediatric uveitis with hypopyon, we should keep JIA in mind. We should keep infectious uveitis, Behçet's, mascarades, and endogenous end-off. It is a very common cause of uveitis in children. So VZV uveitis generally presents with an acute hypertensive uveitis. Vitritis is very common. It is more common with than HSV. VZV invades the root of the iris epithelium and causes segmented iris atrophy. And Pseudomonas tutseri is a gram-negative bacteria with a very low degree of virulence, and it is commonly found in the hospital environment. And predisposing factors are previous surgery. And this is 2 years down the line. Just this month, patient came and he is very stable. So empirical treatment, especially intravitreal injections, are best avoided in the absence of an etiological diagnosis. And acute retinal necrosis should be kept in mind when you're only seeing vitritis. It's better to examine the periphery and look for lesions. Thank you. And I'll be happy to take questions.
Yeah, that's an interesting story. Malika, please comment.
Yeah, I mean, it's surprising that somebody should give an intravitreal injection for uveitis. There was no CNVM or, so there was no diagnosis basically.
Yes.
Yeah, that complicated the picture quite a lot. Otherwise, it should have been straightforward if somebody was seeing the retinitis.
Yes, initially.
Started acyclovir.
Yes. So the initial diagnosis, ma'am, from the notes I saw, it was anterior uveitis. So probably the retinitis was there in the beginning, but it was masked. And the good thing about these viruses are that they are not very virulent. So yes.
Actually, this is a very important point that acute retinal necrosis is often masked by the anterior features.
Yes.
So even experienced uveitis specialists can get misguided. It can present as very severe scleritis, so that everybody is focused on the anterior scleritis and pain. And the entire picture on the backside can be missed.
Yes.
And if there is a lot of exudation, severe iritis, we may not be able to see also. Severe vitritis may also not allow you to see. So diagnosis may sometimes come very late, even to an experienced uveitis person.
Yes,
so yes, the index of suspicion for ARN has to be high, even if anterior uveitis is severe, scleritis is severe. That has to be on the list of your suspicion.
Yes.
And if you just treat with steroid alone, then there is a risk of worsening the disease. So definitely suspicion is, if it is high, then only you would think of antiviral like acyclovir. And as you said, they respond very well. All of them respond very well to proper antiviral therapy. It's not a resistant kind of disease.
Thank you, ma'am.
Thank you.
For more discussion on uveitis, please join us in Hall B at 4 o'clock. We have a uveitis for everyone session there. Thank you.
Thank you, Dr. Abhinasha. Now I will invite Dr. Samashila.
One point, Abhinasha, is that instead of giving intravitreal Avastin, if they had given intravitreal ganciclovir, that would have been at least more useful. In these patients, when they are very severe, we can actually inject intravitreal antivirals to supplement the systemic.
When we don't have any clue, sometimes, as you said, vitritis is very dense, anterior segment features are there. We can just give topical steroids and do a vitreous tap or an AC tap and send for PCR instead of doing like trial and error and wasting time.
Or even if you give oral steroids to clear the vitreous, it can be low dose and under close monitoring, so that as soon as the vitreous clears, you can pick up the clinical signs. PCR and all are not always positive.
Possible, yes.
Thank you, Nitesh. Can I start? So when Nitesh invited me, I said that I'll have one of my fellow or somebody present this case.
I
And
think Somchala,
yeah.
Subhadra has a comment.
Sure,
Subhadra,
sorry.
please come.
Yeah.
Audiovisual help,
Hello.
please.
Hello, hello, hello. I was just wondering why somebody get Avastin. So then I was thinking that maybe they have noticed some vessels on the iris because these patients, they can present with ischemic vasculitis and there can be iris vessels enlargement and engorgement at that time when the iris necrosis is happening. So
Right.
maybe somebody thought this is a neovascular glaucoma and they were giving that anti-VEGF for NVI. So that's a possibility because I have seen people even in end of, they think it is a neovascular glaucoma and they inject.
Thank you.
So my
Somchala.
story, Nitesh, is that I was trying to avoid presenting one more presentation, but my fellow couldn't make it, so I'm presenting. This is actually my case. So, so this is about in the refractive session. Now we are changing hats from uveitis to refractive. By the time the patient came to us, he's 37 years old, and he was from Visakhapatnam. So he had consulted our center there, and then he also came to the Hyderabad center a year later. And his chief complaints was that he had, his vision was very unclear and he was not seeing very well. So he had undergone LASIK in 2004, and after that he did extremely well. He was very happy with his vision until about 2016, and after which he developed these recurrent episodes of redness, pain, and photophobia. There was no similar family history. And though he didn't remember what his refraction was, it was moderate myopia, and he had a good result. When he came to us, he had this compound myopic astigmatism in the right eye, and the left eye showed mainly hyperopic shift, with which his vision was fairly okay at about 6.9 or 6.12 in both the eyes. So what we could see is in both the eyes, I don't know how clear it is. Yeah, you can see it actually. So this multiple cobweb-like reticulate appearance, which is actually at the level of both inside the flap as well as at the interface in both the eyes. So this is a sort of a broad slit which is showing you through a little bit of sclerotic scatter illumination that some of these spots look very dense, and then you have these areas which do not look as dense. And so you have multiple lattice-like looking lines or cobweb-looking pattern over here, mosaic pattern over here. When you look at the OCT, that is very revealing. So you see nice epithelium, that component looks good, but at the level of the anterior part of the flap, as well as the posterior part of the flap, you see that there is this high reflective tissue, that is, the substance is here. So literally like as if the LASIK flap is coated both on its anterior and posterior side with this extra additional tissue. And this was similar in the left eye as well. So both the eyes had this extra tissue, and that is reflected in when you do the pachymetry mapping of the cornea. And you can see that the cornea is pretty thick. It's about 600 microns in some areas. Center also is 540. This is for a patient who's undergone surgery. So you know that this is a very thick cornea. And also you can see that epithelial also looks irregular. Maybe it's trying to compensate for the irregularity below. So what is this we're dealing with? So the choices we have are, so you know that the differential diagnosis for when you have something like a very delayed post-operative interface haze could either be just post-operative interface haze, very delayed haze in LASIK, which is very rare, or you could have epithelial ingrowth, which is what we are more familiar with. You also have interface fluid syndrome, which is usually associated with raised intraocular pressure, or maybe it is the last one, which is a corneal dystrophy. So how do you look at each of them? When you have post-LASIK interface haze, that can happen in very rare situations, more common in PRK. You can have mitotically very active stromal keratocytes which proliferate like this, and this is how a haze would look like. This is not the case in our situation. You could have something following DLK or CTK, and you could have a haze ending up like that. But this is not the situation because it is very delayed, so we know that is out. You can have epithelial ingrowth, which looks like this. You can have interface fluid syndrome, in which the OCT would show fluid, or the last one is corneal dystrophy. So we decided to put our money on corneal dystrophy. And what should we do now? So the patient was okay at that point. We decided to go ahead and observe him for that time point. He came back several months later, and at this point, his vision had deteriorated even further, and this is what it shows. And his compound myopic astigmatism had increased, as you can see, so he was very uncomfortable. The haze more or less looked the same on all the maps, but the vision quality was not good. So we decided to do flap excision, and then, well, we didn't decide to do flap excision. We were planning to do PTK, but the flap, it was a forced decision because the flap was very movable. and the entire flap came out. And then on the residual bed, we did PTK, applied it for about 50 microns, and also included MMC. So what histopathology showed for us is on special staining, we could see some reddish deposits, which you'll have to trust me when I show you, that these deposits were Mason trichrome orange-red deposits, which indicates a variant of granular dystrophy, and that's what we had for our patient. So finally, we narrowed it down to corneal dystrophy for this patient. We did it for both the eyes, the PTK with flap excision, and in the end, he was very happy with his quality of vision, and that is because you see that the surface that you have now is smooth. There is very minimal haze, which is still there, but overall the patient was happy with the result. We did ask him to get genetic testing done, but it's very expensive, and we kept looking for cheaper genetic tests which are available, but we couldn't get that done yet. So that's the only thing preventing us from writing up this case. So thank you very much for listening. Right, exactly. So that's why I said lattice-like lines, just to throw red herrings at everyone. But when it recurs, when it happens de novo, or when it starts off in a patient post LASIK, so then the morphological appearance looks very different from what it is.
Yeah, I think the picture was a little different because this was someone who had undergone a refractive surgery,
Right.
and it kind of bordered the flap. And
Right.
But the way in which you came to the logical conclusion that it was not one of the other issues post-refractive surgery, I think, yeah, bilateral.
Right. It is, so that was there in the discussion of my presentation, which is beyond the time for this. So it is known, it has been reported that some of these dystrophies get activated, it's presumed due to the laser energy or stimulation like that. And then when they get activated, they're in that area where the maximum energy was applied, so around the LASIK, around the area of the LASIK flap. And there is also an epithelial cell origin for some of these dystrophies, which help it grow in a particular way and inhibit in another particular way because of the migration.
What was your corneal thickness at the end of the procedure?
It was still in 400, so it was pretty adequate. It was very adequate. If we want, but he asked us, can we correct the residual? We said, I said, I'm not doing that. Thank you.
One question, madam.
Sure.
Madam, once you remove the flap, in this case,
yeah.
How regular was the surface?
How, sorry?
How much regular was the surface? So because all the bumps and opacities...
No, we did PTK on that.
But PTK will remove the uniformly, all the irregularities will still remain there, right?
So, so just like how we do most of the PTK, so we do 50 microns, and then we... and then examine and see if you need more surface smoothing. So it works. It's, as you know, that it works pretty well. Is there any other suggestion you need?
No, it's not like... so once we remove the, LASIK flap, yeah. So underlying surface, it looks, on the OCT, it looks irregular surface.
Yes, that's right. So we mask it with the help of,
okay, so we have done masking to ablate it. Okay, okay, thank you. Thank you.
Can we pick it up before surgery on OCTs, Dr. Shoma? Can we pick it up pre-operatively by doing some ASOCTs or something, epithelial mapping, or does it give any clue?
Probably didn't have it in 2004.
No, I'm just asking you. So can we do such kind of diagnosis before putting them for surgery?
It's a diagnosis by the time it manifests.
No, you said LASIK has triggered his dystrophy. So can we diagnose this before?
Yes, we can do that by testing for the gene.
Gene only.
Which
Oh,
is done
okay.
In some centers overseas, in Korea also. So it depends on what is the genetic predisposition in that population. So in Korea, in fact, they have ready-made kits also. In some centers, they do that routinely. So the gene is very prevalent in that particular subset of TGF-beta. Very prevalent over there.
So if the dystrophy is not manifested pre-refractive surgery, then it's not going to be picked up either clinically or on the OCT.
Good afternoon, one and all. At the outset, I would like to thank TOS, Dr. Madhukar and Dr. Nitesh for including me in this session. So, We've been doing refractive surgeries and phakic IOLs have been the part of this refractive surgery for many years. And the essential measurement for the proper sizing of the phakic IOLs is the measurement of white to white. Either we do with using a digital calipers or some instruments like OB scans. So at times we can go wrong. It can be oversized, resulting in high vault, which in turn gives rise to glaucomas, inflammations. Sometimes you see the dilated in a pupil in a dilated state. That time when in that case we would rotate the lens in vertical direction. And if it is an undersized one, you see the OCT image here, literally kissing the anterior capsule and causing the subcapsular cataracts. Another problem we encounter is the rotational instability if it is undersized. More so when you implant toric IOLs, it will never stay in its axis, original axis. So I have a case, patient had inadequate pachymetry for the kind of myopia she had. So I decided to implant toric phakic IOLs, used the digital calipers to measure the white to white. And same was done. Patient was happy 1 day, 1 week, and 1 month. Then she comes back with a decreased vision in her left eye after 2 months. Then lens was deviated from its axis. So I thought, it's like any other toric IOL we do after cataract surgery. Let me realign it. But still, again, it rotated back. So reviewed all the measurements, white to white. Also sent it her sulcus to sulcus measurement for the UBM, but I don't have my own UBM. Sent it elsewhere, and then decided to stepped up a little bit larger size for the exchange because patient was very unhappy with the visual outcome. So then the same was done, and a vault was checked post-operatively, had a big relief of sight because it's still in the safe zone. Then another case, similar kind of rotations. This time in both the eyes, the lenses were rotated. And here the vault already is very high in this patient. So I did not plan to replace with the another lens. And the common factor in both the cases is the small white to white. So this patient, I advise a laser touch-up. So in my opinion, estimating the sulcus to sulcus by taking the horizontal white to white can be deceptive at times. It is not reliable always. And I have been preferring to implant the spherical phakic IOL whenever I encounter small white to white corneal diameters. And if there is any residual powers, I'm doing the excimer laser correction, waiting for 4 or 5 months or so. That's how I'm counseling my patients. Thank you.
Sri Lakshmi, are there any other cases which you encountered, or this is the first case?
So after these 2 patients, I evaluated all my cases. Out of 470 phakic IOLs, there were 2 of my patients and 1 of my colleagues, in that also 1 eye. That was, these 2 were IPCLs. And there are 2 patients, they underwent ICLs, toric ICLs. They also had the similar thing. And I noticed the white to white in them also, it is around 11.2, something like that.
What's your take-home message?
So I am, so with my limited anecdotal knowledge, so I've decided if you see any small white to white diameter cases, instead of implanting the toric IOL, either you do sulcus to sulcus, which is again repeatability is the problem. If you have your own, probably you train your technician and do it the best way. But then, taking this white to white horizontal diameter and sending them across, getting the lenses and ending up with such kind of stress, best thing is do the spherical, implant the spherical lens, wait for some time. Sometimes, with the incision and all, 0.5, 0.75 cylinder, patients accept, if you counsel them. Otherwise, do the laser touch-up. That's the best way. Usually -1 cylinder, hardly any cylinder. Even 470 micron thickness also you can do the laser touch-up if the patient is unhappy.
Thank you. Thank you. Rishi and Rashmin, please come onto the stage. We are underpopulated here.
Thank you, Dr. Srinivas.
Yeah.
Now I invite Dr. Rishi Swarup.
So I think it looks like everyone agrees with me.
Like the smaller diameters, where you're not sure of your Y2Y diameter and borderline cylinder power like 1.25, you can go ahead and implant a spherical ICL or IPCL, and then the residual power, if the patient is not very happy, you can go ahead and do a laser touch.
Thank you. Thank you, Dr. Nitesh and Dr. Madhukar, for involving me in this important session of the program. So this is a cornea case, a case of a 75-year-old female patient, came with complaints of diminished vision, redness, and watering in both eyes since 2 weeks. She had a history of cataract surgery 2 months ago, when 2 months prior to coming to me in the right eye, and 2 years prior to coming to me in the left eye. She was on Predfor 2-hourly chloramphenicol eye drops 4 times a day by local ophthalmologist, and was complaining of intense burning after installation of eye drops, and the drops were being instilled by her daughter-in-law. This is what the clinical picture looks like. That's the right eye. You can see that epithelial defect, and there's a haze in the epithelium throughout the cornea, and in the left eye there's a larger epithelial defect almost involving the entire cornea. And the patient was highly symptomatic. There was congestion of the adjoining conjunctiva as well. And even the conjunctiva showed an inforonasal epithelial defect in both the eyes. Unfortunately, I don't have a picture of that. You can see it in the left image. You can see the staining on the conjunctiva. So at this point, rest of the findings were okay. The B scan and all is fine. And there was a little bit of iris atrophy, but that could be from long-standing persistent epithelial defect and cause some anti-segment inflammation as well. So the differential diagnosis in my mind was this some sort of a chemical injury, possibly those drops which are being instilled by the daughter-in-law. So it could be a Munchausen syndrome by proxy, or it's some sort of a drug toxicity or some unusual form of a viral keratouveitis or a neurotrophic keratopathy. The corneal sensations were also very vague, plus minus kind of thing. And because there was a conjunctival epithelial defect, maybe there's a component of mucus fishing syndrome along with neurotrophic keratopathy is what were going on in my mind. So I decided if I have to get the actual picture first, I'll stop everything. So we stopped all drops, put the patient on hourly preservative-free lubricants. And day 2, the right eye epithelial defect started contracting, and left eye was almost the same. So we decided to do a temporary tarsigraphy in the left eye to aid the healing. So at day 10, this is what the right eye looks like. You can see a small epithelial defect in the inforonasal part, and the conjunctiva had healed. And the left eye, the tarsigraphy was there, and the conjunctival defect had healed. The cornea still had a PED, and there was pigments on the endothelium as well, which was there earlier also, and diffuse edema. At day 13, I'm sorry, I had also done an amniotic membrane graft, which I have not mentioned here, along with the tarsigraphy. So on day 13, the right eye was the same, and left eye, an amniotic membrane graft was done because it wasn't healing. And the epithelial defect in the right eye was the same, so we added a BCL. So initially we'd done a tarsigraphy, and because it wasn't healing, I also added an amniotic membrane graft. And by day 20, you can see that the right eye epithelium had completely healed, and the left eye amniotic membrane had got integrated, and the epithelial defect had healed, and then the eye here also had started quietening down. And over time, by day 50, the right eye was clearing well, and left eye had this kind of a scar with pannus. So I was continuing the patient on medical management, and by day 75, right eye, the cornea started showing a little bit of faint scarring, which was probably because of the long-standing defect. And left eye somehow again developed an epithelial defect like this. and with a persistent epithelial defect and some conjunctivalization, which was like circumferential around the epithelial defect, as you can see. So we decided to do a repeat AMG with tarsography in the left eye. So that's how the right eye was at the, I'll just take a couple of minutes more. Yeah, we have time, no? Yeah. So this is how it was in the right eye, and left eye you can see the, again the AMG has got integrated, tarsography is in place. And at day 110, I left the tarsography as it is. Right eye is clearing up slowly, and the left eye shows the integrated AMG there and scarring with the tarsography in place. By day 150, the right eye vision was about 250 best, 2 by 50 best corrected, and left eye showed a edematous scarred cornea with a total limbal stem cell deficiency. And you can see the endothelium on the slit is showing some scarring on the endothelium as well. So basically now we have a cornea in the left eye which is not functioning both at the endothelial level, and the surface has got kind of conjunctivalized. So the stroma seems to be reasonably okay. So we need to do something to correct the surface and the endothelium in the left eye. Right eye has reasonable vision. So I decided to go for a slet and a dissect. This has not been reported before actually together. So I wasn't sure if I should do it or do it separately, but I thought if I just do the slet, the epithelium may not stay because the endothelium is not functional. Alternatively, I could have done the endothelial graft first, but then visualization and all that would may not have worked so well. So we decided to take the limbal biopsy from the right eye like we do in slet, and then went ahead and did resection of the pannus, and then did an endothelial graft. You can see there's a retrocorneal membrane kind of thing which has come out, which is very opaque, along with the Descemet's membrane, everything came out, and the stroma seems to be reasonably clear after removing the surface pannus and the endothelium. And then we basically inserted a dissect graft like we usually do. And after the dissect was complete and the air bubble was in place, I put the limbal biopsy which was taken, we divided into small explants of slet, put on the surface, fixed with fibrin glue, and a bandage contact lens was applied like is being shown here over an amniotic membrane layer. So by day 200, this is how the left eye was. You can see that partly the host epithelium is there, and partly is the explant epithelium which has grown out, and then slowly you can see that the clear cornea, the clear central part of the cornea becomes very clear, and over a year this cornea became reasonably clear. I wouldn't say it became crystal clear, but it became reasonably clear and had a healthy ocular surface like is being shown here, and we managed to salvage this left eye also. So what was unique about this case was we combined a dissect with a slet, which to my knowledge has not been reported before this.
Very well managed, Rishi. Indeed unique that a dissect was combined with slet. Just to go back to the original diagnosis, I mean, what exactly do you think was the
I think it was
diagnosis?
Munchausen syndrome by proxy, because of the picture was like a chemical injury.
So were you not worried that this might continue to happen?
Yeah.
even
So I
later?
told them that the drops should not be put by anybody else except one person I designated, which was a husband, I think, or son. Only he will put the drops. Nobody else in the house should be putting the drops. And I told them that only these drops have to be put. Nothing should be added to these drops. So I kind of hinted that nobody else should be. I didn't really say that the daughter-in-law is involved.
So in fact, the second episode of epithelial defect that occurred also, we are not really sure as to, what
My
the
guess
cause
was that the integrated AMG sloughed off, and maybe that's why, I don't know.
Usually it does not present like that unless there is
So maybe
an
you are saying
inciting-
that again somebody had
So
put
we
drops.
don't know
Yeah.
whether there was again a repeat.
Yes, injury, insult, possible. I didn't think about that, but
Actually,
yes.
one of the best ways to figure out if something like this is happening is just take the drops from the patient
And
just
study
the
them, yeah.
pH, no, just the pH strip.
With a litmus.
And
yeah.
you put a drop on it,
Yeah.
and you will know whether you're dealing with a chemical injury. This is something that we have reported earlier, and it's important that you're aware of this condition.
Yeah, actually I wanted to test the drops, but unfortunately the patient was from another city and they didn't bring any drops, and then they were staying in Hyderabad to get managed. So that's what happened.
Yeah. So usually if they have the bottle, all you
Yeah.
need to do is just put
Put
one
on a
drop
litmus.
on the litmus strip, and you'll know what you're...
Right. Yes, that's a good point. So, but you're also convinced that it seems to be a Munchausen
It does seem to
yeah.
be like that. We've had
Yeah.
4 cases like this, and we've reported 3 cases in the IGO, especially for us to be aware, where one was being done by a family member for a property dispute. And the patient
Wow.
was actually labeled as a psychiatric patient, was under psychiatric treatment, where his signature was null and void because of his mental condition. And every time the attendant used to instill the drop, he would yell in pain, which is why they
My
labeled
God.
him as psychiatric. And then once we discontinued all the medications, you can shift them on to ointments, because ointment, it's very difficult
Contaminate,
to
yeah.
contaminate it. In a bottle, it's very easy to
Right.
just discard the contents and fill it with an acid. Usually it's HCl or H2SO4.
Sulfuric acid, yeah.
And it is quite, it's actually a crime.
Yeah.
In fact, we did report to the police, but then because the patient was not from Chennai, I think it goes to the jurisdiction of where they are from.
Okay.
So you just have to warn the patient that they need to be a little careful about who's instilling the drop.
Right.
Thank you, Dr. Rishi. That's an interesting case. I would invite Dr. Hussain.
I thank Dr. Nitesh and Madhukar sir for the opportunity. So, I had a 72-year-old male patient who underwent phacotrab on 5th of September 22 and presented to me after a few months on 2nd of February with a vision of PLPR. Intraocular pressure was surprisingly 18 and had a uniformly shallow AC with a IOL cornea touch. And on B scan, it was a kissing choroids. So, since it was a long-standing case, decided to go for a choroidal drainage, made a radial sclerotomy 5 millimeters from the limbus, and had this enormous quantity of extraocular fluid which was coming out of the sclerotomy. I did 2 sclerotomies, inferotemporal and inferonasal, and after placing an AC maintainer, did an AC wash. There was a fibrin membrane covering the IOL, and on table itself there was a good red glow, and the chamber was well formed. But after 5 days, again patient turned back with a recurrent choroidal detachment with a vision of counting figures close to face. Intraocular pressure was 20 and again had a flat AC. So at this point in time, I didn't know what to do, had a little literature search, and then I got one of the articles from ICAML where he said that punching the sclerotomy site would help to have a continuous drainage. So went back to the same site and used a Kelly's punch. Enlarged it by 0.5 millimeters, and the next day had a well-settled retina. But my only concern was that having an open ostium there would have a risk of sympathetic ophthalmia and endophthalmitis as well. But covered the wound, did a 180 degrees peritomy and covered the wound with a conjunctival Tenon's flap, sutured it to the limbus. So I had a good result at the end of 1 week, had a vision of restoration of vision of 3 meters with intraocular pressure 16, and chamber was well formed.
Was it an overfiltering that left it caused?
No,
okay.
no, the case was not done by me. It was done elsewhere, and patient came to me after 6 months. What I suspect is there was a leaking blip perhaps, and when the patient presented to me, there was like practically iris blocking the ostium. So maybe that was the reason that the pressures were there in the eye. So the only
If the pressure is there, what is the cause of the
no, it was like the IOL lens iris diaphragm had come forward, and perhaps chronic hypertony has resulted in the choroidal detachment. And since they were not properly attended to, it persisted. It persisted.
So afterwards, then you had like a straw-colored fluid
Yeah,
constantly at the
yeah,
area
yeah.
of the-
It was an enormous quantity. I have done only 2 or 3 choroidal drainage till now, but in this case, I had enormous quantity of the fluid coming out.
Like afterwards, when you closed
Yeah.
it also, then was there like a bleb infrequently from that osteo? The continued drainage?
No, it was like there was no practical bleb, but since the conjunctiva was also chemosed, it was difficult to make out whether there was a bleb forming there or not.
Right.
But after the second intervention, it settled. There was no choroidal detachment. And patient is now 3 months under follow-up. Pressures are 16. But vision was only 3 meters. And we could see some, if we are able to see, there are some like decompression retinopathy, few blot hemorrhages I could see on the retina. Sorry, it's gone.
Thank you.
Thanks.
Now I would invite Dr. Arjun.
Good afternoon, everyone. So I will be presenting a case of phacoemulsification in an eye with a large corneal perforation. So this is about a patient, 60-year-old male, a farmer, who came in January 2022 with a large perforation in the cornea. You can see that the left eye cornea got perforated and the iris prolapse was there, and he was treated locally. At presentation, the vision was CF. And as the perforation was quite big, more than 3 millimeters in size, tissue adhesive or AMT could not be performed. And the AC was flat, and there was a grade 1 cataract. So under peripheral anesthesia, the iris was abscessed because it was lying outside for quite a few days. And after abscessing the iris, you can see that the aqueous came out. And the perforation was quite large, around 3 millimeters in size. And with viscoelastic being injected in the anterior chamber, the iris, which was adherent to the cornea, was removed. And the perforation was, the edges of the perforation was trimmed. And luckily, on the same day, I had a DSEC case. The anterior cap of the DSEC lenticule was retained. And as I did not have a 3 millimeter punch, it was hand fashioned and cut into the size which was matching the size of the corneal perforation. And it was sutured with interrupted 10-0 nylon sutures. So around 8 sutures was put, and at the end of the surgery, AC was well formed and there was no leak, and all the knots of the suture were buried. So this is how, at the end of the surgery, the perforation was closed and the AC was filled with a large air bubble. And the posterior lenticule, which was used for another patient of PBK, was also doing well. This is the post-op picture of that patient. And at the end of this particular patient, at 6 months, you can see that the patch graft was well taken up, all the sutures were intact, and there was a grade 3 cataract. And vision was still maintaining at CF. And this, again, after 6 months, this patient underwent phacoemulsification. So the visco was injected, Trifam was injected to stain the anterior capsule, and the AC was formed with viscoelastic. And all the synechiae which was attached to the lens was removed with the iris repositor, and the pupil was not dilating. So in spite of removing all the synechiae, it was not dilating. So iris hooks were put so that there is a good exposure to the cataract. And the rhexis was done with the cystitome. And as a patch graft was temporal in position, I had to take a superior temporal incision, clear corneal incision, and a direct chop was done. And the care during phacoemulsification was all the parameters was lowered so that the patch doesn't open up or there is no leak from the edges of the patch graft. The bottle height was reduced, the fluidic parameters were reduced, and after emulsifying the nucleus, after bimanual cortical aspiration, think there is some disconnection.
Audiovisual help, please.
So a foldable hydrophobic lens was implanted, and this is after 1 week, the visual acuity improved from 612 to 66 parts pinhole, and this was a refractive error at the end of 1 month, and the IOP was within normal limits, and the patch was intact, and the rest of the cornea was clear. And in summary, the anterior cap of any lamellar procedure can be retained. It can be used to close a large perforation, and this especially helps whenever there is a shortage of corneal tissue. And if you're planning for a cataract surgery after such procedures, we have to give sufficient intraocular, sufficient time so that we can perform an intraocular surgery. And phacoemulsification with necessary changes in the parameters by lowering the parameters can be done safely. And in non-dilating pupil, we can use iris hooks or other pupil expansion devices for an adequate exposure. Thank you so much.
That was a well-managed case.
Very well managed, Dr. Arjun. Sorry if I missed it. What was the cause for the corneal perforation? Was it an injury or?
When he came to me, he was already using some drops for elsewhere, but it looked like an infective perforation. But as there was no cornea left or the iris was out, I could not send any sample to the microbiology. But it looked to be an infective perforation.
And you did the cataract surgery was like 10 months after?
6 months after the initial patch graft.
Did you have any issues with your IOL power calculation, considering that you still had your sutures in the patch graft?
Yeah, so I had to take the IOL power from the other eye. So, and the sutures were, I should have removed all the sutures, but I thought because it was a small perforation and it was not in the center periphery. So.
Very well managed.
Yeah.
It was good thinking. Did you think about a Tenon patch graft? That might also have worked for that case.
Yes. So, as I said, the same day I had a DSEC case, so this cap was there. Otherwise, the next option was using a Tenon's patch.
Another interesting thing which I have done for a perforation like this when we were not doing Tenon patch graft is I put air in the Helon in the anterior chamber, and then I put fibrin glue on top to seal the perf, and over that I applied tissue adhesive to seal the surface. And basically you don't want the tissue adhesive to come in contact with the anterior
into the anterior
chamber.
chamber, yes.
And I've done only one patient. It worked very beautifully actually. That fibrin glue formed like a coagulum, and over that I applied the tissue adhesive. And then the eye coagulated down very nicely.
Yeah, Rishi, we can also use glycerin-preserved tissue for years instead of Tenons or something.
But then you should have access to that also.
No, you just put your used tissue, rims, everything into glycerine, and for years, after 3 years, 5 years also, they remain well.
There are some reports of contact lens being cut into the shape of that shape and put a tissue adhesive. So there are numerous ways of.
But then you have to remove that lens.
Yeah, that's a temporary to save.
Drape has been a small bit of the drape has also been used. In these borderline perforations, it's sometimes very difficult to say which side it would go. For very small perforations, all these things will work. Yours was a little not this side, not that side, so but very well managed.
Thank you. Thank you.
Thank you. Dr. Arjun, now I invite Dr. Charuta.
Good afternoon, everyone. At the outset, I'd like to thank Scientific Committee for giving me this opportunity, Dr. Madhukar Reddy and Dr. Nitesh. I'm going to present a case of long-term endothelial cell loss post-collagen cross-linking. So this is a 22-year-old male patient from South India who presented to us in 2016. He gave a history of undergoing cross-linking in the right eye in 2015. He presented with complaints of right eye persistent haziness in vision since the procedure. He also had documented evidence of post-procedure haze. We couldn't contact the surgeon. However, the institute where the surgery was performed was following a strict Dresden protocol. So on examination, his visual acuity was 6/36 in the right eye, and with correction it was improving to 6/6. So he was reluctant for contact lens use, and therefore, since he also had persistent epithelial erosions and a reduced Schirmer score, we prescribed topical PEG, PPG, and other tear substitutes. Over 3 months, his PE is resolved, and after 1 year of observation and non-resolution of symptoms, we performed a simple limbal epithelial transplantation. So this is the image after 1 year, 1 week post-slet and 9 months post-slet. So at 9 months, we could observe that there was a reduction in the scar density. Also, his unaided visual acuity thankfully improved by 2 lines. And there is also a slight decrease in the hyperreflectivity that is seen on the anterior segment OCT. Post-procedure pachymetry as compared to the pre-procedure pachymetry increased from 324 to 386, and there was also no significant difference in the epithelial thickness. But the patient still continued to experience blurring of vision for distance. So we still continued him on glasses and sent him home. In January 2021, we noted that there was some endothelial involvement in the scar. So specular microscopy showed actually poor cell density in the right eye in that area alone, as compared to the left eye. That is, the left eye was 2,370, and the right eye was 1,702. So he was suggested to use Repasodil off-label basis with a formal consent. And subsequently, 4 months after the usage of Repasodil and after his own self-discontinuation for 2 months, the symptoms, he said, were slightly better when he would use Repasodil and would be worse when he didn't. So at that visit, his specular density was slightly improved with 2,029 counts. We tried to repeat the image at almost the same area where we had imaged it previously. So in summary, we have a case post-cross-linking who presented initially in 2016. We observed the scar for a year. Then we performed simple limbal transplantation in 2017, and there was reduced scarring on the anti-segment OCT along with an improved unaided visual acuity. His blurring of vision was still persistent. In 2021, he showed the endothelial involvement and with reduced cell counts. And he was started on Repasodil for 3 months and discontinued for 2 months, after which his density improved slightly to 2,100. So with this, I wanted to focus on the probable causes of intraoperative UV overdose. That could be, there could be calibration errors in the machine itself. There could be incorrect focusing of light wherein it's closer to the cornea than the requisite amount. And there could also be thin corneal stroma wherein the epithelial hypertrophy is actually masking the true thickness. So this is an in-house study which one of the DNB students in our hospital has performed, wherein the short-term changes in endothelial cell density were done. 35 patients were followed up for a period of 3 months, preoperatively 3 months and 6 months. So when we looked at the data closely after seeing this case, we found that 14.29% of the cases at 3 months showed 200 to 400 cell density reduction, and 22% showed at 6 months as well, which means that probably around 8% of the cases had a progressive cell loss. Now, similar cases actually have not been described in literature. On reviewing, we found that Boscott et al. Have eloquently described endothelial cell density loss in normal keratoconus cases. However, we didn't find any cases where it is being described in cases post-cross-linking. So currently, we are studying endothelial cell density in cases that underwent cross-linking 3 to 5 years ago in order to assess possible common factors amongst those with more endothelial cell density loss than others. So we respectfully wish to state our concerns that probably we have pushed the limits of traditional time-tested protocols by LASIK and PRK extra and have extended the indications to normal healthy corneas. So we think that there should be prudence in limiting usage of cross-linking only to an already weakened cornea and not to normal ones. Thank you.
Interesting case, Chavda. I just want to ask you, why did you do a slit? I didn't understand the indication because there was no limbal stem cell deficiency, right?
So we've done in 2017, I have done 7 cases of slit for corneal scars, and all of them have shown a reduction in the scar density. So we believe that it is probably because of the mesenchymal stem cells. And I think Dr. Geeta, she's here, her paper on allogenic stem cell transplant, which they did in acute stage, also showed similar findings of reduction in the stromal opacity. But I'm not sure whether, since we are just following up after that, we have not repeated the cases. We are still following them up on a long-term basis.
I mean, that was a question that I was going to ask too. We have not done SLET for pure scars without limbal stem cell deficiency, but I assume that you probably extrapolated the role of mesenchymal stem
Yes,
cells
ma'am.
in SLET because we do see definitely a reduction of the corneal scar post-SLET over a long period of time. So,
But Dr. Geeta, don't you think
but
that is because the surface is getting healthy also?
the surface is
Not
getting
just- yeah.
healthier, but even after it gets completely healthy, over the next few years, you do have some remodeling that happens and the scar does tend to fade over a period of time, but we have not primarily used SLET just for scars. We have
But
not
do you
done
think this rationale is justified?
I don't know, but I believed when she mentioned that she went ahead with SLET that was probably the reason why she went ahead with it.
So we've published the first case because we have a 5-year follow-up on that. But the remaining cases we are still following up because some of them showed dramatic improvement, some of them were almost the same, and some
So
of them
the
were lost to
SLET
follow-up.
was, you took, I mean, what did you took the
Ipsilateral
limbus from
autologous.
the same,
Yeah, ipsilateral autologous.
and you just placed it
We
after
debrided
debriding
the
the
epithelium
epithelium, you
and
placed
placed
it.
a small, yeah.
So you placed the cells directly on the bare
No, we put
stroma, or you put
fibrin glue
amniotic?
over it. No.
No amniotic.
Fibrin glue and then a bandage lens. The bandage lens was removed 6 weeks later. That's why we waited for a year. And 3 years actually.
It takes time for the corneal haze to come down, and over time the corneal haze does come down most of the year.
So I wanted actually the focus to be on the endothelial cell loss, which was progressive, but I think it's gone in a different direction. Have any of you seen an endothelial cell loss?
I have seen one patient who had bilateral endothelial injury as well as surface injury following bilateral cross-linking, which was done elsewhere. On the same day, the patient came to me with a complete surface burn and endothelium got fried. I don't know what they did.
Was it in the acute stage or?
Yeah, a few weeks, a couple of weeks after the cross-linking, or some sort of toxic reaction to riboflavin, I don't know what it was. But eventually that patient required a endothelial graft for one of the eyes. Surface I was able to manage.
Dr. Namrata Sharma and Dr. Nikhil Gokhale, these are 2 publications which I found, but both of their publications are on acute stage of injury.
Yeah, there's one case report in the first issue of JCOS about focal endothelial burn following cross-linking. And having a burn simultaneously on the anterior and the posterior surface is very unusual. I mean, you can't even blame it on a focusing issue because then you would...
Look, it could be the focusing issue if an assistant is doing it and they're constantly moving it
they
up
keep
and down.
moving it up
That's
and
what I
down,
was
yes.
thinking. And apparently it was accelerated cross-linking, so I don't know if they use some very high
energy
or something like that, I don't know.
Thank you very much.
Any comments from Dr. Fogla and Dr. Praveen who are sitting in the audience? I'd love to hear from you about this case or any of the previous cases while Nitesh is sitting up. Can we have a mic there, please?
Praveen, there's a mic just behind you, if you wish to talk. Okay.
Good evening, everyone. So I have a case of 41-year-old gentleman who came to us with complaint of blurring of vision in both eyes. He had undergone LASIK 6 months back elsewhere, and you can see the best corrected visual acuity was 6/9 parts in both eyes with mixed astigmatism. And on slit lamp, you can see that there is epithelial ingrowth on both eyes. I didn't have a slit lamp picture, so this is the picture of it. So The diagnosis was both eyes epithelial ingrowth post LASIK, and since this was the first sitting for a first exam, we went ahead and did a flap wash. So the technique is very simple. You just lift the flap, but in the areas where you have epithelial ingrowth, it is quite sticky. So it is important that you lift it gently, otherwise you would tear the flap. And then after lifting the flap, it is important that you scrape off the entire epithelium from both the edges, from the inside of the flap and on the corneal stroma as well. So here I'm using a 15 number blade to scrape off the entire epithelium. And then you can see it all comes out like a cheesy material. And then after that, you also apply mitomycin C to prevent any residual epithelial nest. And then you do adequate wash, and afterwards I place the bandage contact lens. So post-op 1 month, the flap was well opposed. Visual acuity had improved to 6/6. But there was an early epithelial ingrowth around 6 o'clock. Since the visual acuity was good, the plan was to just observe. And then at post-op 2 months, you could see that the right eye visual had started to drop, and there was mild progression noted in both the eyes. So we decided to do a YAG laser in this case. So the settings basically, how different they are from your posterior YAG capsulotomy is that the energy is much lower, and you need to have a bit of anterior defocus. So at 7 months follow-up, we had to do right eye a couple of times, and left eye we had to do at least 3 times. So this is how the cornea looked immediately after YAG in the interface. Then subsequent follow-ups, you could see that the right eye had an issue. There was still an area of epithelial ingrowth which kept on progressing, and you can see that it had approached the visual center of the cornea. So this is the summary of the case. Right eye, he had 3 laser sittings. Now the visual acuity is again 6/36, and left eye is still doing good. So what would you do next in this case?
I would attempt once more the epithelial removal. Only thing is, if the YAG has caused a lot of scarring in the interface or damaged the flap, then it might be a little challenging. If it's looking very difficult, it's perfectly okay to sacrifice the flap actually.
So I went ahead and did flap excision, but I had to counsel the patient that he would require some amount of vision correction, but he was very happy that he wanted his vision back now. So counseling him was pretty easy. So I just went ahead and did flap excision in this case. And then in this case also, it is important that you apply mitomycin C post removal of the flap to prevent any haze. And post-op, the patient did have some acceptance of glasses, but he had a good visual outcome of 6/6. Thank you.
Interestingly, you have those atrophic spots
Yes,
on the iris,
yeah.
which goes to show that you have to be careful when you use YAG and never to use it if the epithelial ingrowth is in the central part of the cornea.
Yeah.
You could end up damaging the lens.
Does YAG really help?
Yes, yeah, like in this case, you could see left eye, he required only 1 session of laser treatment, YAG laser, and then he didn't have any visual.
I think it helps you 50%. 50% of the epithelial ingrowth will work, 50% is continuing. So
Now I would like to invite Dr. Anirudh. Yeah.
A very good afternoon to one and all. I am Anirudh Herur. I am a second year resident at LV Prasad. So my case, so my case is a 24-year-old female who presented to the neuro-ophthalmology with sudden painless blurring of vision in the left eye since 2 days. So with this history, my primary differentials were either a retinal pathology or an optic nerve pathology, and I asked the relevant negative history, but she did not have any pain on ocular movements, no headache, no history of trauma or neurological symptoms, and she did not even have a history of fever. So a mother nudged her a little, and then she gave this this history of transient visual obscurations, which she'd been having for the last 1 month, and she had them for about 5 to 10 seconds. So at this point, the possibility of some sort of an ischemic pathology kept running through the back of my mind. The real interesting thing began when we measured her visual acuity. So her distance visual acuity was 20/60, which improved to 20/25 on pinhole. She had a minimal refractive error, just about minus 0.5 in both eyes, simple myopia. Interestingly, her color vision, as evaluated on the Hardy-Rand-Rittler chart, was impaired. And not only that, she also had an RAPD of grade 2 in the left eye. So at this point, not only was there the possibility of the ischemic pathology, but also with the impaired color vision and the RAPD, there was a possibility of optic nerve disease here as well. The second googly was when we saw the fundus. The fundus had these whitish lesions which were present perifoveally, and there were corresponding hypoautofluorescent spots on the retinal autofluorescence. Her HVF explained two things. One, that her visual acuity, which was 20/60, was improving to 20/25 on pinhole. As you can see here, the center is relatively clear. And secondly, the whitish lesions which were present perifoveally have a corresponding defects in the HVF. Her OCT, MGCL, and RNFL were fairly within normal limits. But the third strike was when we saw the OCT. On the OCT, in the inner nuclear layer, you can see these hyper-reflective deposits. And you put this picture up for any quiz and the residents will shout out that this is PAM, or paracentral acute middle maculopathy. And this is a sign of retinal ischemia. So we went ahead with an FFA, and the FFA showed a mild delay in arterial filling. And we could also see these ischemic lesions on the Whitefield octa. But as I explained before, we could not really rule out optic neuritis because not only was she a 24-year-old female, she also had impaired color vision and an RAPD. So we went ahead with an MRI. And an MRI revealed hyperintensity in the perineural sheath. So at this point, we decided to do three things. One, we sent a blood test because it seemed like an atypical optic neuritis. We sent a blood test for NMO and MOG antibodies. We started her on IVMP. And thirdly, we decided to thoroughly investigate her for the cause of the retinal ischemia. 2 days later, lo and behold, she came back with a positive result for her MOG antibodies. So at this point, we had already established that she had MOG optic neuritis. We established that she had some sort of a retinal ischemia as was seen by the PAM lesions. So now we wanted to know what was the cause of this retinal ischemia. Her blood profile was fairly within normal limits apart from a hemoglobin of 10.4. Her prothrombotic profile surprisingly was within normal limits. We also sent for an ACE for ruling out sarcoidosis, and we also asked her for a history of OCP use, which she denied, and her estradiol was within normal limits, as well as her HIV and TPHA. The only thing that was really raised was inflammatory markers in the form of ESR and CRP, but that too was just mildly raised. And because of the history that she gave of transient visual obscurations, we wanted to rule out vaso-occlusive disease. So we did a 2D echo and carotid Doppler, which is fine. And surprise, surprise, her autoimmune disease profile was within normal limits as well. A week later, after her 5th IVMP dose, she came back and her vision had improved to 20/30, and her color vision had improved significantly. Her fundus too showed a better picture, and the PAM lesions had decreased. 1 month after the last IVMP dose, she was back to normal with a vision of 20/20, a normal color vision, a pristine fundus, and although we didn't have the spectralis OCT because it was not working that day, you can see that the PAM lesions have almost disappeared. And the HVF is within normal limits as well. So what was really interesting about this case was that not only was she a patient who had MOG optic neuritis, she also had these PAM lesions which signified retinal ischemia, but there was no cause for retinal ischemia. So we went through a literature review and we came up with a single case of PAM with MOG optic neuritis, and in this what they had hypothesized was that the perineuritis which is caused because of MOG basically creates sort of a compression on the artery which causes the retinal ischemic lesions, but it's really up to debate. Thank you.
Yeah, very nice case, Anirudh. There are a few points. Can you go back to MRI? Yeah, so you can actually see there with the arrow that there is a clear thickening of the optic nerve, the peritonitis, which is a MRI feature of MOG. Did she have COVID or did she have Covishield?
She had vaccination that was done, yes.
I mean,
But that was a
last
couple of
6
years
months?
ago. No, no. Nothing
The
on
reason I said this because that probably would be one way by which you can connect these two. Otherwise, I mean, that looks to me a little more far-fetched because almost every MOG case would have such thick nerves. So you don't see this macular lesion in all the cases. One way you can say that ischemia and inflammation go together would be COVID, where COVID seemed to be associated with MOG-related optic neuritis. And COVID, because of its vaso-occlusive nature, can cause those little bit macular fissures. But otherwise, I mean, I'm not very sure. I've not read that paper that you showed, but that's the only way I can connect. And surely, I mean, predominant pathology was MOG optic neuritis because she had RAPD. If there was absence of RAPD, then it would have said that the optic nerve is fine and there's something else which is going on in retina, and that has caused an optic nerve problem. But because RAPD was there, this was MOG-related optic neuritis, but I'm not very sure about your macular findings and its disappearance.
Exactly. And the other interesting thing was that her vision was improving to 20/25 on pinhole in spite of a MOG optic neuritis, which can be explained because it could be variable.
Well, MOG is not, MOG-mediated optic neuritis is not as virulent as NMO-mediated optic neuritis. It has generally, between the two, better prognosis and lesser effect on the vision.
There was another paper a couple of years back by Deschamps et al. Which showed the association of optic neuritis with AMN type 2, which basically affects the OPL, in OPL and ONL instead of the INL. So in that, they had showed that there were 6 cases which had optic neuritis along with PAM, and 3 out of those 6 had MOG. But again, they don't have a reason for it. It could just be an coincidental finding. But
yeah, and just, I mean, by the way, that when you say that there is a transient visual obscuration which lasts for only a few seconds, then I would not be too worried about a carotid problem because generally those TVOs last for at least for a few minutes or more. The transient visual obscuration which lasts only for a few seconds denotes there is something which is happening at the optic nerve level and not proximal.
thank you.
Nitesh, I think this is the last. Thank you very much. The audience were quiet and cooperative. Thank you.
Any questions, comments from the audience? Any interesting cases you faced which we can talk about here? We have 10 minutes. Any challenging cases? The session is for challenging cases. Thank you. You can have tea and come back at 4 o'clock. We have a very nice refractive symposium here after this, and we'd like all of you to be there. Thank you. Certificates. Dr. Anirudh, please come and take a certificate.
Thank you, panelists and the audience and the presenters.
Can the hall coordinator give the session program, please?
A very good evening to everybody. So, hearty welcome to this refractive surgery symposium this evening, and I thank Rishi and the organizing committee for helping us put a wonderful show. So, without any delay, let's get started so that we'll have a healthy discussion. We have about a couple of hours wherein we have a lot of cases put forward so that we can discuss in detail. So, first we'll get started with transepithelial PRK by Dr. Harikishan. Hello, sir. So, Dr. Harikishan is a very senior refractive surgeon. Please come, sir.
Dr. Harikishan is the leading practitioner in Karimnagar, practice of many years, and he also has a hospital in Hyderabad, and he's been probably the first person to start to own an examination in that area, and he's been doing pioneering refractive surgery in that area for a very long time. And he will be talking to us about smart pulse, non-touch surface ablation.
Next. Okay.
For laser refractive.
Good evening, everybody. And today's my topic is smart pulse non-touch surface ablation is ideal and safe technique in refractive laser treatment. Non-touch smart pulse transepithelial photorefractive keratectomy is PRK. It is the only difference is in PRK we are removing the epithelium by blunt blade manually, and in trans-PRK machine itself it removes the epithelium. But in this technique, this smart pulse technology is included. What is smart pulse technology? I will explain you. Smart pulse is a innovative surface ablation, non-touch technique, no cut, no incisions, no flap, removes refractive error, epithelium, as well as smoothens the cornea in a single step without touching the cornea. The introduction of the SPT. It reducing the stromal roughness. It improves homogeneous smoothness without compromising stability of cornea or long-term outcomes, including aberrations. Here, the three-dimensional Fullerene model is used to give a very accurate ablation profile of the cornea. The Fullerene is actually the Fuller is a American architect who designed a soccer ball with equidistant intersections. So that technique they have used into this smart pulse technology to have a uniform the ablation profile on a curved surface, like a ball. The three-dimensional Fullerene model is used to give a very accurate ablation profile of the cornea. Concept of SPT. Geometric Fullerene structure in a 3D model imitate curved corneal surface. It can be compared to the surface of a soccer ball, what I told now, with equidistant intersections. If you see the soccer ball, so the intersections are very equal to give a uniform surface. It can be compared to it helps to position individual pulses more closely, results in a higher resolution due to use of 3D model, particularly in peripheral treatment area of cornea, curved cornea. See, without smart pulse technology, you can see on left side, the profile ablation is very rough, and right side, if you enlarge this one, it will look like a soccer ball intersections. With the smart pulse technology, ablation profile is described as 3D volume with XYZ coordinates based on the curved corneal surface. Whereas without smart pulse technology, the 3D volume with XYZ coordinates based on a flat or plane cornea. So difference will be there, because when the pulses falls on the curved cornea, where it bends, it loses some energy. But here in Fullerene technology, what they made, the closer pulses, and to compensate the loss of that energy will be restored. And so the correction will be accurate and optimal. The effect of SPT. Scanning electronic microscope images at 1000x magnification display a more homogeneous and smooth surface using SPT. See here, right side it is very smooth, left side it is very rough. Pearls of SPT. It removes epithelium more precisely, more uniformly, easily than manual or alcohol-assisted. Uniformly smoothens the residual surface. Rapid epithelial regeneration due to small area. Faster visual recovery, less pain. Rapid epithelial regeneration due to smaller area. Precise ablation, accurate correction, less stress and tension to the patient and surgeon as well. Absolute merits of SPT. Biggest advantage is no cut, no touch, no flap. Flap thickness, tissue saving will be there. Here, residual cornea bed is stronger than LASIK or lenticular extraction. Surface ablation will not alter corneal biomechanical architecture much here in SPT PRK. Good visual quality is achieved earlier, even in higher myopic eyes. You can avoid unpleasant suction release, suction loss, or unnecessary pressure on the eye. What happened? Okay. SPT compensates differences in tissue ablation center to periphery of curved cornea. Sophisticated software compensates for slight differences in ablative rates of epithelium and stromal tissue. And OCT measured individual eye epithelium removal profile, resulting in precise correction. Whereas in trans-PRK of older emissions like SRIs, Swind SRIs, now it is a Swind MRIs. In SRIs, this standard epithelial thickness removal, like 55 or 60 microns, they put in the mission. So constantly for every patient, it gives the ablation of 60 microns. But here, we will measure the epithelial thickness each eye. Whatever the epithelial thickness, we will feed the mission, and that much of ablation will give this mission. So the results will be very accurate. Whereas if you, what I observed in my 6 years of clinical life with this smart pulse trans-PRK, the highest thickness of epithelium is 70 microns, I noticed. Lowest thickness is 40 microns. If you go to 60, so suppose that patient is having 70 microns. So 10 microns difference will be there. About 0.75 diopters of difference will be there. If it is 40, 20 microns. 20 microns means 1.5 diopters difference will be, correction will be there. So it will not be accurate. Here in smart pulse technology, what they included, we have to feed the each and every eye epithelial thickness to the machine. So that much of ablation only it takes into the consideration. So the results will be optimal and results will be very good. In normal cases, it leaves a higher residual stromal thickness, giving the patient higher safety. Dry eye incidence is minimal because we are not creating the flap by cutting, by using blade or by using femtosecond laser. Smart surface ablation with aspheric and topo-guided profile avoids higher order aberrations and spherical aberrations also. So it gives aspheric ablation profile. Due to that, it will avoid spherical aberrations also. So spherical means this curved cornea, according to the profile is curved one, like that. No flap, flap-related complication. That is biggest advantage. We are not creating any flap here. So the flap-related, all complications of flap-related are avoided. Intraoperative, postoperative, like that. And other mission, flap, to create a flap, we need microkeratome, mechanical microkeratome, or femtosecond laser. It is another mission, cost of mission, and disposables. We are avoiding here. Flap-related complications, what I told, intraoperative is incomplete flap, bisect flap, buttonholing flap, free cap. All these are flap-related complications. In postoperative, ectasia, dry eye, micro and macro wrinkles, and interface infection.
Harkishan, time is up. Cross the time.
Yeah. Just 2 minutes, I will complete. It is very important information to the audience. In normal cases, it leaves a higher residual stromal thickness, giving the patient higher safety. Dry eye incidence is minimal because we are not cutting. Smart surface ablation with aspheric and topo-guided profile avoids higher order aberrations, spherical aberrations, no flap, no flap-related complications. Flap-related no DLK because we are not creating flap. no homogeneous smoothness of residual stromal bed, corneal haze and scarring is minimized due to optimal quality removal of epithelium and smoothening. Interface infections are difficult to treat than surface infections. So we are not creating flap. Interface infection is will not be there and DLK will not be there. In retreatments, topo-guided wavefront surface ablation is better than LASIK. In sports, athletes, police, army, safer than LASIK, and LASIK is not allowed now. No suction, safety to the radial keratotomy, keratoplasty, glaucoma, post-glaucoma, surgery, and retinal pathology cases we can do safely because here we are not using here suction. Useful in cases where a difficult epithelial flap can be expected. When the epithelium covers normal irregularities used to treat haze, scarred corneal tissue, and keratoconus with corneal collagen cross-linking. Economically cost-effective. No microkeratom, no femtosecond laser, including disposables. Collagen and vascular
Hari Kishan, I
abdomen
think we have
does like
exceeded the time very much. I think in the interest of finishing the session on time, I think we should stick to the time.
Yeah,
So that we have more time for discussion.
Well, anyhow, one speaker was not there. First speaker, I am second speaker. Huh? Little
Gives us
time,
more time for discussion.
please allow to me. Collagen and vascular autoimmune disorders like rheumatoid and lupus, uncontrolled diabetes, keloid tendencies, and herpes simplex hepatitis, surface ablation is good because where potential of wound healing is poor in LASIK. High brow, this is anatomical relative merit. High brow, deep-seated eyes, narrow palpebral pressure, small corneas, thin corneas, very steep corneas, very flat corneas. Surface ablation is better where LASIK and femtolaser is difficult to do. Correction range, it is not so important. Conclusion, the innovative smart pulse surface ablation procedure is the gentle, safe, touch-free, non-invasive, rapid visual recovery, less pain, answer to LASIK and lenticular extraction like SMILE. It is suitable for any laser candidate as well as patients with thin corneas, corneal pathologies, complex topographies, and steep and flat corneas, very steep and very flat corneas. Smart surface ablation can also be combined with C3R or CXL in keratoconus cases also. SPT is a combination with corneal wavefront topo-guided aspheric ablation profile gives optimized results. And another mission maintenance is also we are avoiding, like femtosecond laser or mechanical microkeratom and their disposables. Take home message. Fullerene structures provides greater corneal smoothness, wow effect for patients immediate following treatment, rapid recovery of visual acuity, good patient compliance, positive feedback from patients, beneficial for all refractive treatments, easy to insert in your practice. Thank you very much for patient listening, and thank you for the Rishi to giving me this opportunity and all ophthalmic society. Thank you very much.
Thank you, sir. It was a very good talk, very comprehensively covered all the aspects of surface ablation. Even we are using this machine and it's actually very useful to have trans-PRK. At one point I was doing as much as 75% of my lasers were trans-PRK, but now with SMILE we've started doing more of SMILE. But still about 40% is still trans-PRK. It really gives very nice results, very accurate, and because it's single step, I think the epithelial defect also heals faster and patients have lesser pain post-operatively, have that wow effect Excel mentioned. It does, but the wow effect goes away after 3-4 days when the epithelial again it comes back. So you have to tell the patient that, otherwise they will sometimes come.
I just have one comment to make, and I would request the opinion of the stalwart sitting there. What is your opinion regarding Dr. Fogla doing PRK, trans PRK with SPT, whatever it is, for higher errors? I still believe that we are not doing something differently for us to go into the realm of more than -6 diopters to prevent haze. If at all we are doing that, what is it we are doing differently? And the second question which I would like to ask you is, in smaller powers, the company recommends that we use a larger optical zone because of the variable thickness of the cornea. So, are we justified, or are the nomograms so advanced that we can do it straight away without increasing the size of the optical zone? Like very small diopters, they recommend as high as even 8.5 to 9 millimeter optical zone. And then for cylinders also, they recommend a very high optical zone. So these 2 points, I would like your impression on that.
Basically, one way of looking at it is that if you're taking lower dioptric errors, chances of undercorrection are a little high. That's why whenever you enlarge the optical zone, the ablation depth increases. The smaller the optical zone, less the ablation depth. So by enlarging the optical zone, you're ablating more. So it's basically similar to like adding 0.5 to your refractive error when you're feeding it into the laser machine. And also if you're doing like a trans PRK, it's always better to look at the epithelial maps as well, because we put in a standard value of 50. Sometimes you can have epithelium which may be thicker in the center part, maybe 55 or 58. And remember that almost 1 diopter ablation is about 30 microns. So even if you have 10 microns of epithelial variation, you can have the effectivity, especially in low powers, you can have a variation of 0.5 to 0.75. So by enlarging the optical zone, that's the rationale behind where you ablate more in the center, so you can overcome this abnormality because of the epithelial thickness variations. Regarding the large, for PRKs, yes, even in our clinical practice, we try to limit it up to 6, but yes, it can be done up to 8 or 9 diopters as well. Remember that some of the data that we have for PRK are from the older generation laser, especially the broad beam or the scanning slit. Now what we have is a flying spot where and a much smaller spot size, so the surface is much more smoother, and also the impact of the laser on the surface. So by the time the second pulse comes back, there is a cooling effect. So that's why you have a better opportunity of avoiding haze and still getting good results. The only thing that is variability is the percentage of patients achieving 20/20 or better. You may have residual error higher if you go towards the higher refractivity. So that you have to explain.
I'll just give a small correction. They said for the higher cylinders, you don't have to use large optic zone, because the ablation zone as it is will become very large. So I don't think the company recommends for...
No, the company recommended it. I had a talk with them, and they recommend higher zones. They said for smaller powers 7, and maybe for cylinders 8.5 also.
Regarding high power, I think the author of the paper is here. Let me tell you from the horse's mind.
So thanks, Rishi. Like we did look at our data when I was at LV Prasad. We did look at our data when I was at LV Prasad Institute, looking at over the years how the patients with surface ablation of different refractive magnitudes performed. And we did see like even people above close to 10 diopters have been doing very good, very stable. Over a period of 1 year we have follow-ups, but long-term follow-ups we do not have for many patients. But initial results have been very predictable, and a lot of people achieved what we intended to achieve. So that was a good, promising thing. With the use of mitomycin C, with the appropriate timing and dosage, I think the risk of haze is also very minimal. It's very comparable to others, yeah.
What is the percentage of haze you had in the higher refractive errors?
I would say like 4 to 5%, not much, yeah. We were using mitomycin C about 10 seconds per diopter. So if it's 10 diopters, you use 100 seconds type of thing. So that way it has been working very well. We hardly see, clinically, we don't make out haze until they don't use steroids and they come back with haze or something like that. But if you're using the appropriate protocol for steroid usage and tapering, I think they do very well.
Yeah, maybe that's a very important point, that we should use steroids, maybe for a longer period than 3 months.
Yeah, a lot of people
And
take the steroids very fast
yeah,
for
yeah.
surface abrasion.
And then the second point would be that prevention of exposure to ultraviolet rays should be stressed upon, I think. That could be another factor which could be responsible for the haze.
Yeah, most of the lasers perform well, but it's the usage of steroids and mitomycin C is one of the things that everybody should use it appropriately.
With this machine, I corrected up to -9 because every case I use mitomycin. So with mitomycin, definitely 10% overcorrection will be there. If you correct 9, it will come to 10 -10. So after that, I don't advise for LASIK. I advise for ICL. It is very safe. And the haze part, above 5 diopters, I will keep the mitomycin up to 2 minutes regularly. Below 5 diopters, 1 minute, 1.5 minute, like that, half minute, -1, 2, like that. I am using mitomycin. But every case I am using mitomycin. The haze part, scarring, everything is not seen. One case, unfortunately, my assistant forgot to give instead of mitomycin, he has given ringer lactate. I mean, another case, it was good. But high pain, it is -8 or -7. So, one eye is very clear, one eye is very hazy. So, I struggled with that patient for 3 years. Why it is hazy, why it is clear. Only you did, and machine is same, everything is same. So, I thought it might be he forgot to give mitomycin. Or otherwise, is there any corneal variation will be there in a single individual? Two corneas reacts differently. It is any your experience or something is there in literature? Let me know.
With regards to mitomycin, there is just one simple question. This is a simple clinical thought. We want the effect of mitomycin where on the surface. But if you keep it for too long, like for 10 diopters, if you keep it for 100 seconds, you would have mitomycin penetrating much deeper. So for me, if I want to keep it for longer duration, I keep it in, I have like 2 Mercer sponges. I keep the first one for like 30-40 seconds, wash it out, then I reapply for 30-40 seconds and then wash it out. So thereby I ensure that I have mitomycin impact more on the surface rather than keeping it on the surface and allowing the mitomycin to really percolate both into the cornea as well as into the surrounding lesion into the sclera, which you know that in the long run, if you use it for long duration, it may have some
Yeah, so we use a drop. We don't use a sponge. I put a drop and spread it out. I agree with you, there's a possibility of percolation into those deeper layers, but clinically have not noticed.
2 minutes. But I didn't notice any endothelial damage, endothelial haziness. Nothing is there. That much of short time, it will not percolate up to.
If you speak to Parag Mashmuda,
He's the one.
don't use it more than 30 seconds. Doesn't matter what degree of
myopia they have.
They have a separate protocol using it. Just 15 seconds for low and for high.
30 seconds.
In fact, there's one paper in which by mistake the dilution error was there. Instead of 110 dilution they used, is 0.002 instead of 0.2, and in spite of that they didn't get haze. But again, that was the Caucasian eyes which do behave a little differently. I think in the interest of time, we'll move on to the next speaker, who is also the convener of this session. Thank you, Dr. Jagdish, for taking on and moderating this session so well. The topic that Dr. Jagdish will be talking is something very important, LASIK complications. As we all know, Dr. Jagdish Reddy was earlier at M. Prasad Eye Institute, where he was leading the refractive surgery department. now he's in private practice with Christine Eye Hospitals, and he's into refractive cornea and cataract surgery. A brilliant surgeon and a dear friend, and let's see what he has to say.
Thank you, Rishi, and it's a privilege once again to be here. And thanks to Telangana Ophthalmology Society for having me today here. So we had a good discussion with surface ablation. I do agree, like majority of cases we perform surface ablation, but there's a lot of buzz about
Jagdish,
it.
closer to the mic, please.
Yes, sir. So I'm just waiting for the slides to. Yeah. So we do hear a lot of buzz about LASIK, and patients come to us for LASIK and not for PRK. So we do perform LASIK quite often, and then we do encounter some complications in the process. And since it's a procedure that we would like to be very precise with very minimal complications or no complications, we would like to know how to avoid these complications, and also if there's a complication, how do we come over it and restore vision in these patients. So I have a series of cases. We'll go through these in the next few slides. As we know that refractive surgery has evolved over the years, especially the keratorefractive surgery, and we have the procedures being LASIK and the SMILE, most recent ones, and we do have variations in these procedures happening all the time. And today we'll discuss about what we're looking at after LASIK, and the patient's expectations are no less than beyond 2020. So it's very important for us to deliver the expectations of the patients. So there are a very big list of complications, both intraoperatively and postoperatively. They could be as simple as subconjunctival hemorrhage and as severe as causing inability to continue the procedure as well intraoperatively. And then post-operatively, you have a list of complications with minor ones like simple dry eye to very severe infections that can lead to severe visual debilitating complication. So we will go through some of them here, and it's not possible to look at everything. So simple complications like subconjunctival hemorrhage, it may not affect the vision, and though it doesn't look good for the patient to see their eyes on day one, and we keep talking about it and counseling them, but there are situations where the subconjunctival hemorrhage can seep in under the flap. So this flap can have hemorrhage, so under the flap. So this affects the outcome of the surgery. When you want to ablate this can lead to inappropriate ablation when you're ablating if the blood is present in the interface. And if you can see this blood after the procedure is completed, that means subconjunctival hemorrhage can be seeping in under the flap. So where does it happen? It can happen if you have larger flaps where you have bleeding at the periphery. Patients, especially using contact lenses, can have vascularization. They can have bleeders. These bleeders can lead to this thing. And this is from a FS200 femtosecond laser platform, where a small channel is made on the top. There you can see there's a subconjunctival hemorrhage. Though the hemorrhage was not seen intraoperatively and postoperatively, we did see this. It's pretty large. If it's a small in the periphery, we ignore it. But if it is large enough like this, like we cannot leave it like this because it can induce scarring and more irregular interface that can affect the visual acuity. So we went ahead and lifted the flap and did a wash immediately to make sure this was cleared. So this is the hyperreflectivity that you can see on a OCT. So I think this is definitely not desirable. So it's important for you to look at, when you're ending your case, to look at these factors so that the blood doesn't seep into the interface. So this was washed and patient did well post-operatively. So the other complication, it looks simple, but it troubles you later and at that point as well. It's an epithelial defect. It's pretty commonly seen, as high as 14% of them can have. And these are some of the risk factors where someone has an epithelial basement membrane dystrophy or older age group or hyperopes. And if the flap was dry when you're manipulating it, this could lead to this. But it has some other consequences wherein the adherence of the flap can be at risk, or someone can develop DLK. And we do implant or place a bandage contact lens in some of the cases where the epithelial defect is large, so that the patient is not uncomfortable and he doesn't squeeze his eyes so that the flap doesn't dislocate. But we remove the BCL at an early stage, maybe day 1 or day 2 for these patients. So the other complication is a free cap, wherein you have your hinge broken off and the cap is free in the eye, or it is stuck to your microkeratome in case of microkeratome assisted LASIK. And there are a lot of factors. This is more commonly seen with microkeratome assisted LASIK, and these are the risk factors. One of the commonest risk factor is malfunctioning of microkeratome. The other one is you have a deep orbit. These are the two commonly seen things, but even flat corneas can lead to this complication. What exactly happens? Like you would think everything is going on fine here, so you will not notice until you lift your head off and then see this patient suddenly moved, and then you can see here the flap is out of the bed here, and then surgeon is searching for the flap. Okay, it was in the head of the microkeratome, so flap was removed. So it's very important for you to mark asymmetric marks placed on the cornea when you're doing a microkeratome LASIK, so that in such situations you can align your flap appropriately. And once you have, since it's a free flap, you have enough area of ablation, so you complete your ablation and look at the irregularities of the flap in the periphery and align your flap appropriately, and then make sure you place a bandage contact lens so that the flap stays well in position and it doesn't move away. So other complication is a free flap, but in a different format. It's called hinge avulsion. So the microkeratome did its job, everything went on well, and surgeon was pretty okay so far doing a ablation. Ablation was done, and he was trying to keep the flap back, and then you can see the flap detached from the hinge. So I think it's very important for you to understand whenever the epithelium is dry, it becomes more sticky. When the flap is everted and is placed on the drape, so it gets more sticky. And when you're trying to move your flap back, you'll put more pressure on it, and that can lead to avulsion of the flap. It happens more with thinner flaps, like if you're doing a 90 micron or a 100 micron flaps. I think it's very important for you to wet your flap and make sure it's mobile before you reposition it. So this is another complication. We labeled it as a sandwich flap. So this was a patient for hyperopia, and he underwent LASIK elsewhere, and he presented to emergency at LVP with this complication, with the flap in the eye and eye patched. And then he was taken into the OR and he was assessed to look at what was happening. So this is a case of Praveen, and I think Rajesh and Praveen co-managed this case for some time. And here there was a flap, and it was difficult for the surgeon to identify as well what is happening here. It was not a complete flap through and through from cornea to limbus to limbus, and it was a flap where it was a double flap. So I'll show you why this would have happened. So difficulties that the surgeon had faced during the surgery were identifying which is epithelial side, which is stromal side, because the epithelium was off by that time. But the patient came here, and when we took into the OR, so that was difficult, and it was difficult to align. The first judgment that was made was it was a limbus to limbus free flap, so it was checked that way. So it was not fitting there, and there was a gutter in the inferior part of the cornea. So further assessment was done, and after talking to the surgeon to understand what had happened, and then we came to a conclusion, this is what would have happened. It could have been a microkeratome jam. So a flap was done, and then it was microkeratome was jammed at this point, and the surgeon came back with the microkeratome, and then he went back without making any adjustments, and then he went back. So a deeper flap was made, and this time a free cap was done. So it's a free flap which has a bifid. So here you have two hinge, a hinge and two parts of the partial flaps attached to it. This is what has happened, and once we understood, and after identifying this and noticing a gutter in the inferior part, the irregular stroma was an indication in the inferior part that the stroma was deficient there. And on the top, you can see the smoother part is the Bowman's membrane, which was intact. So there, the flap has not been made, and the flap was positioned, and then it had to be sutured, and it was tricky to suture as well in order to make sure there was a proper apposition. And this is OCT post-operatively to look at. You can see the OCT where there are two planes that have been there. And post-operatively, once the sutures were done, and they can see the OCT. Patient did well. He got what his refractive error was pre-operatively, but this was not desirable. So loss of suction is one of the complications, and that can happen both with microkeratome and femtosecond laser as well. So these are the risk factors: narrow palpable aperture, deep set eyes, flat corneas, and inadequate suction pressure is one of the things, and an uncooperative patient where they could move their eyes or the head, that can lead to a loss of suction. So since we've been doing more of femtosecond lasers, so I'll just show a video here. So this is a femtosecond laser, like where the flap has been made. So you can see here the bed has been prepared, and then you can see the movement, and then you can see the fluid seeping in, and then you can see a sudden loss of suction. It's very important for you to keep talking to your patients during the process. So because the bed was made, we took the patient again, marked the center, and then went and did the side cut immediately so that we could lift the flap and finish the procedure. So here patient was docked again, the center was marked and then identified and marked, and then only the side cut was done. So it went on pretty well and the outcome was really good. So it depends on the stage when the suction loss happens. Here we were lucky where the entire bed was prepared and it was only the side cut that was pending, and then side cut was completed, and then flap was lifted comfortably, and then ablation was completed. So the other complications which we commonly see is the opaque bubble layer. So this is because of these bubbles not having space to escape, and nowadays the lasers have been formulated in such a way they create an escape way wherein the bubbles can escape so that it doesn't cause opaque bubble layer. Some of the lasers hardly give, but there are few lasers still give this opaque bubble layer. It's as high as 70% in a few studies. So it has some implications where it would be difficult for you to lift the flap, and this can lead to your flap tears and irregular islands when you're trying to dissect this area. So I think it's very important for you to understand, and this is some of the risk factors that we see. And when you notice these, I think it's very important for you to be prepared for these complications. And flap tear is one of the complications. This can happen during your lift of the flap. I think it's important for you to identify this at an early stage and be sensitive or be a little delicate when you're lifting a flap. So this is one of the patient where flap was being lifted, and then you can see here there's a tear inferiorly. So you'll have to be more delicate here to trying to lift the rest of the flap, and surgeon went on the other side and is trying to lift the entire flap. Now you can see there's a flap that is not being lifted inferiorly. It can happen if the dissection hasn't happened in that area as well. So since the central part of it is pretty clear for ablation, the ablation was completed and then this flap was repositioned. But it's very important for us to understand you have long-term sequelae with these type of complications where patients can develop epithelial ingrowth at any point of time post-operatively. So this is another rare complication, like whenever you have OBLs and whenever you are not able to lift your flap, when you put your pressure to lift this flap, you can end up having such complications. This is a split flap. The surgeon is trying to lift the flap, and then when he's trying to split the flap, there's a split that he notices. And you can see there's a central split in the flap. The flap was lifted, two halves of the flap were lifted, and then ablation was done, and the flaps were repositioned after that. So this is very important to notice. Like whenever you notice a sticky flap, you need to be very careful, very gentle, so that you're not very aggressive in trying to lift the flap and lead to such complications, because it's in the visual axis. This can lead to visual disturbances, and epithelial ingrowth can also be a concern as well. So other complication that is seen is flap striae. So these are some of the risk factors with very thin flaps or very dry flap, or if you have very high refractive errors, that can lead to flap striae. I think it can be identified very much in a retroillumination. So this is one of the patient who has a flap striae, and where we are trying to deal with it because patient's vision was 20/25 and not happy. So we lifted the flap, and then we are trying to remove the epithelium in the periphery, and we tried to use distilled water to swell up the flap and remove all the irregular epithelium on the surface, and trying to iron over the flap. So If you swell up the flap becomes thickened, and usually it stretches out. At times when you see these striae not going, I think the epithelium is more rigid here. You need to remove the epithelium and then use more distilled water and trying to iron out the flap. And there are situations where we even take 2 instruments and stretch the flap like you see here. So the idea is trying to stretch the flap, remove as much as possible. You may not achieve 100% during the process where you do see some amount of irregularities, but post-operatively you will not notice them once you've done this removal of epithelium and ironing. And then we place a bandage contact lens. This patient did pretty well post-operatively. And this is a post-operative picture where the striae have disappeared and visual outcome has improved as well. So this is another complication. This is rarely seen, but this is another complication. It's called DLK, diffuse lamellar keratitis. It is an acute inflammatory process that is seen post-operatively, and it can be very mild to very severe forms. So identifying it early and treating it is very important to avoid a complication. It can be mild and where the visual acuity is not affected because it's in the periphery. It can be severe where the central part of the cornea can be affected and needs intense steroid. And at times it can lead, this DLK can lead to CTK, central toxic keratopathy, or central toxic keratopathy can be an individual entity as well. This is a non-inflammatory entity in the cornea that you see, and this can lead to lysis of the keratocytes. It can lead to thinning of the cornea. It can lead to flattening, and this is this can lead to a long-term recovery process, and the flattening of cornea can lead to certain amount of hyperopia in these patients. So it's very important for us to understand nothing has to be done for this patient. Just observe these patients. Do not lift the flap. Do not give steroids because steroids have no role in these patients. And this is what it was pre-operatively after the surgery, and this is what we see post 1 year, I guess, this follow-up. This patient did pretty well, and where this CTK slowly disappeared. And you can see the eye which had CTK, there's significant amount of flattening compared to the eye which didn't have CTK. And if you look at the ocular scatter index, the quality of vision definitely would be less in these patients. The right eye, you can see the OSI index is pretty high compared to the left eye. So they would have some certain quality of vision issues, but usually visual acuity improves to 20/20 pads or 20/25, they're pretty happy. And more severe complications like infectious keratitis to the flap or interface, I think identifying them at the appropriate time and treating them appropriately with proper scraping or amputation of the flap would help a quicker resolution of these. So Rishi, you have anything else?
I think
we'll wind up? Okay.
So epithelial ingrowth, I think you've shown, right?
No, I've not shown.
So we'll quickly just show
epithelial ingrowth
because that's an important complication.
Yes, yes.
And then I think we'll wind up for the next talk.
Yes, sure. So epithelial ingrowth is one of the complications, though rare. It does happen with all the flap-related complications that happen intraoperatively can lead to epithelial ingrowth, and this is how it would look on OCT. So I'll just share a case. Like there are two common reasons. One is you can have an implantation of epithelial cells during the process of the surgery itself, or there can be a reason like you have your peripheral flap is not well apposed. That can lead to a tract that is formed, and that tract can be a common continuous supply of epithelial cells into the interface where the epithelial cells can keep migrating into the interface. So I'll skip this. This is a surgical procedure where you lift the flap and remove the epithelial cells. I'll show you a more simpler form of treating this epithelial ingrowth. This is a patient who presented to us after a few years after LASIK with a white spot in the eye. This is a milky white spot. So this was an epithelial ingrowth that we noticed. And then when we looked at slit lamp, we could see that it was a complicated LASIK procedure. There was a flap lift as well that was done for the patient post-operatively. Patient doesn't know the reasons. And when we look at the periphery, there's an irregular flap adherence in the periphery. And this is there in all the sides. And you can look at superiorly, you can see irregular scarring that could have been a track for the epithelial cells to migrate into the interface. And then you can see in the inferiorly as well, we can see a track that has been sealed now, but the epithelial cells would have migrated from here as well. So the inappropriate flap apposition could have been the cause for this case. And gradually the white opacity increased, and this is what we noticed on OCT. And then topography, you can see an irregular axial and tangential maps here. And then what do we do for this? We need to remove the epithelial cells because it's encroaching the visual axis slowly. So what we wanted to, because of all the irregularities in the periphery, we didn't want to lift a flap. So we wanted to do a non-invasive method, that is a use of Nd:YAG laser. So we use very minimal amount of Nd:YAG laser to ablate these, to do disruption of the epithelial cells in the interface. So small spots were done in different areas, both in the center, in the periphery. And this is a post-operative course. Like we did 2 sittings, day 0 and day 14. And then you can see day 30, the density of the epithelial ingrowth is decreased. And day 60, you can see day 60, there was a decrease, and then you can see at 2 years, the epithelial ingrowth has reduced significantly, and you do see that there's no recurrence as well because we did not lift the flap and everything has been intact. And over a period of time, you do see the cornea has flattened, the irregularities have gone, the significant amount of keratometrial changes that you've seen, and the amount of astigmatism also has reduced. So this is how we manage in a very non-invasive way for epithelial ingrowth. So I have a few more things to go, but I think in view of time, I'll just stop here and we'll discuss if the time permits.
Thank you. The very nice array of complications. Thank you for sharing. I think more than doing refractive surgery, it's important to know how to identify and fix these complications in the right way, because that's what makes you more confident as a refractive surgeon.
Yes.
Anybody can do refractive surgery. It's very simple. So thank you for sharing.
Thank you, Rishi.
The only point I would like to mention is that the contact lens which you leave in all these complications, I think we need not remove it in a hurry. We need to wait for a longer time. I think most of us tend to remove it on the 2nd or 3rd day. Maybe unless you are absolutely sure that the flap is in place, whatever the complication, I think we should not attempt to remove the bandage contact lens.
Yeah,
that's the only point I wish to make.
Yes, sir. So we do remove it based on the type of complication, how soon or late you want to remove. There are situations where we leave it for a week also, depending on what has happened intraoperatively. Yes, that's a good point.
I think the other point, especially with free cap, because obviously the surgeon, when you get a free cap, get worried. So it's important not to allow the flap to dry too much or to overhydrate it. If you keep it in a bowl of fluid, the flap will swell up, and then when you put it on the eye, you will find that it looks bigger and thicker and it doesn't stay on the surface. If you don't put moisture and let it dry, it becomes smaller, shrinks, then also it doesn't fill, leaving behind a gap. So you should just apply a few drops of fluid and then try to complete the procedure. And once you put the flap, you have to wait sufficient time for the flap to adhere. Because if you are in a hurry and you put the contact lens, what will happen is the flap will stick to the contact lens. And then when the patient blinks and the contact lens moves, the flap usually gets dislodged.
I think that's a very important point. Thank you, sir.
Next we have Dr. Sahitya. She's a gracious refractive surgeon, and she's been doing refractive surgery very well. And then she owns the Best Vision, and she's been practicing refractive surgery for quite some time. And she's a cornea surgeon trained at LVP, and she's at Best Vision. She'll be talking to us about different complications of smile, and we know that there's been a lot of buzz about smile in the recent times, and a lot of us do perform smile, and it's not free of complications like we saw in LASIK. So we do have some complications, and Sahitya will take us. Sahitya will take us through a journey with smile over the years. Over to you, sir.
Good evening, everyone. I thank Dr. Jagdish sir and Dr. Rishi sir and organizing committee for giving me this opportunity to present on Smile in Toscon. My journey with the Smile has started when I was a fellow with Dr. Jagdish sir, where I had assisted making a video on Smile. I learned the technique of Smile with him. So I'll share my technique that's what I learned with Dr. Jagdish sir. So these femtosecond lasers, where the mechanism of this is by photodisruption, where a plasma wave is created by creating a flap. The main inclusion criteria, most of them, the myopia of more than, including 1 to 8 diopters, with astigmatism up to 3 diopters. The mesopic pupil size less than 7 mm. The residual stromal bed should be more than 250 microns. The central corneal thickness should be more than 510 microns. Expected post-procedure keratometry should be between 35 diopters to 47 diopters. The patient should have stable refraction within plus or minus 0.5 diopters for at least 1 year prior to undergoing SMILE. So initially, the posterior surface of the lenticule was cut, followed by the anterior surface, and then the incision cut at 12 o'clock position. So here the cap diameter is always larger than the lenticular diameter. It's always 1 to 1.5 mm larger than the lenticular diameter. The lenticular diameter is around 6 to 7 mm. The incision size at the 12 o'clock position is around 2 to 4 mm. We can choose whichever we want. The lenticular edge thickness is around 15 microns, and the cap diameter, as already I had explained, should be more than the lenticular diameter. The cap thickness can vary from 110 to 130 microns. There are two energy settings in the SMILE. It can be 130 nanojoules with spot spacing of 2.5 to 3 millimeters, and the another energy setting was 160 nanojoules with spot spacing of 4.5 millimeters. Here the laser delivery is through a curved contact cone called contact lens glass, where it is helpful in such a way that the intraocular pressure is not raised much in case of SMILE. A green blinking light serves as a fixation target. We ask the patient to fix the green blinking light. The contact glass is available in 3 sizes, in small, medium, and large. This is the mechanism. This is the technique. Initially, the posterior surface of the lenticule was cut. It is from outer to in. And then the anterior surface of the lenticule is from inner to outer direction. And then the 12 o'clock incision. Then we move the patient to the operating microscope, where we dissect this is the normal technique where we initially separate the anterior surface of the lenticule. And then we move on to the posterior surface of the lenticule. And the edge is also separated fully. After that, with a micro forceps, we remove the lenticule. So moving on to the SMILE procedure complications. So there is high chance of suction loss in case of SMILE, because the SMILE procedure is a longer procedure. It takes 25 to 30 seconds. It's almost 30 seconds. So suction loss is more seen in case of SMILE rather than when compared with the LASIK. So this can be in anxious, uncooperative patients. So we should always explain the patient the procedure, what we are going to do. We should ask the patient to focus on the green blinking light, and we should keep on talking while doing the procedure. The smaller corner diameter and the larger cup diameter, always check with the cap diameter. So this can also lead to suction loss by creating the fluid surrounding the cap. Forceful eyelid squeezing, this also can be due to the anxious patient. And smaller palpebral aperture, loose corneal epithelium. When you instill lot of paracaine before the procedure, that can also will lead to the loose corneal epithelium and suction loss. Excessive reflex tearing and fluid entry through the suction parts also can cause. So we should ask the patient to raise the chin and tilt the head while doing the procedure, so that we should always concentrate on the center of the pupil. Otherwise, there can be a chance of decentered ablation that again leads to the abrasions, corneal abrasions. So, sorry.
Slides have gone, yeah.
Yes. So if you face with the suction loss in the initial less than 10% of the cut, if the posterior lamellar cut was less than 10%, you can always redock and start the procedure. If the lenticule cut was already finished, or if it is more than 10% or 10 to 100%, then better you convert to LASIK or any surface ablative procedures. If you face suction loss in case of lenticular side cut, you can always redock by making the lenticular size little smaller, like 0.2 to 0.5 millimeters. And suction loss at the time of cap cut, always redock and you can redo it. Cap side cut, again you can redock and do it by reducing the cap diameter of 0.2 to 0.4 millimeters. So I wanted to show you one more, the anxious patient, what I had faced. So while docking, you can actually notice the patient was moving a lot. This was like almost third to fourth time I had docked the patient. So while doing the anterior cut, suddenly if you see, he has moved. I wanted to show you. Yeah. During the incision cut, he had pulled back his eye. So if you see this, the incision cut was not made. So it was all superficial. He pulled back his eye. The suction loss happened. So initially I tried making a small incision, which is very difficult because the cut was near the epithelial level, where I cannot insert my instrument. So then I have to use 15 number blade to create the incision. I had removed the epithelium so that epithelial ingrowth doesn't happen. So I had created the incision with 15 number blade, and rest of my surgery went on well. And this is the posterior plane, which I am doing. So this is the anterior part I am separating. So next, coming on to the opaque bubble layer, already Dr. Jagdish sir already explained it can be due to too high or too low laser settings. The main risk factor for OBL are seen in case of thicker corneas and thinner lenticules. So the management will be, it can be, the opaque bubble is usually seen because the gas bubbles cannot escape. They accumulate in one area where the the area is disturbed. The management includes dissection with gentle lamellar movements to release the adhesions. So never try to forcefully remove the adhesions. You can use gentle movements. You can use the tip of the instrument to separate. And the optical energy settings can help to prevent the OBL. Increasing the cap thickness may reduce the risk of OBL in cases of lower correction. The other complication is black spots. This is usually seen when there are any adherence of water droplets or meibomian secretions onto the interface between the suction cone and the cornea. So always try to wet the cornea before doing docking. But if you see any secretions, you can again stop the docking procedure. You can clean the cornea, and you can also use the Meckel sponge to clean the cone, and then again you can redock the patient. So this is a patient with meibomian secretions where you can notice there are many black spots. This is the area where laser is not fired. It's very difficult to dissect in that area. Now the posterior flap is created, posterior area is. So now we are trying to dissect this black spot area where the laser is not delivered. So we are using the tip of the instrument to separate it rather than the shaft of the instrument. So where there is a high chance of cap perforation. If you see once again, I wanted to show you, here while we are trying with the shaft, it's very difficult. So we use the tip of the instrument slowly and we dissected the area. So always use the tip of the instruments in such case scenarios. Sorry. The next complication is cap perforation. It is seen in case of inverted handling of the instrument when facing tissue resistance. Before what I had shown, when you are facing with the tissue resistance, during anterior plane dissection, it may lead to cap perforation. Incisional tear risk is greater when the incision is smaller than the 2 millimeter. Initial stages, always it's better to go with the 4 mm incision, then you can reduce the incision size once you are well versed with. So this is, again, I wanted to show you here, while we are trying using the shaft, the posterior part of the instrument, we cannot dissect the anterior. This is the area where there is a high chance of cap perforation. I wanted to show you this. You can use the tip of the instrument. You can just actually join the air bubbles. It's very easy to dissect rather than using the shaft of the instrument. You can always use Hoskins or McPherson to hold near the limbus. So the technique what I learned was always go to the periphery and then go to the anterior, because the anterior cap is always larger than the posterior cap. So when you go to the periphery and enter the anterior part, you cannot mistakenly, you cannot go to the posterior plane. So here I am going to the periphery and then I am going to the anterior plane and then the posterior. Directly you can go. So you cannot shift the instrument then to other side. Here I am using the tip of the instrument to separate. I am just joining the air bubbles to separate. And the technique for the posterior plane dissection is always dissect till the border. Rather than directly entering to the border, you dissect till the border and then separate the border. Because you may tear the lenticule if you directly separate the border. So there are chances of partially retained lenticular fragments after forceful extraction. Never pull the lenticule. When you are feeling any traction, never pull the lenticule. You should always separate and then only you have to remove the lenticule. A torn lenticule during extraction can rise from situations prone to difficulty during lenticular dissection. So you can use the microforceps. You can use the microforceps to remove the lenticule. At the same time, you are facing any difficulty while you are pulling, you can always tear the lenticule, like you can always, rather than pulling, you can always rotate the lenticule and then remove. Thank you.
Thank you, Sahitya. I think the steps have been elucidated very well. I think it's very important when you're dissecting the posterior lamellae. I think having the adhesions in the periphery is very important. Otherwise, the flap will, lenticule will fall on its own, and it's very difficult to separate again. Yeah.
Yeah, I have one question for the panel and Sahitya. So, in case if there is a suction loss, so after half an hour, once the OBL is quietened down or it becomes clear, can we do a surface ablation?
Depending upon the cap thickness, as we can do surface ablation, how much amount we are going to ablate based on. We should keep the cap thickness in mind.
That's 120
yes,
usually. So
that's it.
Okay,
thanks. Yeah, that can be done. So I think it would be important to wait for some time for these bubbles to settle down, and then let the cornea to become more compact for maybe an hour or so, and then you can look at ablating. If the amount of ablation is going to stay in the cap, then I think it's pretty well, you can go ahead.
Basically, if your iris pupil recognition can happen, you don't even need to wait too long. I don't think the cornea becomes thicker or anything like that. It's just the OBL will prevent your pupil recognition or iris recognition if you have a cylinder. Yeah.
If you have an OBL, the bubbles may stay for longer. Otherwise, they disappear very quickly. Yeah, so we'll move on because of the time constraints. Now we have Dr. Prabhakar. So Dr. Prabhakar is a cornea, cataract and refractive surgeon trained at Shankara Eye Hospital, Coimbatore, and he's now the practicing cataract, cornea and refractive surgeon at Shankara Eye Hospital, Hyderabad. So he will be talking to us on refractive correction in complex situations. Over to you, Dr. Prabhakar.
Yeah, good evening, everyone. This is Dr. Prabhakar from Shankara Eye Hospital, phaco-refractive and cornea surgeon. And I would like to thank Jagdish Reddy sir and Telangana Ophthalmic Society for this opportunity. So I'll be going through 5 cases, refractives, where we did a multimodal approach to get rid of glasses for the patients. So this is a 27-year-old lady who has undergone LASIK, and after 1 year she came back with decreased vision. On topography you can see that there is a post-LASIK ectasia. So ideal regular line of treatment will be C3R, and we have to give glasses. But if you can see here, we have a 100 microns flap which can be used to correct the little bit of power she has. So what we did is, we did on the flap surface ablation with C3R, minus 1.25 and 2.5 cylinder have been corrected. And postoperatively, she still has 40 microns of flap, and we didn't touch the actual stroma which gives the strength to the cornea. So in this way of approach, we are giving more strength to the cornea, and at the same time, we are getting rid of the power she had in post-LASIK ectasia. This is the post-C3R and PRK topography, and we can see the differential map here. And she maintained the same vision, a 6/6 vision, post-operatively also in a long term. And this is the second case, post-DALK. This patient, 30-year-old lady, post-DALK for keratoconus, who ended up with -6 diopters myopia and 4.5 cylinder of astigmatism. This is a topography. And as a regular line of treatment, what we did is we have implanted an ICL. So the main thing when you're planning an ICL in post-keratoplasty cases, the most important thing is to get the right refraction, because on the topography and the subjective, the axis will be different. So you have to at least check twice, and you have to make sure that the patient is not tilting his head or squeezing his eyes behind the trial frame. So once we get the appropriate refraction, we can plan for an ICL. And I'm just showing this video, like the challenges one can face in post-keratoplasty ICL. Main thing is planning of the incisions. The incisions you have to plan towards the limbus. You have to make sure that you're not touching the graft-host junction, and you leave at least a thin rim of clear cornea between the graft-host junction and the incision, so that you'll have clear picture of manipulations. And the second thing is, most of these cases, they have more toricity. More cylinder means more toricity. They'll be bulky, and these lenses, they tend to move towards the side, and there is more chances of tumbling and inverted implantation. So you have to take your own time and see what is happening, and inject the full ICL into the anterior chamber. And so once this is done, the next challenging part is, wherever you are trying to manipulate the haptics to tuck it under the iris, right there will be graft-host junction, which will be obscuring your vision, and there will be a lot of distortions. So these cases take more time to tuck in, so we have to be more patient and tuck in appropriately. And because of obscurity, we never know whether the haptic is above or below the iris, so we have to check twice at least. So once everything is done, you wash the visco, and somehow in these post-keratoplasty cases, you can see the axis has rotated from where we have actually implanted. So in these cases, you have to release the ICL from both the sides, because at one side if you rotate, it will just twist back into its own position. And maybe due to the asymmetry of the AC, the rotation is more in post-keratoplasty cases. So that is one thing you have to keep in mind. And this is another case where post C3R stable KC, patient had -7 and -8 and -7 cylinder, and ICL doesn't come beyond -4, -5. So we planned for a customized refractive implantable lens. So this is a simple technique where you can implant it just like any intraocular lens. The loading and all is easy. And best part about this RIL is that it comes in customization. There is, you just have to implant it at 180 degrees, 0 degrees. There is no need of rotation and all. And it is a very slim lens. And one more thing is, in post-keratoconus C3R patients, we always see the sphincter is atrophied. And whenever there is sphincter atrophy, it's difficult for the haptics to push under the iris. So in this particular lens, it's more rigid, and it is very easy to tuck in the haptics below the iris. And we can see two oval holes at optic and haptic junction, which act as center of flow. It doesn't come with center of flow, but there is no need of PI also. And this is another case, 45-year-old lady, post-LASIK ectasia, for which we did PRK with C3R, just like in first case. But it didn't go well. After 4 months, there has been exaggerated flattening, where she ended up with plus 3.5 diopters, where we can see here. The lower picture is post-LASIK ectasia, and post-C3R, there has been so much flattening. You can see the blue area, which is the flattening, which caused plus 3.5. Since this particular patient was presbyopic age group, so we planned for a hypermetropic ICL with multifocality. So this is an IPCL. It's just like any other regular ICL surgery. And this hypermetropic ICL, that doesn't come with center of flow, so we have to do a surgical peripheral iridotomy with the help of a cutter. And preferably the laser iridectomy has to be avoided because these young patients, it will just accelerate the cataract formation, and surgical PA is much better. You can see the PI being done. So what I wanted to highlight is, since the patient is more than 40 years, anyways we are doing implanting an ICL, you have to just plan for a presbyopic ICL. The patient is happy. She can see both 6/6 and N6. So this is the last case where...
Can I just pause you? What was the outcome of that case? Can you share that? The presbyopic ICL, yeah.
Yeah,
How
she
did
had
the patient...
minus 0.5 diopters.
Okay.
And that was a plus 2.5 add.
What is the reason you took a multifocal one? Because the cornea is irregular, right?
No, sir, but the central part is flat, but it's not irregular. And
Okay.
she was already 45 years old. So that we thought we can give both near vision and distance vision.
So she got a good outcome? She was happy?
Yes.
Even near vision?
Yes.
Okay.
6/6 she got, and she got 10/6 also. So this is hypermetro, for which we did add in keratophakia using femtol laser. So this is a patient who had plus 8 in right eye with 2 cylinder, and left eye plus 6 and with 2 cylinder. This is the topography. And as we know, the ICLs doesn't come up to plus 8, and LASIK is not possible also in these cases. So the options we have is clear lens extraction. As we know, these hypermetropic eyes, they always have chances of refractive surprise, and then there is also UVL effusion. So we thought, why not add a refractive lenticule to the cornea? So this is how we planned. The cylinder part, we used excimer ablation, and the hypermetropic part, we have taken the lenticules from SMILE, which is 105 microns and 100 microns. That is what you get when you correct minus 8 and minus 6. So this is a video showing the surgery. So after femto flap has been made, the 2 diopters of cylinder has been ablated using excimer. And the lenticules that has been procured has been spread onto the pupil equally. The most important part in this is the centration. You have to make sure the center part of the lenticule is in axis with the pupil. Once it is dried, the flap has been deposited back. And this is post-operative readings, where the patient got 612 and 6/6 unaided, and the patient has been happy since then. This is the post-op topography, and these are the slit lamp pictures. We can see little bit of haze, but it's not very significant for the patient also. The take-home message is that we really need not be desperate to get rid of glasses for every patient who walks in, but wherever the signs permits and there is a scope, we can use multiple modalities and we can try. And the important part is you have to counsel the patient properly, you have to tell all the pitfalls, pros and cons, and then you have to take it forward. Thank you.
Yeah. Thank you, Dr. Prabhakar. Lovely cases. So if anybody has any questions, we'll take one or two questions. Okay. No, it was good to see the last case. I think one of the crucial thing is centration there.
Yes, sir.
I think getting an appropriate centration in that open flap, I think it would be difficult. I think marking at several areas and trying to get it to the center is crucial, I guess.
Yes, sir.
The smile lenticules that you use, did you try and match the refraction of the hyperopic?
Yes, sir.
So you had one more patient with approximately the same error in which you have.
Yes, sir. We had to wait. We had to wait for it, sir. One is -8 and one is -6.
Interesting.
And we had to ask.
So you kept the lenticule in medium or something like that?
On the same day.
Same day you had.
So
you planned those patients to be done on the same day.
Yes, yes, yes.
That's a logistical challenge, but nice outcome.
Yeah. Once it is done, they have carried it over to our hospital and we have done it.
And how long do you continue steroids in these patients?
1 month, sir.
1 month. That's
1 month.
Okay, it's 2 months. Okay, thank you so much, Dr. Prabhakar.
Thank you so much.
Yeah, so we'll move on. We have a couple of cases now. I think we have first case, Dr. Arjun will be presenting. So Arjun is a cataract, cornea and refractive surgeon, and he practices at Meenakshi Eye Hospitals. Arjun, over to you.
Yeah. Thank you, sir. Good evening, everyone. So I'll be presenting a very short case. So this is about a management of a trapped foreign body under a LASIK flap. So this is about a 26-year-old female who has underwent LASIK surgery 3 years ago, and she went into a garden. And she had an accidental prick with a lemon tree thorn while gardening. When she presented to me, she said that 4 days back she had an injury with that thorn. So she visited a local ophthalmologist. So as we all know that any corneal foreign body which is stuck onto the cornea, we put Paracaine and we try to remove it on slit lamp. So the local ophthalmologist did the same thing, put Paracaine and tried to remove with a 26 gauge needle. And in the process of removal, that foreign body went inside further. Then the doctor there realized that this patient underwent LASIK and referred the patient to me. So on arrival, the patient was using antibiotic and antifungals. And at the time of presentation, you can see that there is a small infiltrate in the paracentral area of the cornea and faintly visible few black spots which are suggestive of multiple foreign bodies. So it was in fact a single thorn which was broken by a 26 gauge needle into multiple pieces, and around that thorn the infiltrate developed. So this picture is at the time of presentation. So if you see on careful examination, there's a big foreign body is there, and surrounding that there are multiple 3 to 4 sharp foreign bodies, and there is a surrounding infiltrate which is just adjacent to these foreign bodies. Visual acuity was 6/12 and there was no epithelial defect on the surface, and ASOCT was done which shows a LASIK flap which was well attached, and in the interface there is a hyperreflectivity and underlying shadowing was seen. This hyperreflectivity is nothing but the infiltrate. So this patient was taken into the operating room under topical anesthesia. The flap edges were opened carefully with a Sinskey hook, and the flap was lifted with the iris repositor. And you can see on the Merzel sponge there are multiple 3 or 4 foreign bodies which are removed, and the infiltrate was scraped with a 15-number blade, and it was sent to microbiology. The bed and underlying flap surface was thoroughly washed with saline, and the flap was reposited, and the patient was started on antibiotics, intense antibiotics 2 hourly. And meanwhile, the scraped sample was sent to microbiology, the foreign bodies and the infiltrate both, but the microbiology did not yield any organism. So this is at 1 week follow-up. You can see the flap is well opposed, the flap edge is seen, and there is faint scar which is there, suggestive of the area where we have scraped. And ASOCT at 1 week shows that the infiltrate has, the hyperreflectivity has reduced, and the vision also improved by 1 line. So the clinical pulse from this case would be that any corneal foreign body, especially on the LASIK flap, should not be, if it is deep, it should not be tried to, we should not try to remove it on a slit lamp, because there is a chance that we may penetrate and push the foreign body into the interface. If it is a PRK or a normal cornea, it is fine. But if it is a LASIK flap, you have to take it to the operating room, and careful dissection and lifting of the flap is helpful rather than doing it on a slit lamp. So it's a very small case. So any questions or?
You could not be able to remove it with the forceps from the surface?
On the slit lamp, sir?
Yeah, if it's only a track is there, I think lifting the flap and everything would be more traumatizing, rather than if you can
But
just...
when I saw carefully on slit lamp, it was way below the, like not on the surface. It was little bit embedded in.
Yeah, agreed.
So,
Arjun, would there be a risk of epithelial ingrowth in the long run, because it's a buttonhole-like thing right now? So that could be one of the thing, I think.
So any other ways of
sorry?
Any other ways of handling? I just wanted to know.
No, one of the thing may be removing the epithelium around the anterior part of it. Removing the epithelium from the top would be one of the thing, so that allowing it to have a smooth pass, because chances of some debris seeping through that hole they will be there, they'll proliferate later, so that you will start seeing. Otherwise, if that Bowman's membrane is disrupted and the stroma has a hole there, there's always a possibility of these going. So following up little closely and watching for these would be a good thing, I think. So, so that was very well managed.
Yeah, sometimes these foreign bodies, they have the way the orientation is that if you try to approach them from the surface, you tend to push the foreign body deeper instead of trying to grasp it. So yes, what Jagdish pointed out is that the entry point is also a nidus for epithelium to track, so you should not unnecessarily manipulate that. What you did, I think I would have also done the same thing. I would have carefully lifted the flap and then try to access the foreign body, take samples, because you cannot, there is an infiltrate there, and from the surface, if you cannot take a scraping, it's very important that you need to know what you're dealing with, especially if you're dealing with fungus, because you may want to give some steroids, to try and minimize the scarring at that point. But if you have a fungal etiology, then you would not be doing that. So I think that approach, what you did, was perfectly fine. But it's vital not to lose time. If you see a foreign body, then don't wait for it. It's not going to spontaneously go away. So proactively go and lift up the flap and get it out.
Yeah. Had there not been any infiltrate, maybe we could have tried from the surface. But because there was an infiltrate, the best idea was to. Even I thought the same, because we can't scrape from the surface the infiltrate, especially if it's in the interface.
So next we have, Dr. Rishi Swarup. He needs no introduction. He is the superstar of cornea at Swarup Eye Center. So he'll be presenting a challenging refractive case. Rishi, all yours.
Thank you, sir. The real superstar is here. So Jagdish wanted me to present a challenging refractive case. So I've just one case. I think it might be interesting. So this was a 43-year-old female school teacher, progressively decreasing vision both eyes, several years, consulted elsewhere earlier in 2016, was diagnosed with some congenital corneal disease. She had a family history of similar disease in her siblings and niece who underwent eczema PTK with me a few years earlier. And she had undergone a FALC, femtosecond anterior lamellar keratoplasty, in 2016, and told me that the vision was significantly worsened after the procedure and was extremely unhappy with the quality of vision. This was her right eye, 6/24 unaided, and with correction was coming to 6/9 partials, N8. And it had the typical breadcrumb, well-defined opacities in the anterior stroma, which we all know is with clear intervening spaces, which is the classic presentation of a granular corneal dystrophy. These are some other images showing the same thing in the right eye. This is what the left eye looked like. She had unaided vision of 6/36 with a mixed astigmatism, plus 3.25 with 2.5, sorry, hyperopic astigmatism, 3.25 with 2.5 cylinder, and improving only to 6/18 and with add to N/18. So she was not at all happy with this vision, and even the quality of vision was very poor. We did a RGP trial with which she was coming to 6/9, but she was not happy with the lens. So she wanted to have some surgical treatments so that her vision could get better before we did anything else for the right eye. So the graft actually was quite clear. The only problem with the graft was it was overriding on one side. Almost 5 to 6 clock hours of the graft was overriding on the temporal side, and as you can see in the arrows which are pointed out. And she had a few discrete granular deposits in the host bed. Otherwise, the dystrophy per se had been taken care of quite well, and this was the only issue. And this is something which is known with FALC. If you can have sizing issues. If it oversizes a bit, you can get override. And if it's slightly undersized, then you can get a gape through which you can start getting epithelial ingrowth and stuff like that. So FALC, although theoretically it looks very good, these are the challenges in FALC. FALC, of course, stands for femtosecond anterior lamellar keratoplasty. So these are some slit images. You can see the interface is quite clear, but there is override on the one side. OCT images, you can see the granular deposits on the right eye, and the left eye shows you a thick cornea, reasonably thick cornea with few deep deposits. So that's the topography. You can see some amount of irregular astigmatism actually in both eyes, and one would not expect to have such poor vision with this kind of a topography in the left eye. However, I was quite sure that it's the cornea that's causing it. In my clinic, I have a Placido topographer, so I wanted to go back and see in the laser center again with the Scheimpflug tomographer. So this was the diagnosis: granular corneal dystrophy, both eyes, left eye status post FALC with irregular astigmatism. So the management options at this point was, of course, for the right eye, we could do some, for the left eye only, we could do a transepithelial PTK or FALC for the right eye, And for the left eye, one could either go with an RGP contact lens or scleral, which the patient didn't want, or a repeat FALC, remove this and put one more, but patient was very clear that she didn't want the same procedure again. So that left us with only one option, was to try and treat the irregularity of the cornea with the laser. And I explained to the patient that the result may be unpredictable. We'll initially try to focus on the irregular astigmatism, and then we can try and address the refractive error if it's significant at a later stage, and which she was perfectly okay with. So this is what we did. We did she wanted to see better in one eye first, so we did the trans PTK for the right eye for the superficial deposits so that she can become comfortable in this eye first. So we did a trans PTK with mitomycin, and she did well. And in the left eye, subsequently, we did a topography guided trans epithelial PARK with mitomycin application for 1 minute. So you can see in the tomography, the irregular astigmatism is a lot more than it was in my Placido topographer. And this was definitely significant. And this was the topography guided ablation that was planned with the Schwind excimer laser. And it was done as usual, just like any other topo-guided treatment. And those are the parameters there. So it was a transepithelial treatment. So advantage of doing a transepithelial treatment in irregular corneas is, often irregular corneas, the epithelium kind of compensates for many of the irregularities in the stroma, and you may have thicker epithelium at one side and thinner at one side. If you remove that epithelium and ablate, your ablation will become more unpredictable. So it's always good to do a transepithelial ablation, because epithelium is really the best masking agent, and if you remove it and put some other masking agent, it can never be as good. So this is how the patient was a couple of months later. You can see the left eye has become much more regular, and the patient with some correction, mixed astigmatism, was improving to 6/9 N6, and the patient was very happy with this visual quality and was happy to wear glasses, which anyway she was wearing for the right eye. And that's how the OCT was. You had a little bit of recurrence of granular deposits in the interface over some period of time, by about a year's time. But otherwise, the patient did not really find any problem. You can see that left eye has some few deposits in the interface. The topography is fairly regular, and patient was happy. Then another 2 years later, the patient came back, and at this point, the hyperopia in the left eye had increased significantly, and vision had dropped by 1 line. So patient wanted to know, I had initially told her that we can do a second laser later to correct her residual error and if there are any other irregularities. So I said, okay, if you're keen, we can do a little more treatment and enhance this. So we went ahead and did that, and we, again, because there was a little bit of irregularity, we did a topo-guided enhancement again as such. as you can see the planning. And then finally she did very well, and this was her last topography in July 22. Of course, she's come after that, and she's doing even well now also. So she's now come down to just a 0.125 astigmatism and improving to 6/6 parts and N6, and she's actually seeing better than the right eye in the left eye. So she was happy, and the surgeon is also happy. Thank you.
What did you do to her sister?
I just did a PTK. Yeah.
Very, very interesting case.
Thank you,
Shows you the role of doing excimer PTK in granular dystrophies, where even though the spots don't go away entirely, but by smoothing the surface, you still can have a very good correction. An important point in post-keratoplasty eyes, when you try to do a treatment, it has to be a multi-stage treatment. It's impossible to achieve that kind of a refractive outcome in the first stage. So I think that was the right approach of first trying to address the regularizing the surface and then coming back and doing a refractive correction later.
And especially in post-graft eyes, if you see the graft-host junction, you'll see a lot of irregularity. I think you have to ignore that and just focus to the central cornea. An important thing is also to use mitomycin.
What was the optical zone that you used for the post-graft eye? Did you try to use a smaller optical zone because you have a graft-host junction?
Yeah, so luckily this was a fairly large graft, so I think I did about 6 something of that sort. I don't remember now, but it's there in this. And both times I used 1 minute of mitomycin C.
Yeah. Thank you, Rishi, for a wonderful case.
Thank you.
And if there are any questions for any of the speakers, or the panelists, we can take 1 or 2 questions. Okay, so in that case, I will conclude the session, and I thank all the speakers for accepting my invitation and being here. And I also thank the panelists for having a healthy discussion here. Thank you so much.
Thank you. Thank you for finishing perfectly on time, Jagdish. Thank you all.
Rajesh, we both are class fellows.
Future refractive surgery, it goes to surface operation only, or still LASIK kind of smile will exist. Most of the surgeons globally. But that technology was different, sir. No. epileptic, alcohol substance, alcohol